Good morning, everyone. We are live here at Seattle Science Foundation, December 7th, our 9th annual, 9 years. Can you believe it?
Congratulations, Danielle.
Congratulations to you.
Great job to you, Terry Kim, and the entire Seattle Science Foundation staff, and Rada Skuyan, Jens Chapman, Gary runs the lab. Terry Kim, you need to come here and be part of the intro. We know you're eating breakfast.
Yeah, thank you for joining us. We want to thank all our sponsors as well: AlphaTech, AscuLab, BrainLab, Globus, Johnson & Johnson, Medtronic, Stryker, VUS Medical, and all our esteemed faculty. You'll be able to claim some CME credit. And obviously this course is being recorded and will be available on the ssfyoutube.org channel. You know, we've been putting this together for 9 years, and trying to get people to come to Seattle in December is always a challenge. So we thank everybody who showed up today. Appreciate you. We have some virtual attendees, of course. And we also have some virtual faculty. So this is actually more virtual faculty than in-person faculty this year.
Reminds me of COVID.
Reminds me of COVID as well.
Exactly, it is. That's great.
Well, actually, you want to introduce the first speaker, Dr. Lombardi? Since
Did Johnson want to say something? Did you already say something? I was going to get breakfast.
No, I actually did already. And I want to thank you guys in particular, okay? Terry Kim and Danielle Drazen. And Izzy Lieberman is part of our administrative staff for running this course. And we have, this is the core leadership right here. But thank you guys for everything you do in making this thing happen for 9 years. And we've been talking about year 10 already. We have some great ideas, and let's start the program.
All right.
Terry, thank you.
Great. No, thank you. Wanted to thank everyone for coming as well. I know it's everyone has busy holidays coming up. Definitely for me, SSF and this robotics course is always a year to reflect. And I think this year we have a lot of very amazing speakers, interesting speakers, and new technology that we see coming through the pipeline. So that's always exciting to take a look and understand what's coming through. But our first talk to start off will be coming in, we're piping in from New York. Dr. Joseph Lombardi is here with us virtually. Hey, Joe. Can you hear me, Joe?
I can hear you, Terrence.
Great. Joe, is your conference over in New York? Are you still in it?
We're still going, but so I just stepped out.
I think this is the dedication of Dr. Lombardi. He will talk about robotics whenever opportunity he can. And he's a true tour de force when it comes to robotics. He creates, he develops. And more importantly, my experience with him has just been about trying to be safe about things, trying to be critically analyzing the way we're doing things. We've collaborated on a lot. And so I think we're extremely lucky to have Joe kind of talk to us today about leveraging the latest technology in spine surgery. So thanks, Joe, for coming.
Thanks so much, Terrence. I'm going to share my screen. And can you all see that okay?
Looks great.
All right. Well, I'd like to thank the Seattle Science Foundation and the folks over at Cedars for inviting me to speak on the latest and greatest in robotics technology. These are my disclosures. And so I've really had the privilege of having exposure to multiple iterations of robotic systems dating back to 2015 when we got our first Mazor system. And this was the Renaissance. And this was the Coke can that used to mount on the back of the spine, and it would help direct your screw trajectory. And we did some initial studies on this, and it was pretty good. We were able to successfully instrument 90% of the time. But the issue is there was a loss of registration almost 10% of the time, and about a 7% breach rate. So comparable with historic freehand techniques, but not really a game changer. The big advancement came in 2017 with the Mazor X, and this looks a little bit more like the robotic systems you would see today. What we saw was significant improvement overall in accuracy rates, with a 1.2% versus 9.5% breach rate, and much lower abandonment and higher registration rates, 2.3% versus 22.7%. And we did publish quite a bit on the safety and accuracy of this system. The issue, though, is that it was, from a workflow standpoint, a bit clunky. You would drill, you'd place a tube, you then place a wire and then a screw over the wire. And so the big criticism at this point was that it just slowed surgeons down, and it really wasn't an advancement from that standpoint. That was until 2019 when one of the latest iterations came through. And again, this was a leap forward in terms of workflow, particularly with the introduction of the burr. And this is a slide from my partner, Ron Lehman, who showed that with the introduction of the burr to these robotic systems, we were able to place screws much faster, on average under 1 minute per screw. And we did, again, publish on multiple safety and accuracy profiles for this system. And where are we in 2024? Well, the latest is this is a multi-center prospective study of 6 surgeons across 4 centers, and now done 411 cases and almost 3,500 screws, looking at all reported outcomes and complication rates up to 90 days. And overall, the accuracy rate is quite impressive at 99% with a 1% breach rate. When we look at intraoperative complications, there were 17 overall, only 2 coming from the robot. One was a durotomy and the other one was an instrumentation failure, so pull out. When we look at complications in the post-operative time frame, 4.1% intraoperative event, only 0.5% related to the robot, 6.6 post-operative complications, none robotics related. Ultimately, 1.5% went on to revision surgery, again, none related to the robot. So really impressive where we've come in just 10 years in terms of robotics. We kind of turned a corner, and Dr. Kim alluded to that, and the focus in the last 1 to 2 years has been really on the safety of these robotic systems. How can we go from that 1% breach rate, where some patients may still be getting harmed, to having these be never events? And I've worked with Terrence and a number of other great robotics surgeons on developing best practice guidelines and classification systems for robotics errors. And I think Terrence will talk a bit more about that in a future panel. What I want to stress, though, is that robotics today is so much more than just placing screws. This is an entire software system where we can plan screws, we can optimize our constructs, we're integrating AI, and we're automating surgery. So it's making surgery easier and more automatic for surgeons, so we don't have to use that mental battery. This is incredible technology. We're decorticating facets, we're planning our incisions, we're working around prior instrumentation, and I'm going to highlight some of that in cases moving forward. When I think about where robotics is really a game changer and a level above the other technology we have out there, it's with MIS applications, pelvic fixation, and revision surgery. And I'm going to highlight that here. And so here's an example of an everyday case that we're all doing. This is a 56-year-old female presented to see me with back pain and right leg pain, had a high PI, over 70. Overall, a 15-degree mismatch, but importantly, only 25 degrees from L4 to S1. So, I can do a T-lift here, but it's going to be a tall lift here with the patient as a large habitus. I'm going to need to lower dose quite a bit with my T-lift cages. So instead, we opted to do an A-lift. And so we placed the A-lift, we did an intraoperative scan and plan, and here you can see not only the screw plan at L5 and S1, but also a trajectory that I can place the robot cannula arm through the incision to decorticate our facets, seen here. And this is all done through the same incision. Additionally, I can use this software technology to optimize my screw plan. And so what that means is, instead of a more traditional anatomic screw, I can tip my screw up. And in effect, it's going to make my start point on the skin for L5, S1, and my facet decortication almost at the same place. So we're really minimizing our skin incision and helping with ambulatory surgery. Additionally, we're using the robotic system to plan around the screws that I placed at S1 and L5, something that even with navigation would be a bit tricky. And so able to do all of this through a 2-centimeter incision in the back, and patient went home later on that day. Here's an example of complex pelvic fixation where the robot really saved me. This was a 68-year-old woman, had multiple prior spine surgeries, presenting with back and leg symptoms. And so the first surgery was actually done in Korea after she fell out of a 2-story building. She went to a local hospital in 2017, and you could see instrumentation failure. The set plugs had popped out, the rods were coming out. This was revised to multiple points of pelvic fixation later that year. You can see in 2021, starting to see instrumentation failure again. By the time she saw me in 2023, the rods had popped out again, and we could see haloing around our points of pelvic fixation. She was fused a little bit flat, a little compensatory mechanisms here, extension of the hips, flexion of the knees and ankles. And so we see supine films. It looks like she straightens out, but actually her pelvis is just tipping out. So not only sagittal, but a little bit of coronal malalignment. CT scan is really telling here. You could see really poor bone quality, multiple areas of vertebral compression fractures, poor trabecular bone, and haloing around our screws here at S1, almost no trabecular bone in the S1 body. When we do click-throughs here, we see not just haloing, but really profound bone loss in the pelvis, in the sacrum, and also the body of S1. There really wasn't a lot of bone there that made me feel comfortable that I can do an A-lift safely and have an area for that to sit on. And again, here on axial cuts, you see very, very poor bone quality and significant bony erosion. And so this is one where, I really wasn't sure that I could do before I sat down with my robotic technician. MRI shows maybe some foraminal stenosis at L5S1. Bone density was quite poor, minus 3.4 T-score, and I did put her on 6 months of an anabolic bone agent. And so again, sat down with my technician, and I wanted to make sure there were actual areas of bone before I could even take this patient to the OR. And we planned for a right-sided S1 alar screw on the left side, able to catch a little bit of bone. And you could see the pelvic fixation that we planned around the prior screws, around these really bony voids in the pelvis. Rearranged some screws at the L3 level as well. And this is what my final construct was planning on looking like before surgery. And this is what the rod associated was going to look like. And this was the execution. And so we did 4 points of pelvic fixation, quad rods across the lumbosacral junction. And through that pseudoarthrosis, actually able to flex down the sacrum a little bit, improve my sacral slope. And actually, you could see significant improvement in her compensatory mechanisms as well. The plan here is I'll get a CT scan in 6 months and try to do an A-lift at that point to give her some more intracom support. I didn't mention that we did also use the robot to guide the arm and actually pack bone graft in the S1 body to hope that it would heal a little bit more robustly there. These are the close-up x-rays as well. Here's another example where we got creative with the robot. This was a 56-year-old female, had multiple prior surgeries complicated by infection. So she had a successful fusion at 4.5, underwent an adjacent segment fusion at L3-4 with a lateral interbody cage, had got infected, and they went back and removed it. And she presented to see me with significant disc erosion and bony end plate collapse at the L3-4 level, and really had significant mechanical pain. And you could see when she stood up that L3 nerve was being pinched off. And so I talked to her quite a bit about some surgical options. You see here, CT scan, really significant erosion of the L3, L4 end plate, and actually the L4 screws going up into that space. Again, seen here on CT scan, okay bone quality. And so, again, I wanted to use the robot here to better understand what I can do, what bone I had. And here at L4, you could see how there actually was a way that we could redirect the screws into a good bone purchase. But interestingly, what we used the robotic here for in a novel technique was we actually planned a trajectory into that void between the L3 and L4, where I could then sequentially use a tap in order to debride the area. There was no clear evidence of persistent infection. Her labs were okay, but you really never know. And I did speak to her about doing a PSO or a bigger surgery here, but she wasn't interested in that. Her alignment was okay in her eyes. She just wanted some stability. She was autofused at L5S1, and so we were going to really treat this almost like a 3-column injury and give her a lot of support above and below and hope for posterior lateral fusion. But not only did we debride the area sequentially tapping, I then placed a bone funnel and used antibiotic-laden bone graft in order to deliver that through the robotic cannula into the space. And so really a unique way to use the robot, kind of think outside of the box in a tough situation. And this was her final screw plan and the rod plan, and this was the execution. She's now 2 years out, doing really quite well. Here's an example of a 70-year-old female who had a prior Harrington rod instrumentation and had presented with adding on phenomenon, a little bit of sagittal imbalance, but mostly leg and back pain. You could see extending the hips, flexing the knees and ankles. And this was one where the robot was incredibly helpful in planning around prior instrumentation. But you can see that when we did that, we really had two disparate rod contours. The one on the right side, because of the rotation, was more concave. The one on the left side was more convex. And so this is now looking at the next generation technologies where we can understand the screw plan and then create a rod around that. And you could see the two different rods that were created in order to help accommodate the screw plan and accommodate around the instrumentation. And so this was the pre-op and post-op, some improvement of the sagittal alignment. And this was the final post-op lateral. And you can see when we overlay the screw plan and the rod plan, how nicely that worked. And so this is a case that went from would have been really tricky in order to navigate this in the OR, but with a well thought out robotics plan, you just show up and execute. It takes away a lot of that stress. And so this is what the future is. We're now going to be able to marry a rod plan with a screw plan. And the previous criticism of pre-contoured rods was that you could place a screw ventral or you could place a dorsal, and you're going to have really different rod contours for the same spine. But now we're solving for that. And this is what this software looks like. We're going to import a rod, and it's really going to be more of a red light, green light in terms of does the screw plan match the rod plan. And here it turns purple when the screw plan is out of sync with the rod plan. But this is an example of how these next level technologies are solving problems for us as surgeons. Here's an example of bringing it all together. This is a patient with a high-grade spondy at L5S1, and you can see on the right side, when we plan those screws, that is going to be a wonky-looking rod. It's going to be pretty tough to do freehand bend that intraoperatively. And so after you account for spondy reduction and the T-lifts at the L5S1 and 4-5 level, you can see this is what a typical rod bend would look like. And this is what our rod plan was instead. And so here's the execution. And so again, taking a problem that can really be challenging for surgeons and making it much more easy, predictable, and better for patient outcomes. Thanks so much.
Joe, do you use the robot all the time? And if not, when, and what's your considerations at this point?
Yeah, so really any degenerative case, whether I do MIS open, I'm using the robot. The only time I'll opt to use it in a hybrid manner is for my deformity cases. And so I'll use the robot for pelvic fixation and whatever I could get in that first registration, usually up to L2. Sometimes you could sneak L1 into it. At that point, I'll freehand the rest just for speed and efficiency. But really with the robot, the pelvic screws are so easy. I mean, it goes from being a point where you would really struggle to do that freehand, as I did early on or even in fellowship, to placing those screws in a matter of 30 seconds, really reliably and predictably. And for bigger deformity cases, I'm putting 4 pelvic screws in now. So that's a huge time savings.
So before robot, Joe, was it primarily open for you or nav for you for your cases?
Yeah, it was open freehand.
Or nav?
Yeah, didn't really use much nav. Really, it was open freehand, and then I kind of jumped on the robot train.
We have a lot of novice users out on the virtual landscape that's listening in. What kind of advice would you give them in your experience with using the robot about whether to adopt or how to adopt or how to incorporate all this into their practice?
Yeah, I think the first really big thing is to try to have a team and try to get people to understand the workflow of robotics and be patient. You know, it's probably going to take 15 to 30 cases before your team really gets down how to drape the robot appropriately, how to make sure that everything is safely fashioned to the robot, screwed in, all of the frames are in place. So take it slow initially. do an easier case, maybe something open where you could look at the docking point and make sure it looks right to you in your eyes, and really take it slow. And I think there's some panels talking about workflow techniques changes in order to make it safe, because the biggest thing when you first start out is understanding that it's not just slamming screws in. There are some technical aspects to using the robot that can really improve the safety profile. And what I worry about is a first-time user using the robot on a big, tough case and not recognizing these technical aspects and having breaches and then dropping the robot. As I showed, the robot can be incredibly helpful for those more challenging cases, but start small.
Start small. Andrew.
Great talk. I really appreciate it. And thank you for participating. The clinical situation I'm thinking about is redirecting a screw through a very corticated track. So the screw's windshield wipered, and now you want to get purchase into there. I have found, and I'm looking forward to your insight on this, that unless I'm making a drastic change, like 30 degrees or more, that there's a tendency for the initial drill to skive off of that corticated track and bump back into the old track. Do you have any tips on how to redirect within that well-corticated spot?
It's a great question.
It's a good question. It is something that is challenging. So a couple of things that I think about. What the point you mentioned, if it's a minor redirection, it's going to be tough. So really try to get a different start point and a different trajectory overall. But even if it is a minor redirection, you can try to get through the cortical bone. And one way is to introduce the burr a little bit deeper. It depends on the robotic system. Some systems allow for 30 millimeter depth. Others allow for something smaller, 15 millimeter depth. And we've talked a lot about safety and how the burr can be dangerous, but in certain situations under very controlled conditions, you can drop the burr a little bit lower to try to get through that cortical bone from the prior track. I also use a sharp tip tap in those situations as well, instead of the more blunt ones, to help kind of really redirect. And what I'll do is I'll start small. So maybe I'll start with a 4-5 tap, go to 5-5, 6-5 if I'm going to put a 7-5 screw, for example. So it's working it a little bit more, massaging a little bit more.
Pat?
Joe, thank you very much for a great talk, and always I learned something from you. And I think actually there's something else that I may have learned this morning just from listening to your last case that you presented, is that in using a lot of pre-planned rods with some seriously deformed problem that you have to work around, it almost seems like, and this is really going out on a limb for me, it almost seems like the robot is mandatory to be able to place screws in that case with multiple different trajectories where you're trying to put a different length screw in just to compensate. Can you elaborate on that a little bit more? Because I actually think this is a game-changing way to do things, that it just makes it so much easier, and it's actually better for the patient because the pre-planning, okay, is trying to prevent failure of your next adjacent segment in the spinal column.
Yeah, thanks, Pat. It's a great question. And what I would add on to that is that the systems now, again, are so much more than placing screws. What it forces me to do is sit down a day before, 2 days before, and really think about the case, plan out the case, and that makes me a better surgeon. And so I wouldn't say that it's mandatory to have the robot for complex cases, but it certainly helps in terms of screw planning. But it also makes me now think, well, okay, here's my screws. What is my rod going to look like? And how do I want to create a rod plan in order to execute this? And so it, without question, makes me a better surgeon, not from the standpoint of placing screws, but because it's forcing me to plan the case, think about the case more. And down the road, that's what this software will be. It's going to be about designing a construct and really doing a lot of the hard mental parts of the case before you even step into the OR.
Yeah, great perspective. And Thanks again for coming and giving a lecture with us.
Joe, would you go back if they said no more robots, we don't make any more? Would you go back, or would you retire? How important are robots to you these days?
Yeah, I mean, I could go back to placing screws freehand. I don't think that's an issue. I feel confident in my training there, but the part I would miss the most is that preoperative planning, feeling confident before I go in that I know where my screws are going to be. I'm thinking about my T-lift cages, the height, the lordosis of it, and it helps me execute better. And so, I have a plan going in. I know how much L I want to get from 4 to 1, for example. I'll take an x-ray and an arm spin, and I'll scrub out and I'll do those measurements and make sure that I've achieved my intraoperative goals. And I think that's what's going to make us better surgeons and have patients have better outcomes. So I would miss that part of it tremendously.
It's funny, I was just in the elevator this morning with our primary care physician from Pennsylvania, and I'm trying to get in his head and understand like what kind of messages we want to give him. But it's kind of crazy that before robotics, the way Dr. Lombardi was talking, this whole preoperative planning, us really thinking through things very critically, was not really done. It was all done at the moment of the surgery. Once the screws were all where they needed to be, it required so much creativity and so much mental computing power to get the job done, right, Joe? And so it's kind of what robotics has forced us to do in a lot of ways is to say, here is a perfect plan, and this is the steps that we're going to get to that perfect plan, so that when we approach surgery now, it's not the Wild West. You're galloping into the frontier and and figuring out what you need to do. You're trying to actually achieve targeted goals that you've already set, which is a different paradigm and shift, I think, right, Joe?
Yeah, I think that's so well put. And just to add a different flavor to that, I think as surgeons, we all have a limited mental battery, some more than others. But I want to use my battery on the technical aspects of the case, the deformity reduction, that challenging T-lift. And I don't want to use it on placing a screw or worrying about my rod contour. I don't have to do that anymore. So it takes away as you said, Terrence, that idea where you went into surgery and you're kind of going on the fly. It helps me so much more with those other aspects, so I could focus on the more important things to me.
Awesome. Well, Joe, we stole him away from his conference in New York. We'll let you get back to it, but always a pleasure to interact with you. I always learn so much from you. You're a rock star, and look forward to seeing you again next year. Awesome.
Thanks, Terrence. Thanks, everyone. Have a great day.
Thanks, Joe. Okay, great. That was nice. Huh? I definitely don't need an introduction. I'm not that kind of guy. So today we'll be talking about best practices or guidelines in spine robotics at Cedars-Sinai. It's been one of those roads where at Cedars we're starting to really get into the weeds with robots. And we've gone through that, if you remember that learning curve of initial adoption and then going through a lot of failures and then plateauing to a point where you really feel like you're good. At Cedars, we've gone beyond that plateau, beyond that learning curve, and there were moments where there were problems happening years out from the adoption of robots. So this is that later phase of failure where things were just kind of not mimicking our initial great success. And so that's kind of the context of this talk is what happened and what we did to kind of fix it. So here's my consultants. I do a lot of heavy work in robotics all throughout, so I am biased. But this is not that conference that is robots, no robots. So kind of to get started, our robotic experience at Cedars has, I think, been fantastic. It's been led by great leadership. When you think about, it was only 5 years ago when we started using robots. It's not like this was 10, 15, 20 decades of entry. It's one where our first case was done in 2019 with the Mazor X Stealth Edition. We acquired the Globus Excelsius quickly a couple years later because initially it was a technology that no one wanted to use, and after a couple early adopters, it seemed like everybody wanted it, and there was issues with who would get the robot. So we acquired a second robot in 2022, and since then we've done, I think, almost the numbers I was looking at yesterday, at least 1,000 in counting cases so far. And the benefit of that, or the reason that occurs, is because at Cedars we have a ton of surgeons. We have 16 spine surgeons that use the robot of both specialties, orthopedic and neurosurgery. So there's a vast experience and application and perspectives from this. But in that same problem, that same benefit, I should say, of 16 spine surgeons, you have 16 spine surgeons. They're all doing things differently. And there's great heterogeneity in robotic usage. I mean, I love these videos. I watch them all the time. Every time they come out, this is Boston Dynamics. They do the true robotic like stuff. But I think the problems we've faced at Cedars is there's so much heterogeneity in the way the robot is used. The workflows are completely different, and how they deploy the robot in specific cases are different. And it's, the key is not to tell a surgeon how to use the robot. Give them freedom, let them figure out what they're going to do, how they want to use it best in their hands. But at the same time, when you allow this to have such heterogeneity and difference of application, you're going to have variable outcomes on robotic performance in terms of accuracy, in terms of clinical revisions. I think that's what we saw. We saw the initial early adopters that all did it the same way. And so when you did it the same way, the reproducible outcomes were coming. But all of a sudden you add the whole gaggle of 16 spine surgeons all doing different things. That's when we saw that late phase where things were starting to look not so reproducible. And so the administration asked me, they said, go take a look at our cases and see where we are. Joe did a nice recap on his Columbia experience, or their institutional experience. And at ours, with our 268 initial patients, spread pretty evenly amongst male and females, a little more with females. Age is 63 in LA. The BMIs are pretty attractive at 27, but 4.2 number of levels of fusion, 2,000 plus screws, mean follow-up of over a year. And what we found was that the number wasn't zero. It was not 1.5 or 1.0. It was actually a little concerning. And they were starting to cluster. They were starting to happen later. If you looked at the early stage, yeah, we were hitting zero, less than 1%, but we saw an alarming rate of increase month after month. Another case, and where what was kind of a highlight was the M&Ms that we do every month. One of the months, it was like robot complication, robot complication, robot complication. I think it was during the summer at that time, and we were like, there's something wrong. When you look at the 2.2 that failed, there was nerve root injury from screw reoperation, nerve root injury from the tap, nerve root injury from the high-speed drill, a durotomy from the screw, and 4 out of the 6 underwent repeat clinical revision surgery to address their problem. And so to highlight, these were examples. This is a T10 to pelvis with use of the robot. And clearly, we know this from navigation, but there must have been some kind of frame shift or maybe the location of the T10 was a little too far away from where the robot was. This was at the time with the use of the Mazor. And this is a pediatric case that was done by our colleagues, and that transacral screw attempt where the distal portion of the screw pushes the vertebral body forward, leading to distraction and a dynamic change in the spine, which leads to loss of accuracy. And so we published this in our paper. And what we concluded was newer generations, the new generation robots, did not have better complication risks or reduced complication risk compared to the old robots, which was kind of like, well, what does that mean? I thought new robots are supposed to be better. They're supposed to be safer. And what we found was that 50% of robot-related complications resulted in reference frames, issues like the same issues that always seem to be a problem with tracking. And this represented an opportunity of improvement. And so again, the robot didn't seem to make things better, and somehow we saw that there was, we were kind of scratching our head trying to figure out what the issue was. And what we realized early at Cedars was that best practices, standardized guidelines, we thought that might be the issue, because when we critically looked at what was being done, it wasn't the robot's fault. It wasn't the surgeon's fault. It was just the system's fault. We learned this in psych. It's called the fundamental attribution error. And you think it's the individual in that situation that's creating the problem, but really it's how everything came together that pushed that individual or that the people in that situation to do the wrong things. And so what we realized is if we did the same thing over and over and kept blaming the robot and we expected different results, that would be insane. So we sat down under the leadership of Dave Skaggs and others. We sat down, had meetings, collaborations, a lot of them, with all our Cedars robotic spine surgeons. And we collected a best practices, an institutional specific. We went over all the procedures. We collected our Hive experience, and we tried to understand kind of what's best, what isn't, what should be done, what shouldn't be done, all within the realm of the surgeon still can do whatever they want to do with the robot, but we'd rather create the guidelines now instead of the institution coming back and saying the robot program is shut down, because that's what could happen, and that's what had happened in other parts of the country. So in our grand rounds in July of 2023, so this was only last year, we introduced these guidelines after coming up with a lot of things, and we'll go over that today. And the key thing is the robotic and implant reps were present and notified, and they were told, these are the guidelines. If you're going to use your robot in our institution, this is what you have to do in order to make sure it works. And our final guidelines were revised in January of this year. So to kind of go over the organization of these guidelines at Cedars, we have a thoracic spine, and we have a lumbar spine. Their applications of robots in these anatomic areas are completely different. So going over the thoracic first, the main, and these are mandatory guidelines. These are not the surgeon can say, I don't want to do it. The rep is required to enforce this and really make the surgeon understand that this could be a problem if you want to use the robot and you don't follow these. And the first one sounds kind of silly. To adhere to the limitations and working distance from reference frame and or bone mount fixation per manufacturer recommendations. So what does that mean? In the thoracic spine, if you look at, for instance, the Mazor X robot, in order to use, in the thoracic spine, use a single clamp, if you look over on that first line over to the open procedure, 2 vertebral bodies above, 2 vertebral bodies below with a single clamp. And so that was not what was happening. We were clamping it, and then we were spinning it to try to get 7, 8, 9 levels, and we were using that clamp to put screws in as much as we can to maximally efficiently use our OR time and get it done. And in these simple kind of adherences to manufacturer guidelines, we realized that we weren't following all the rules, and this will come up in the lumbar as well. So if you're trying to do that 7, 8, 9 level small thoracic spine where you can get it all in one spin, you got to use a double clamp. The other things, interestingly enough, the attendings relied a lot on the implant robotic reps to do all the screw trajectories. They felt like they got it, they knew what was going on, but as we learned in our later experiences, the skiving, the unique anatomy that only spine surgeons know about facet, landing points, that was all critical to evaluate. But there were a lot of attendings that were just like, glancing over it quickly to get the case going and relied on the implant rep to do it. So they were responsible to review all the plans again. There are a couple attendings that would actually go and get coffee while there was a fluoro CT matching calibration going on. Because again, that wasn't part of the surgeon's job. It was the implant rep's job or the fellow's job to learn the process. And so we made it that the attending needs to be present for all of these things. When you finally go into the open part of the robot, you're always anatomically confirming. I think that's an obvious mandatory that didn't need to be enforced. And then a big thing at Cedars is the high-speed drill bit or burr with a positive stop. When you look at the anatomy, and we looked at a couple hundred, and this was actually published by the Columbia folks, if you actually track a medialized, an intentionally medialized trajectory, one where it isn't exactly where it should be, that lamina depth or thickness is about 10 millimeters in an adult. And so what we realized is if we just use the drill, that high-speed 75,000 RPM drill, just to break the cortex, go just a little bit into the cancellous bone, but those drills are meant to go 30 millimeters deep. And not to shove it all the way down, but just to break the initial cortex, positive stop at 5 millimeters, allowing the slower tap, which is much more tactile feely to actually cannulate the pedicle. That was a major change in the way we used robots in the thoracic. A ball probe check to always check. We use neuromonitoring heavily at Cedars for thoracic screws. That was all mandatory. And then there are a couple attendings, myself included, that would leave the OR without getting imaging at the very end. But we mandatorily made it so that either an X-ray or fluoro or a check spin O-arm would be done. Specifically to Excelsius and Globus, the surveillance pin needs to be included. At some point in the learning curve, there were a couple surgeons that said that wasn't necessary, and we said it was. There's a lot of foot pedal resettling if you use the Excelsius, just really always double checking that you're pushing the pedal to make sure that you're within target. And then the offset warnings, to adhere to those offset warnings, those pressure gauges on the Excelsius that really tell you if there's an issue with potential skive or a wrong trajectory. On the Mazor X, they have this little on the end effector, there's a little divot. Before the case starts, you put the chicken foot on there. That checks the internal reference frame accuracy. That was a mandatory thing. And then this was another big one in the thoracic spine. We no longer, the actual reference ball or the reference frame, we attached on the human being. And what I mean by that is, this is the example of a Mazor X Stealth Edition where they intentionally put the reference frame on the robot. That is no longer the case in thoracic spine. We require that you actually put it on the thoracic spine. So if there's some deflection or some movement of the thoracic spine, the reference frame on the robot won't pick that up as well. Having something on the human is exceedingly important. That was a big game changer for us as well. In the lumbar spine, same things, adhere. So here's the thing about lumbar spine. If you look at where the MIST bridge, link bridge, that percutaneous pin that goes into the pelvis, the first one where it says shank screw, according to the manufacturer guidelines, if you put a shank screw in PSIS and you're doing an open T10 to pelvis, you're only allowed to go up to L4. Okay, that was absolutely not happening. We were putting Chance pins in, open T10, and the surgeon was trying to get it all in 1 or 2 spins all the way up to T10. And so those T10 screws that were a little bit off, that was because, again, these simple rules that you got to change your bone fixation place to keep marching along. And these are just the details that we realized as we were moving along. Same things for lumbar, tending present, confirm accuracy. In the lumbar spine, we do a 10 millimeter stop. So we did that same look at all the lumbar spines, particularly at the smaller ones at L1, and we realized with a medialized trajectory, you can still be safe at about 10 millimeters. And so that again, breaking the cortex, just a little dab inside and then using the tap to figure out the rest. Ball probe trek, postoperative imaging, same things, similar to the thoracic where the surveillance pin, one of our failures was a knock on the reference frame of the Excelsius. The surveillance pin was not used, so we said that should be a mandatory thing. It's annoying because it's a separate stab incision somewhere, but that at the cost of a clinical revision, I think that's worth it. Same thing with Mazor, same issues, mandatory guidelines with Mazor. In the lumbar spine, we felt like our complications weren't there, so we didn't want to burden the MIS surgeons with putting reference frames over MIS places, so we said it's okay to leave it on the robot. And then all these highly suggested for the lumbar, try to use patient-based reference frames if you're losing accuracy. Neuromonitoring is not a mandatory for the lumbar screws, and for MIS, we talk about percutaneous Caspar pins. And so since the introduction of these guidelines from July of 1st of 2023 to May of 31, 2024, this is prelim data. Our research fellows are working on the final draft, which is we'll be publishing soon. Same kind of numbers, same kind of similarities to the initial cohort before the guidelines. And to this date, and Dave really highlights this when he talks to companies and stuff, at Cedars, we right now still are at a 0% reoperation rate for robotic complications. No dural tears, no issues with symptomatic hardware. And so at the end of the day, guidelines are important. Robotic-assisted instrumentation is important. It's historically a 2.2 complication rate at our institution. Guidelines are critical. They help. We need to do more multi-center expert consensus to bring back to our institution, but not all guidelines apply to each institution. What works at Cedars may not work at UT Austin or anywhere else. You got to kind of still figure it out for your own institution to make it work. It's a collaboration of the spine surgeons. We have to take the lead, and if you do it properly, then you'll lead to successful outcomes like we did at Cedars. So want to acknowledge everyone, including a heavy lift from the Medtronic and Globus robotic team for helping us, Dave Skaggs for pushing this along. So thank you.
Excellent talk. I think that's great, and I'm glad you guys are taking the lead on helping to guide education in robotics as well. One suggestion that I might add from my clinical experience is that because of the power of the taps and the screws and such, starting as far away as you're going to start from the frame and then working in a serpentine pattern down, and I might, if I were to adopt your protocol at our place, I would probably add that one as well, just because when you're tapping, you're actually pulling the body a little bit towards the tap, and then you're placing the screw, you're pulling it back. So if you start as far away as possible and then work yourself down, alternating sides, you can compensate for that. And that's one of the things that, I mean, you've heard me talk before. I've been pretty evangelical about it because I found in my cases that's really kept me out of trouble. Those frame shift errors, although they're hard to get, especially with the reference ball nowadays, the skyvometer and all, but they still happen and you still can see them. And so anything we can do to prevent frame shift error So, but great talk, and I'm so glad you guys are leading on this.
Totally. That definitely came up. And you get lost in the weeds when you start talking about guidelines, because every surgeon has their very strong opinion about, that's not a super detail. That's actually a pretty good thing. But that was brought up too. And some surgeons were like, well, do I go serpentine? Do I go my side first, the other side first? And we were like, you know what, that's a little bit too thorny. Don't, again, if it's surgeon directed, we understand we don't want to be too like telling you what to do kind of thing. So that was brought up as one. It didn't make the cut. The going from farther away and working towards. I think a lot of surgeons do that from our navigation experience to just do it, but we didn't feel like that was, and we couldn't really tie that to what the failures. So like if you look at that T10 to pelvis where the screws were all shifted, even if you started at the top and worked your way down, you know, the theory would be that the lowest screws, like your L2, 3, 4 screws, would be the ones that were off. And the T10s would be perfect because that's the ones you started at first, theoretically. So it didn't quite make the mustard of like what's mandatory, what should be mandatory and what shouldn't.
Right. Now, I agree that it makes sense to tailor to individual institutions. That's good.
Yeah.
I would say, though, if you start at the T10 and you don't have frame shift error and you alternate back and forth, you're not pulling the frame. What ends up with a T10, T11 frame shift error is when you start at the bottom and you go up and down one side and you pull that frame over to your assistant side. And then you start marching down the opposite side. And you'll notice that on the pictures that we saw earlier today, that the assistant side screws were contained in bone, and it was the surgeon side that wasn't. And that's because they marched up that side, and then they started coming down the other side.
Okay. Let me ask you this, Andrew. So when this is a late stage failures kind of thing, have you seen those like going through the learning curve? You've had years of experience with the Globus. Like what are, if you're thinking in your head, what are some recent failures? I know there's not many because you're the best in Washington, but like, does any of this ring true? Have you seen any failures like this late term?
Absolutely. I think the most dangerous time for a surgeon is when they think they know what they're doing. And for me, having done all three platforms, you know, because I did it with the Renaissance, I did it with the X, and you know, I'm still doing it with X Stealth and the Globus now. It's when you get that comfortable part, like, oh, I've got this. You know, the first 20, 30 cases, you're sweating bullets, you're double checking everything. Then you get into this lull of like, oh, okay, I know what I'm doing. That's when the bad stuff happens. Mm-hmm. And so does need to be this constant vigilance kind of mentality towards it. And that's where having protocols like what you're putting together is really helpful. That's where having the attending come in and check this, you know, instead of having the coffee break. I think that kind of attention is really helpful at avoiding that. And as long as our residents and fellows are leaving with, you know, 50, 60 cases under their belt with that system, they're probably over that overconfidence hump. But there is definitely a phenomena that I've seen in people that I've taught in my own experiences with the 3 different platforms where it's the most dangerous time is where I think I've got it.
Yeah. So let me give the mic to Dr. Ross. Your experience, how many years have you been using the robot now?
So I've been in practice about 2.5.
2.5.
So I learned info, so 3.5.
3.5 years. So any late term kind of, or late stage, I would say, I mean late term by the latter part of that learning curve where you're already done and you're cruising along and then you're like, whoa, what happened? Did you have those kind of issues yet or not?
Yeah, I would say a lot of it actually has to do with getting to the top levels. So I'm doing longer constructs in the peds world. And, you know, I clamp at the bottom, and then I sometimes, I've noticed that I try to stretch the limits too far, and I try to reach a little bit too far proximal.
Yeah.
And that's really where the accuracy checks are super, super important. And having the navigation array on the patient is so important because, like, you know, those pedicles are really small up there, and you have to make sure that, you know, you're very sure that you're going down that trajectory. There's been times where I've had a couple medial breaches, nothing bad, no neurological issues, but I can feel that I've had a breach. And I either have to redirect that, or sometimes I'll just use a hook at the top level.
And so you're seeing it really
It's
farthest away.
usually when I'm
it's
trying to push
usually-
the limits, when I think I know what I'm doing, right? And I'm like, oh, this is gonna be okay. And that's where you have to be really careful, where
Yeah.
you think you know the technology and you're like, oh, I can now try to like use it in maybe a different way and push it a little bit, and it can get tricky.
Yeah, that goes all the way back to like navigation and, the inability to, and that's the frustration, because this is all built from navigation up, and the fact that we still don't have a good answer for dynamic tracking. And if something shifts, the computer or the navigation system should be able to accurately shift with it. That's the frustration that I keep talking to the companies about. Figure it out, get it done, and hopefully that happens sometime soon.
Okay,
So,
before you
Yeah.
move on, I just wanted to say, we've been talking about this for many years, about this idea of proctoring and training, and I think this is such an important step forward, what you guys have come up with the guidelines. The company, you go and someone gets a robot and they get trained, and then they say, okay, go for it, get out there. And I think what's really important about these guidelines is that it allows someone a foundation to sort of, this is where you should start from. And what worries me when a new hospital gets a robot, that they don't know about these guidelines, they don't understand these things, right? So like Medtronic tells you the shan screw is only on label from L1 to S1. Now I know I've used it more than that, and I push that, but I do it with the knowing that what's the risk and what I can do and when I have to add in a spinous process clamp. But I think the value is courses like this, where we're talking about these failures and these risks, and how to talk to the fellows that are in the room, how to sort of convey that these guidelines are based on all these failures that have happened that are catastrophic, in my opinion, right? Putting a screw through a nerve when you have robot guidance is supposed to never happen.
yes,
So I applaud you guys for putting the guidelines together. It's really great.
thanks, man.
TK, excellent talk as usual. I've heard it from the beginning since 2019, because I was there at the
Work in
beginning for all
progress.
those
It
things.
takes me a
And,
little time.
And I want to add a little different perspective, but it's along the same lines, is that we were incredibly good navigation surgeons, okay? And we still are, obviously, but we'd been doing navigation back before there were CT scans, back into the 90s. And so we became so good at these things, and I think Andrew is the one that pointed it out. You get too confident. Okay, so if you're going to use robotics, it takes a structured set rather than a gifted surgeon, okay, lecturing us about being a world-class navigation surgeon. It puts it into a different realm, and there's a new ball game, and it's kind of a whole new set of rules. That's kind of what this is. It's a set of rules that says if you're going to do robotic surgery, it's going to be held to kind of a different standard of what is acceptable, because the consequences are, okay? And I look at most of those cases up there, the complications, they were my patients back in 2019, or most of those were. And that was the learning curve, is that you get a little too overconfident with the navigation side and say, oh, I can do this robotic stuff.
Yes.
I think we've gotten really good at robotics, and it's because of making a set of rules. Great job, thank you.
Okay, Martin Pham, Dr. Pham, are you on?
There he is.
There he is. Are you at the same conference as Dr. Osorio in New York? Oh, we don't have the audio on. Are you on mute or? I am getting bad flashbacks to COVID. Do you remember that? Or it's like, oh, man.
That was a rough time.
It's like, no, the mute button is off. Like, everything should be working, and it's not working. Meanwhile, the AV guy in the background.
Through the COVID, we ran this meeting.
Yeah.
In fact, the room was empty.
The room was empty.
Except for the
We were
leadership.
maskless at the
Yeah,
time.
except for the leadership, everything was virtual. It was kind of like robotics. You have to be in the room to really get it.
Drazen, are you prepared to do a live demo if this doesn't work?
GK, if you need me to, I can give my talk.
Oh, Dr. Skaggs, David, how are you? So, Martin, can you say anything? Can you say something right now? Are we still not hearing you? No, we don't have you on audio yet. So let's move on, and then we'll jump back to you, Martin, once we figure it out. Maybe restart all those computers and stuff like
So
that.
Martin can hear us.
Martin can hear us, I think.
Okay, we'll get that
But
sorted
he
out.
just can't.
Our tech people in the back are going to get it working.
Okay, so our next speaker, who I'm remiss that he didn't come up here to Seattle and be here in person, but I'm sure he's juggling a million different things, such as running our Cedar Spine Center program and doing important things, much more important things. But we were able to capture Dr. Skaggs to come in today to talk about a novel use of robotics for PARS repair. One thing about Dave Skaggs is he's a humble surgeon who leads our institution, but always asks us for advice. And so when he came in, I think he was a primarily freehand surgeon. Nav and robotics was not really his thing or something that he had been too exposed to. And now that I see him and he's just applying it in all different parts of PEDS, it's really cool to see how he's developed it. And it's really a frontier. Kristen is here and Dave is here, and I think that's the cool thing is robotics is starting to pervade into pediatrics, which is one of the last frontiers. So very interested to hear what you have to say, Dave, about novel use of robotics for PARS repair. Thanks for joining us.
Thank you, TK. And let's see if I can get the right sharing screen here. Tell me if this is working, please. Oh, not that one.
Advantage.
You see it?
Yep, we can see it,
Yes,
Dave.
that looks great.
Awesome. Okay, well, first, let me thank Terry, Kim, Pat Johnson. I never even saw a robot or navigation before I came to Cedars almost 4 years ago. Them and Corey Walker taught me everything I know. And to this day, this week, I was frustrated with a robotic case, and I called up Terry Kim on the way home, and he taught me over the phone how to do it better. So big thank you. Here's the boring disclosures. Here's a real disclosure. Trying to fix a spondylolytic defect in a young athlete with healthy bone is so much harder than a robot-assisted pedicle screw. I want to thank my MIS fellowship director, Corey Walker, who scrubbed with me probably for the first dozen robot cases to help learn. And I'll say, if you have the opportunity to learn from someone who has been through the brutal learning curve, learn from them. You don't have to do it all on your own. Okay, so first off, let's talk about who not to fix. If you have no pain with the spondy, there's no problem, don't fix it. Most people probably don't even know they have a spondy. Most spondies are asymptomatic. When someone bends backwards and there's localized pain, they're telling you they have a posterior element fracture, but be careful, it might not be a spondy. It might be a facet fracture, which is kind of like a piece of sand in someone's eye. So before you go into the operating room, I recommend having a CT scan to make sure there's no other problems going on. And if you have a big old gap, you're not going to fix that just with a spondy repair. In a young athlete, you pretty much have to do a front-back spine if they're going to return to sports. And beware that sometimes the joint is already destroyed. So just fixing that little broken bone is not going to fix that joint. So look for that, warn the families ahead of time. And of course, if you have a black disc, that could be an independent source of pain. So simply fixing the bone might not take all the pain away. Okay, now let's get into the nuts and bolts of how to use a robot to fix a spondy. So by the time young athletes get to me, they've probably had pain for 6, 12, 18 months, failed conservative care. A lot of spine surgeons have been trained, don't fix spondies, leave them alone, it'll get better over time, but that just is not the case. And we want to see, is the spondy hot on bone scan or MRI. And for MRI, the sagittal stir sequence. If it looks like it's increased signal there, that's basically pathognomonic for spondy. It looks like it's in the pedicle, but we know that's what we see for a spondy. And if you see it hot there, that gives you more confidence that the spondy could be causing the pain, but it's not always hot. Sometimes the body has given up on healing, and we don't always get a bone scan because that's a lot of radiation. So planning on the robot is essential. And as Terry Kim shared, we now mandate that attendings at least approve of the planning. I personally try to do them at least a day ahead of time so I could sleep on it. And since we should be having a CT pre-op, it's not that hard to do. And it's very humbling. Look in the upper right corner there. Let's see if I can do a really cool job here. Maybe not. Look how close we are to the joints. Whoa, I didn't mean to do that. I'm going to try one more time to use a pen. Doesn't always work. So look how close we are to the joints here and there. This really is a very, very precise screw. And if you're a millimeter in one direction or the other, you could do a bad job and hurt someone. And if we can look at the skin and perhaps use one incision for both screws, though that's not always possible. Given the choice, I'd rather have both a reference frame on the patient and a surveillance marker so you know if you've hit the reference frame. And the workflow is, this is a typical L5 spondy. Use a burr to help prevent skiving, use a drill, guide wire, and then tap across the lytic defect and put the screw across the lytic defect. Now, on the imaging for the robot, it always looks perfect, even if you're in the wrong place. So I believe in a Swiss cheese model of safety. Maybe not for every pedicle screw, but yes, for a spondy repair. Because again, this is hard bone, very high skive potential, and you have to be exactly in the right place. So I'll bring in a separate fluoro. I'll feel it to make sure you're in the right place and even stimulate the screw. I've had to pull a screw back because it was touching a nerve. And here's what it generally looks like. This is my first case. The kid was surfing post-op week 2. All of his pain was gone. And, well over a year out, he's lifting back to normal life. So far, I've not had one of these fail. I've not had any screws break. So the first case, we did a CT at 5 weeks. And look at that haloing around the screw. Whoa, what's going on? Was it infected? Was it loose? I was worried. But it turns out that HA-coated screws look like this at first. They start incorporating 3 to 6 weeks. They really get incorporated around 12 weeks. And I don't follow with any more than one CT these days, but for the first case, I kept following to make sure everything was okay. And we could see how with HA-coated screws on both sides of the lysis, it stops motion. And so far, all of these patients have healed. Now, there's a lot of pitfalls. These are tough cases. So one pitfall is a super hard bone. If you're 0.5 millimeter off, you're going to skive. So do your best to try to start on the flattest surface possible, though it's not always possible. And sometimes, even if you get the drill in the right place, the screw goes in the wrong place because it's bigger and duller. So why not put in a guide wire? What could go wrong? Well, I'm going to share a case where I was a bozo. I violated the typical orthopedic idea that you never put the screw or the tap all the way to the guide wire. Once you get the tap past the lysis, and once you get the screw past the lysis, you can pull out the guide wire. I made the decision to leave this in place. Kid is well over a year out, no symptoms. I think pulling out the broken guide wire would have been worse than leaving it in. Now, if you're doing it at, say, at L3, it's really, really steep. And sometimes, this is a key teaching point, the spinous processes of L4 or S1 or L5 can get in the way. Sometimes you need to cut the spinous process, leave the ligaments attached, just bend it out of the way so you have a clear shot of the screw, put it back in place, and it'll heal. And here's a more extreme example of where something upstream got in the way of the robot. And here I was very happy that I tried to feel with a ball tip probe. It didn't feel good. We had the independent C-arm. It clearly didn't look good. And the problem here is when we planned it on the robot didn't see the previous instrumentation, which knocked the relatively wide robot arm out of the way. So let's talk about another potential problem. If you're dealing with an L5 spondy, which is most common, L5 is locked into the pelvis. It's not going to move. You know what? L4 moves and L3 moves a lot. So if we have pelvic fixation and we're putting a screw in L5, we could make one little skin incision, move it to the side, move it to the other side, it should be fine. However, if you have pelvic fixation and you're moving a skin incision in L3, what could happen is you could move the entire spine. And you see on the right, the whole spine was moved to the side, but the robot didn't know it. The robot just knew where the pelvis was. So I would say if you're on L3 and probably L4, you should probably put the reference frame on the spinous process of that vertebrae. So if you move it a little bit with retraction, the robot knows where that vertebrae is. So into bone graft. The number one thing we found out in our series is if it's hot on bone scan or MRI, the body's trying to heal itself, it's more likely to heal. The 2 times I've had to go back and bone graft later are cases where the MRI or bone scan wasn't hot. So I'd say in general, any gap more than 4 millimeters bone graft. If it's not hot, I might even bone graft a 2 millimeter or 3 millimeter gap. So here's a kid who had a bigger gap. The surgery, number one, put in the screws. We don't want to move anything around. We want to do minimal dissection, put in the screws. Next, this is kind of cool. You could use the robot to plan a pretend screw to give you the path down to the spondylitic site. So then we could put a guide wire right at the spondylitic site, put down some tubes if you want to take bone graft through the same incision, and then looking through the microscope in the tube, you could see the threads of the screw crossing the spondylolysis. You know you're in the right site, take out the fibrous tissue, put in the bone graft. And so far, all of these that we've done have healed. I tell patients it's going to be about 3 months before you're back to competitive sports. Oftentimes it's before that. So here's the patient is now more than 2 years out, totally returned to all activities, including weightlifting, baseball, and football. Here's a 12-year-old from the East Coast. I ended up using BMP. There was a massive amount of bone graft. I'm not sure we should use BMP all the time. I feel safest with iliac crest, and it seems to work. But you can get massive amounts of new bone. And this is kind of getting near the end here. Every time I give this talk, someone says, hey, why don't you use a compression screw? Because it does sound appealing. And I bet you the compression screw provides compression at first, but they seem to loosen up later. This is a failure done saying elsewhere. This surgeon has now changed over to use HA-coated screws. My belief, without much data, is that having an HA-coated screw with good fixation on either side of the lytic defect is probably better than trying for the home run of compression, which I think could loosen up over time. And in general, remember, the old ways work. If the robot's not working, you could open it up, you could do it with a pedicle screw and a hook. If things aren't working, don't keep proceeding. You could harm someone. If you need to, open up as a bailout. And the final thought is there's now evidence that when someone has spondylolysis, they are abnormally stressing the disc and causing a black or degenerative disc, which we can't fix. So now that we could fix spondings less invasively, should we perhaps consider doing them sooner before the disc goes bad? So in my opinion, robot-assisted MIS intralaminar screws are difficult. There's lots of challenges, but I really think it's better patient care. So thank you very much.
Thank you very much. That was a great talk. I have one comment that I got from Brandon Carlson in Kansas City, and that is when you're doing these bilateral repairs, his protocol, which I've adopted myself and found it to be quite good, is to drill, tap, and then go to the other side, drill, tap, screw, and then go back to the first side and place the screw. Because especially if you're starting off on the right side with the clockwise motion of the screw insertion, you can actually twist the vertebra out of plane and then you'll have a harder time hitting the trajectory that you want on the left side. So just a small point, but it's really kept me out of a lot of trouble, and Dr. Carlson was kind enough to share that with me. Hopefully you'll find it helpful as well.
Yeah, that sounds totally reasonable. I like the idea that we don't want to do anything that moves the spine until we have the correct trajectory drilled. Good suggestion.
Kirsten, do you have a question?
Yeah, hi, Dr. Skaggs. We did our first one, we emailed you a couple weeks ago, and we've done one of these so far. And I just wanted to ask you about your patient positioning on the bed, because what we thought about beforehand and what was actually really helpful was we put the patient on a Wilson frame, and that really, really helped with that angle that you were talking about to be able to get a little bit better of an angle. So can you talk a little bit about how you position on the bed?
Yes, so I did one this week also, and I also used a Wilson frame. There is some data that using a Wilson frame will open up L5-S1 by about 5 degrees more. So that's a great point, Christian. Thanks for bringing that up. And I want to apologize to everyone in the room that I'm not there. I wish I was there. Seattle Science Foundation is fun, and there's nothing like going out to a faculty dinner with all of you.
Dave, I'll tell you, it's just refreshing to see you go through the process, because I saw you starting to use it. I saw your failures, and the way you bring it all back home and put it so eloquently in a talk, it's great. I mean, because I think for a lot of adopters who, like Kirsten and others, like it going through each one of those failure cases and being like, okay, I'm going to pull that guide wire out before I put the screw in. I think you've actually saved a lot of failures across whoever's watching. So that's amazing. But again, thanks, Dave, for coming in. Martin, are we back on track?
All right, can you hear me now? How about now?
Yes, we can hear you great. Martin is also in New York. We want to thank you again for taking time out of your busy schedule. I know you're all over the place. You just have to figure out how to clone yourself, and then we could be here. But maybe next year. So we were, before Dave's talk, we were getting on this guidelines and understanding our experiences. And what's neat is we're starting to get Columbia's experience, Cedar's experience, all the different other institutions. And so hearing from you down in San Diego about your experiences, because Martin's been in this game of robotics, I think from the beginning. Although he looks like he's 10 years younger than most of us, he's been around for a long time, and he has a lot of great pearls. I always learn a lot. So go ahead, Martin, pearls of MIS robotics.
Well, I appreciate that introduction. And, similarly, we also started in 2019. Also had a lot of concerns. Initially, I just dye my hair to take out all the white hairs from all the anxiety I had when we were first adopting all of this. Similar to David, sorry I couldn't be there in person as well. Similar to what Terry was saying, we're all stuck in the colder New York area for another conference out here. But happy to share kind of my own learning process. Pearls of robotics in minimally invasive spine surgery. Here are my disclosures. So relevant to the talk, but the talk is about robotics, so hopefully not as conflicted. Many of you will recognize this painting girl with the pearl earring. She's wearing that pearl because she's already listened to this talk, so she always knows all the tips and tricks for robotics here as well. So, MIS is great. And the issue, though, is that you can really see everything, or you think you can see everything, but you're working down a very, very tiny tube. And the analogy I always make is, especially for the residents here, instead of building a ship like in open surgery, you're really building a ship down a bottle. And that comes with its own challenges, because now you can't see the spine. And whether you're doing something like minimally invasive lateral surgery, working down a tube, or a minimally invasive deformity surgery, right, where you're placing instrumentation, but you never actually see the spine, it brings a lot of challenges. And so I think my hope here is to provide at least some of the lessons that we've learned here at UCSD. And I think robotics and MIS, there are three main use categories. And those are MIS prone. So we're talking about your TLIF, your ALIF, your PERC, prone lateral, or your PERC tumor and trauma, right? So prone positioning, I think, can be very straightforward. But then the other three use categories that we've explored are MIS lateral. So now you're doing your transpsoas or your anterior psoas or your lateral ALIFs, like we also do here, or your lateral corpectomies, and then MIS deformity, right? So now you're talking about 10 levels of instrumentation, potentially putting in multiple rods and multiple iliac screws. And so these are hopefully some of the pearls that I'd like to talk about today, and hopefully you'll get something out of it. So in terms of case tips for MIS prone, here is a 2-level TLIF I did back in 2019 when we first started this. And then, here's an example of an ALIF and PERC. So here's a 5-1 spondy. Here's the robot plan. And then, did the ALIF, then did screws percutaneous from the back. Here's another example of prone, right? So prone lateral is becoming a bit more popular. And we also use the robot for prone positioning as well. Initially, in our early experience, we would spin the O-arm just to check. So this is the O-arm spin for the robotic system. And then, that case, right? So 3-4 isthmic spondy, prone lateral. We've also done prone corpectomies, right? So especially for trauma that comes in, you have a burst fracture, then keeping the patient prone in case you can just do PERC or whether you have to open. It's a very nice way to do it, right? So here is, it was probably an L3, L4 corpectomy, L3. So, be able to do that corpectomy prone and then place those screws percutaneously. All these are excellent use cases for using the robot. Now, in terms of what those tips are, in terms of the planning, it's just your usual trajectories, right? So however you would put in your pedicle screw in positioning that patient, as in most spine surgeries are prone, that's just what you would plan. And the execution, it really is as straightforward as it gets when you compare it to, the other potential use cases. And, all of the prior talks preceding me were excellent in terms of touching base on how to maximize your accuracy. What I tell, a lot of the residents here, it's light touch surgery. You don't want to manhandle the robotic arm. You can still push the system out of accuracy. So you as a surgeon just want to be as accurate as possible. And for my prone cases, I skip the tap. So I just put down the drill and then we use an all-tap screw and then we just place the screw. Right? And that's sort of our experience in prone. Now, I think where it becomes a bit more interesting is the other use cases, so lateral and deformity. So for MIS lateral, this is something that we started doing in 2020, and there really was no great workflow for it yet at the time. Similar at Cedars, we were trying to figure out how to do robotics in lateral, because as you can see here, it opens the avenue for simultaneous surgery, which is exceptionally efficient, because now I can be in the front, my resident can be in the back, we can do a front-back surgery at the same time. So you have a case like this, 4-5 spondy. I got a very straightforward degenerative case. Here's the robot plan, right? So you simulate the inner body, you plan those screws, and then patient's positioned in lateral position. Since the majority of my cases are OLIF or anterior to psoas, they're just positioned on a flat table. I don't break the bed, and they're positioned as far posterior as possible at the edge of the bed. Now, once this is done, we register the robotic system with those 2 X-rays, and this is my first X-ray, right? So both screws are already in. I navigate in the inner body, so this confirms that the inner body is in the correct position on lateral and AP, and then the screws go in. This is the final standing film, and you can see good restoration of that height, right, through that lateral inner body approach. But what's more telling is the fact that it's become very efficient. Right, so the robot pin goes in at 8:49. Everything's registered probably the next 10 minutes, right? So 9, a little bit after 9 o'clock, and then drapes come down at 11:08. So for a single level lateral inner body surgery, we're getting it down to about 2.5 hours, right? So it's very efficient. Now, it's not just single level surgery. We've begun exploring multi-level single position surgery, right? So this was a gentleman who came in with a mild scoli and a terrible radic on that side. And so, we did inner bodies from L2 down to L5, and then I did a lateral ALIF at 5-1. And so the question became, well, with the robotic system being so accurate, why don't we just place the instrumentation in the same position? So we go from L2 to ilium with the patient in lateral. And you can see here the ability to do that. Now, there's the planning process is really what makes all of this happen, because in planning that rod from L2 down to S2, everything lines up, and so it becomes as straightforward, say, as a smaller case. Other lateral applications here, T12 burst fracture. So for burst fractures that I do where I want to take down that posterior fragment, as you can see here, right, pedicle is gone. I take out that fragment directly from the side. That means then that it becomes also a circumferentially minimally invasive surgery, because then the screws go in lateral position as well. So I don't flip the patient, I don't change the number prone, everything's been decompressed from the side, and so then the screws just go in, right? And so, for all of these case examples, what were the tips that we had found? The first is the planning, right? So the screws, as you may have noticed in all those cases, they're always going to be a little bit straighter. And we found that the max degree of angulation is about 12 to 15 degrees. And when you plan at that upper instrumented level, you really have to plan closely to avoid that joint. Now, we used to just plan it as we would, right? A straight lateral to medial trajectory, but it just became very difficult. So when you look at this plan, you can see right there, right? That's the upper instrumented level and the proximal joint. So, it's close. And you can also see here that the degrees end up being about 10 to 15 degrees. And it compromises and creates the balance between then doing this in lateral position, right? Because again, with your screws in lateral position, those downside screws are always going to be the most difficult. And whenever we went more than 15 degrees, I would peek over the patient because my resident's putting in the screws, and it was just a huge struggle. And I'd worry about sterility, I'd worry about inaccuracies because of just a steeper angle. So we've gone to about 12 to 15 degrees. Now, in terms of execution, the first is to really secure the patient down to the bed. When the patient's in lateral, they're never going to be as secure as prone, where they're hugged by the Jackson table. So I'm always worried that the patient's going to move in some way. So they're secured very tightly to the table with tape 3 times around. And then I personally give muscle relaxant. I do ATP O-lift, so I don't have to monitor the psoas. So as soon as the patient is secured to the bed, I have the anesthesiologist paralyze them. Because in our early experience, we did see malpositions, and I always wondered if it was because once I'd positioned the patient, they began to sag a little from registration to execution. So for me, you can see here, flat Jackson table, you see those 3 rolls of tape that really cinch the patient down to the table as tight as possible. 1 at the axilla, 1 at the trochanter. And then once this is done, and the neuromonitoring gets their baselines, I just have anesthesiology paralyze the patient, so then they just sag into the table. This is a positioning, as you can see, that distal tape. I'm planning a lateral ALIF here, so that's why you can see markings for the inguinal line and the lateral rectus. But this is also why I tape so far down at the trochanter so that I have access to 5-1. Now, other things that we'll do, again, the screws go in first. If I am doing it simultaneously with with assistant surgeon, then as the anterior surgeon, because I stand in the front, then you just have to take great care not to move the patient while the screws are going in. And then lastly, for the posterior surgeon, bovie that soft tissue tract to reduce bleeding. And then for laterals, I do tap, right? I think I just want that extra preparation of the bone, just to prevent any inaccuracies. So you can see here what that ends up looking like. So while the screws go in posteriorly, for me, standing in the front, I make the incision, I dilate down, I'm in front of the psoas, I open the retractor, and I get that disc space ready. So as soon as all the screws are in, then the disc prep is proceeded to. And so I hope to get in that cage within the next 5 to 10 minutes because everything's already exposed. In doing that, though, naturally, I take great care not to move the patient. You can also see, especially in lateral position, once you make that incision, the patient will just continue bleeding onto the ground. And I was almost embarrassed. I am embarrassed to admit that within our first 10 to 15 cases, I noticed that the residents would start wearing booties because they would just bleed all over themselves. And a valid question that the anesthesiologist asks is like, hey, is this really MIS surgery? There's all this blood on the ground. And so I tell the residents, hey, because the bleeding is not going to stop in lateral position, when you make that incision and when you make those cuts, bovie down, right? So use the bovie, because otherwise, if you put in that knife and you cut that muscle, things are just going to bleed, and to make good hemostasis there. Now, the last use case I think that concept is one of the more interesting and something that I care a lot about, near and dear to my heart, minimally invasive deformity. So, here's a case of a woman coming in, 52-degree curve, right, degen scoli. She is off on her sagittal parameters. And, you get a closer look at this at 52 degrees at her main curve, 27-degree fractional curve. I do use patient-specific inner bodies as well. So this is in an effort to keep things circumferentially minimally invasive. So these are the planned personalized inner bodies that will straighten up her scoli. And then this is, kind of out of the scope of this talk, but the first stage, she gets the 4 inner bodies from L1 to S1 through a single incision because I'm working at her concavity. And then she has a separate incision at 5-1 where she gets a bullet cage for the 5-1 A-lift. Now, once those inner bodies are done, here's the robot plan. So, with that correction, the entire goal then is to place the screws and rods from T10 down to S2 minimally invasively, right? So transfascial. And then with this software, you could simulate some of that derotation. And then this is what it looks like intraoperatively, right? So I make a single skin incision and you can see how bloodless it is because we're not accessing the muscular envelope. Here's my PGY2, right? So he's passing that T10 to S2 rod, but because everything lines up quite well, it's not a difficult maneuver to do. Once that comes in, here's our long film, right? So, many systems you're able to either get a 36-inch film or a long film using your intraoperative CT scanner. So good correction. And then here's our postoperative standing films, right? So for completely circumferentially minimally invasive surgery, no blood loss, no ICU stay, and it's just a nice opportunity to correct some of these more mild deformities. And of course, the whole goal of course, is to get her in alignment. So whatever alignment parameters that you choose to use, whether it's PILL and PT, which is starting to be a bit more long in the tooth, or L4 to S1, L1 PA, T1 PA, right? She's put back into her parameters. So, what were the tips that we found in exploring how to leverage robotics to do something like this? The first would be the planning. So the first tip that we found is to make sure all your screws line up to S2, right? Your S2 screws are going to be the limitations within how medial your screw heads can be. And it's okay for your L5 and S1 screws to be straighter, right? Because again, you don't have the luxury, like in an open surgery, to line this all up. And I'm presuming that for MS deformity, you're putting in inner body cages, so you already have anterior interbody support. You don't have to have your perfect lateral to medialized triangulated screws. The next is because you're on the robotic system, you can plan and avoid some of those L4 to S2 tower collisions on the sagittal views. So what do I mean by this? If you take a look at this robot plan, you'll notice at S1, my screws are actually fanned out. Because when you look over to the left side of the screen, my priority is lining up everything from T10 down to S2. So once I've drawn that line, all the rest of the screw heads are meant to line up to that. And although it looks kind of silly for the S1 screws to be fanned out, as we know, for the vertebral bodies, it's just bone, right? At this point, I have a 5-1 cage, I have S2 screws. The S1 screws are more of a formality, right? Because they don't really provide a lot of biomechanical support in addition to everything else I'm putting in, but I still want it in bone. So at this point, I'm just making sure that they line up. The next is if you take a look here from L4 to S2, you have to be careful to make sure that your screw towers don't collide, right? So, in our first few cases, I was just planning the screws level to level, and I started realizing intraoperatively that many of these were colliding, right? Because I was just looking at it from bone to bone. So here, if you have to go a little bit higher on the starting point at L4, L5, or a little bit lower on the starting point at S1, it makes it a lot easier to manage your screw heads and screw towers because again, nothing is open, right? All you have are just screw towers popping out of the fascia, and this will save you a lot of heartache in the future and in the operating room. The next is in terms of planning. For multi-pelvic or multi-rod constructs, you will usually use outrigger screws. So for those of you who do deformity and you do it open, again, when you put in multiple rods, the most common way to do that is to put in dual-headed screws, which I do for my open deformities. You can't do that in minimally invasive. And I say that because I've tried. I failed. Maybe other people have been able to do that. But there's so much fascia and muscle. That means if you want to put in multiple rods, they're generally screws that are coming outside of the main rod. So if you take a look at this more closely, you'll see these screws up at L1 and L2 are just more lateral to medial, and they lay outside of the main rod, right? So this allows me then to have 3 rods in this particular construct, in addition to the anterior support. And I just essentially I pass that rod L1, L2 to iliac, sorry, traditional iliac. You can see here as well the planning that we're able to do that, right? So I plan the other screws down the main rod and then the accessory screws for the accessory rod. You can see here another example of that, right? So these screws were planned just more lateral to medial. This ended up being a kickstand rod, right? So with that, I was able to kick down her right hemipelvis to make sure that she was kicked over. Another example, right? So 4 rods here, but you'll notice that these screws are planned outside of the main rod. So then I still get the benefit of the 2 main rods with multiple inner bodies and a 4-rod system, which we know has the potential to reduce rod failures. Now, I have started trying, for deformities that are just well corrected, and this gentleman, he was just well corrected with his inner bodies. I ended up just putting in the screws where they lay, and you can also just put in open connectors. You do have to cut open over that rod, but that's also something that you can do, right, to get in multiple rods as well. But whatever your technique, we found at least that you can't really put in a dual-headed screw. It doesn't fit down the robotic arm. And so there's other ways, though, to get in multiple iliac fixation points and multiple rods. The last planning point, for PJK prevention, I've started over the past 3 to 4 months to do vertebroplasty at UIV +1, and then cement screws at the UIV and UIV -1. Now, in terms of deformity, though, in terms of the robot, this makes it quite straightforward because with the robotic system, you can plan your cement trajectories. So you'll notice here at the UIV +1, I just plan a trajectory that would essentially line up to where I would put my vertebroplasty Jamshidi needles. So here are the fenestrated screws. Again, they're angled further down just to prevent pullout. And then you have the vertebroplasty screws at T9, and you can see that trajectory here as well. So with robotics planning, you can do all this, and then at the time of the surgery, this can be executed much more easily. So in terms of the execution, I do a single skin incision, wide undermining of the fascia. We talked earlier about trying to reduce errors, and it's interesting to get everyone's experience. So I still just pin at the pelvis. So I put in 2 iliac fixation pins that our robot attaches to, and then I go from T9 or T10, and I work my way down. So we have not necessarily moved to attaching in the middle or to a patient reference frame. And then we'll place the screws without the extension towers, and then we'll do a K-wire for the cement trajectory. So this is what that looks like. So you can see a very wide undermining of this. I mean, I feel like a plastic surgeon almost when we do this, because we completely undermine on top of the fascia, still very bloodless, but the skin is very loose. So now, as we do our trajectories, the robotic arm is not fighting any of the skin. Once those screws go in, you can see the screws I initially put in without the towers. And this allows me to manage the airspace above the body better. At the top, we have K-wires going into where the cement trajectories will go with the vertebroplastic Jamshidis. And then those towers that you see existing at UIV and UIV -1, those are for the fenestrated screws. So those towers will be for the cement itself. And then once the towers go in, right, that's what it looks like. And then this is what the final long film would look like, right? So again, you can see the cement up at the top, as well as the fenestrated screws with their cement at UIV and UIV -1, and then what that CT scan would look like. And again, very straightforward, especially when you're using the robotic system. So after the conformation spin, I'll nab the cord to get all the facet joints. Again, you just follow that screw down. The joints are just above that screw. And then I personally use pre-bent rods, right? And so for that, I'll either cut it in situ if needed. The engineers have gotten very, very good at planning some of these, so oftentimes I won't have to cut them at all. But you'll see, as neurotic as I am, just to make sure that the rods are very flush, this is just a cut rod. So if it's a little bit long, I'll cut it in situ with a cutter or just a carbide burr. Here's another example as well, right? Also circumferential minimally invasive case. And for that rod, I end up just cutting it short so that everything just still looks very neat, okay? So in conclusion, the topic of this talk is robotics and MIS. MIS is great. in well-selected, medically complex or frail elderly patients, as long as the surgical decompression, realignment, and fusion are achieved, right? So MIS is not a panacea, right? MIS, it sounds great, but you still have to accomplish your surgical goals, right? Whatever they may be. And for the purpose of this talk, robotics facilitates and streamlines MIS, right? As you can see in all of these use cases. But again, advanced technologies are not a substitute for good surgical decision-making and judgment. And I know that the prior talks have talked about, that intraoperative sense of judgment on making sure your technology is working for you and is accurate as well. With that being said, open surgery is great, right? When I grew up, I wanted to be a paleontologist, right? Doing an open surgery is just like digging up dinosaur bones every single day. So it's very enjoyable. But sometimes an open surgery is not what either you want to do or maybe what the patient would need. And naturally in an open surgery, you're just in a pool of blood, and swimming in a pool is great, except when that pool is a pool of blood. And so how do you go from a maximally invasive surgery to a minimally invasive surgery? Well, robotics is certainly one way to facilitate that transition. And so, hopefully this has provided some tips and tricks for those of you who are interested in incorporating MIS and robotics in your practice. And thanks again for the time.
Martin, you're getting a standing ovation over here. That was a fantastic talk, really. Is there any way we can get our panelists on? Martin, can you stop sharing your screen?
Yes.
We actually have a ton of people on. I was actually shocked that there were so many on. I don't actually know if they're all present or if they're doing that whole COVID virtual thing where their screen they're logged in, but they're, do you have the view of the gallery of everyone? I'm sorry, they're the only ones who have their camera on?
You're the best looking one there, Terry. That's why they've trained it on you.
What I would tell you is, or I tell the panel folks that are on right now, especially our fellows and so on, if you have a question, please pipe up. You have access, and by all means, let's get a microphone over. If we have a bunch of questions, Martin, for you. Go ahead.
Thank you.
Identify yourself again.
Sure, yeah. I'm Nick Minnesali, spine fellow here at Swedish. We
yes.
recently adopted using the robotics. I've really liked it. I didn't have any prior experience. We've done your technique here with skin incision, wide undermining, and then fascial percutaneous screw insertion. I was wondering about closing and wondering about seroma or using superficial drain under the skin. Do you have any tips for that portion to avoid any drainage or seroma?
Yeah, so the first tip is telling the patients, because they will get a seroma there, and it essentially feels like a waterbed because it's like this bag of fluid. I do put in a superficial drain. So that's essentially the only drain I place, especially when it's just circumferential like that. And it essentially stays the entire time that they're in the hospital. And it's removed either the day they go home or the day before their anticipated discharge. Invariably, some of that comes back, right? So when I see them in follow-up, there is a fluid collection that's there. It also invariably goes away. So I remember I had actually one of those cases in there is a very thin woman in her 50s. And so her seroma was quite noticeable. And it was cosmetically not the best looking in early follow-up. By 3 months, it was completely flat, right? So I tell people, especially if it's a seroma, it goes away. And seromas all go away. But the only strategy I've had is really just leaving that superficial drain. Maybe some of your attending staff can provide you some feedback. I know as a fellow, all you really see is the intra-op and then the early post-op inpatient. But they've all gone away in my experience. So it's not a huge concern.
Pat.
Martin, thank you very much for an incredible talk. And I'm becoming a believer more every day about this. And we did, in fact, I just sent you by email, we did a paper 10 years ago about lateral simultaneous single level that we did. We didn't use navigation. We did them with fluoro. And it was incredibly successful. I mean, and this just takes it to a whole new level. I mean, I just want to commend you and everybody that's doing this technology, and especially you as who I think is a big leader in this. So I want to come learn from you again. I did a bunch of years ago when we started, and I'm going to learn from you again about some of the simultaneous lateral stuff.
I would tell you, Jay, that probably the reason it didn't take off, because I remember I published that with you and Donnie, was it was hard. It was hard with fluoro. The surgeon is like bent 90 degrees, looking at the fluoro screen, trying to get that down pedicle trajectory and stuff like that. And I think that's why it never took off. And it didn't even actually take off much with nav as much as I think. So it's something about that robotic arm that's able to just get to exactly the trajectory without the fuss, right, Martin?
Yeah, I mean, Pat, I see your paper here, and I have to say that I have the luxury of standing on the shoulders of giants like yourselves who pioneered doing this with the technology that was available, right? With essentially a fluoroscope and then later with nav. And I came in, I feel very fortunate coming into it at the right time, because when I started doing OLIF essentially my first 1.5 years into my attendinghood. So in residency, we were a big TLIF program. I did a handful of laterals, and then I graduated, and I really believed in lateral access. So I learned it as an attending, right? So for those of you in the audience who are residents and fellows, even if you don't see something in training, the learning continues. And I essentially started with single position, right? So I actually never did a lateral only and flip. So imagine the learning curve of learning both lateral access and single position at the same time. But I also had the benefit of all these papers prior to me doing single position and all of the caveats at the time, which robotics was perfect for. And it was mainly just making sure that technology was used in an appropriate workflow. Because, similar to a talk earlier, the manufacturers create the robot, give it to a surgeon, and then, have at it, see what you find. And so we found out, and now it's a lot safer in terms of the protocols we've made.
I think any other questions right now? What you highlighted, that everything we learned in fellowship is nothing like what we're doing now. It just rings so clear, because for the fellows in training right now as well, gosh, the things that you're going to be doing in 10 or 15 years, all this stuff will be super archaic. You'll be like, the first robot, what a joke. Now we're doing this or that, and I think that's the exciting thing about spine. But I think we need to move on to the live demonstration broadcast for BioSkills. Are we ready with number one?
Gary's over there giving the thumbs up.
Yeah, Gary, good. Drazen, let's feed over to the lab. There he is, all decked out. Love the hat as always. Dr. Drazen was a fellow with us, or was a resident with us in neurosurgery. He did his fellowship up here at Seattle Science, I believe. And he is going to talk to us about how to utilize the robot on a very detailed live view robotic-assisted traumatic fracture stabilization. So you're on, Johnny.
All right, thank you very much. So first thing to talk about is that this cadaver doesn't have a fracture. So it's always difficult to demonstrate a true fracture case when you don't have that in front of us. So we're going to pretend this cadaver has a T12 burst fracture. And we're going to say here that there's no posterior involvement, meaning there's no need for laminectomy. I'm happy to answer questions about how I do those cases. And we could additionally talk about if this patient had osteoporosis, because we see those quite often. In my practice up north, it's heavily trauma-based. I pretty much show up on a Monday morning and I may have a burst fracture waiting for me just from overnight. So I don't have the luxury of days to prepare for the case. I really kind of have to take care of it that morning. So it's kind of what we're dealing with right today, and we're just kind of going to go through all the different nuances of setting up the case, whether it's a T12 or say a T6 fracture, and we could talk about the different positionings there. So let's start with positioning. So if it's a upper thoracic fracture, I use a Jackson table, and we're going to tuck the arms just so we could get the O-arm in for a spin. If it's a T12 fracture, like in this case, we will likely Superman the arms. And again, we always have to think about how that O-arm is going to be able to come in safely and avoid those arm boards. So that's always a first point of concern. Next thing is we review all the imaging, CT scan, see where the pedicles are, see where the tension point is. Is there a small pedicle? Do we need to think about using a smaller screw for one of these smaller thoracic pedicles? So planning that early before we scan is important, also to make sure that the reps and everyone has the right screws involved. You could see here on this case, we have it set up as a Shands pin, and as the guidelines suggested, you should really stick to the lumbar spine. Well, the first thing I do is when I put the patient down, we bring the robot in and we see, can we reach to T10? Is this something that we're gonna have to do a hybrid, PSIS and spinous process, or could we just do this straight from the PSIS Shands pin? A lot of times we could do it with this particular T10 to L2 with just the PSIS, but it is stretching it a little bit, so we always have to be mindful of that. So, the actual on label is L1 to S1, so we are always focused on that and then doing things that are safely. There are other options besides the spinous process clamp and the Shands pick. There is a articulating part that actually isn't really available anymore, I'm told, so that's unfortunate, but that is the idea, right? What can you do to do this safely is where we're talking about. Okay, so we've attached the robot, we've placed the patient, we've gotten all the anatomy figured out, so we take an x-ray, we mark the levels. Next thing you know, we're gonna spin, and then we're gonna start to set up the plan. So we've already planned all the screws and all the facet decortications, and maybe we could show the plan, Brian, onto the screen there. And what you'll see are screws from T10 to L2. And as much as possible, I will try to get screws at the fracture level. Now, sometimes the fracture is highly unstable and you could only get in a short screw, or you could only get a screw in on one side. So the fracture really dictates what I'm going to do. If the fracture is highly, highly unstable, or I'm really, really worried about it, often I will only instrument one side, then place a temporary rod, and then instrument the other side. But my workflow is mostly the same no matter what I do, which is I kind of believe that you have to be really sensitive to this fractured spine, meaning you really need to drill and tap almost everything before you put any screws. And that's because once you start placing that screw, it really can affect the navigation and the accuracy. So we'll start just putting some the drill and tap, and we'll start at T10. So again, we're starting at the highest level away from the PSIS because we know that's going to be the most accurate. And so, this is our friend, and you can see what I've already done on the skin. I mark the skin out completely for every trajectory because, for example, and if I'm doing deformity or some other sort of degenerative cases, I want to see how that rod is going to line up and how my incision. Sometimes if I'm doing L4 to S1, sometimes that incision, all those screw markings are all close together, and I may have to, just link one incision together. In this case, these is all percutaneous, T10 to L2, they're all far away, so they're all gonna be stab incisions. So I mark that, it feels like good trajectory. I call for the harpoon, which is just the long blade. I make sure I go down, and in my practice, I usually have an aqua mantis because I just like to not have any bleeding at all. And obviously the cadaver is not going to have any bleeding today, but that's also a little trick. I'd say the other tricks that I use is I use some hydrogen peroxide, again, to lyse those red blood cells. I like to have a really clean operation. Next thing I do is I ask for the drill. I usually start the drilling ahead before I'm on the bone. And you can see there, pretty straightforward. And then, over time, I used to use power for everything. And, I found with the osteoporotic spines that it was just too much. And so I've been moved back to being really on without power. And I found, I think the arm needs to be moved, losing some. I found that with just manual, I felt a little bit safer. So that's what I've been doing with that. And I think Andrew also doesn't use power. Is that true, Andrew?
Yes, that's true.
Yeah. So I think we're both on that same mindset where we just feel a little bit safer, just feeling it and not questioning the safety. So again, I drill, tap, and then I move on to the next level. So there's T10 done. And then you may be asking, when am I going to do the decortications? I really drill and tap as much as I can before I do any decorticating. So we're just going to go through that. Again, it's all very, very similar workflow, up and down. The scrub techs get very used to this. Everyone feels really comfortable sort of going up and down like this. Again, in this case, we're pretending that this patient's highly unstable on the one side. So what normally I would go back and forth, in this patient, I'm going to go down one side, and then we could pretend that we're going to pass a rod. So why don't we, after this, why don't we go back? Why don't we do a decortication so they could see that? And so then for the decortication, we would ask for a different bit. It's the acorn bit. So I'm going to take that guide out. Brian's going to send it to the decortication. And again, so one of the things we do in that preoperative section is that we go and make sure that the incision for the pedicle is the same for the incision for the decortication. So we check that. Maybe lower it down a little bit for me. That's the lowest it goes? Okay, no problem. So then we'll show you where we are for the decortication. You can see our plan there. Again, the planning is all done together. And then here is the acorn bit. I don't know if you could see that on the camera. There you go. Again, the navigated decortication is a game changer, especially for these minimally invasive cases. And then next is we have a graft gun. This isn't navigated, but nothing's changed. And then inside here is usually some mastograft and allograft together. And then usually after that, I will use sometimes the purple pointer just to be able to make sure that graft stays all the way in. I will say that sometimes the graft kind of comes back out, so I may even use the acorn bit again just to make sure that that graft stays all the way in. These are just like micro details that kind of make the case go smoother.
Hey, Donnie, can you hear me?
Yeah.
Can you put that acorn down, the
Yeah.
navigated? Sorry, I was pulled away for a second, so I didn't get to join you yet. I'm sure you were doing a great job. Why is that not more superior into the actual facet? Do you see
know-
where you plan the decortication? Are you catching the inferior facet? Is it because you're afraid of plowing into the neuroforamen? Because in my eyes, and I imagine a lot of the audience is thinking that too, is why is that not higher and deeper?
Yeah, so number one is I'm really trying to stay away from anything, any foramen. And I consider, most of these sort of cases as just needing a little bit decortication, a little bit of graft. And I don't want to have any injury. So for me, this is, I'd say a minimalist decortication, minimalist bone graft. I'd say you could be more aggressive, and we could talk about some cases where you really, say it's an osteoporotic patient, what I do, and I could explain that. And in those cases, well, first of all, in those cases, a lot of times I'm adding cement to the screws. So probably, the two above, two below, I'm putting cement in all those screws to make sure they stay. And then a lot of times for those cases, because there's some kyphosis with the trauma, the traumatic fracture, I have to realign them. So, to do that, we've used either a rod-based distractor or sometimes a pedicle, like either a tower-based distractor or a rod-based distractor. When the rod-based distractor is used, then I make a wiltsy on that side, and I go down and I, tighten the screw above, tighten the screw below, and then distract. And in those cases, then I'm decorticating the bone even more so, because I want to be sure, especially on those osteoporotic patients, that I'm getting a good fusion bed. In a lot of these sort of younger traumatic fractures, this minimally invasive decortication it's minimal for sure.
Okay, go ahead.
So,
Can I ask you a question?
yeah.
Can you hear me okay? It's Dr. Johnson here. I'm just in the lab.
I don't hear you, Jay.
Danielle needs any help, but obviously not. I'm seeing that there's no power.
Can we get him a microphone so we can hear him?
Can you hear me if I'm speaking into your microphone?
Here, he's going to give you one.
Is there any power used in these cases?
So,
Or is that the whole point?
yeah, so early on, I would use power because they gave it to me. And nowadays, for the tap, I'm just manual. But for the drill, what I'm doing is we're lowering the RPMs down to 100? And just doing it really slowly. Now, the reason is I had one case where I was going a little fast and I felt the screw it was like it caught like a bone island and shifted. So ever since then, I just haven't trusted normal speed. Now, if it's a really, really unstable fracture, I will just do it by hand. But if the bone feels pretty good, I'll do it on low speed. And I'll show you what that looks like.
So all this robotics technology is going back to having a tactile feedback.
Correct.
The whole issue about loss of tactile everything and anything and haptics and things like that, you've eliminated just because you're doing these parts, and even with the drill, it's a tactile procedure.
Yeah.
Okay, this makes sense. Okay, the whole thing about robotics, when it started back in 2019 and we had complications, it was because we just believed everything and we
Right.
thought, oh, it's going to be a
Give it to
perfect
me,
system.
put it
Yeah,
in.
Yeah.
Yeah.
Oh, perfect. I love this. That's
Yeah.
good. Real surgery.
Yeah.
Okay, keep going. Thank you.
All right, well, why don't we move over to my side for the T10 and 11. Again, we're just trying to mimic the idea here. Drill, tap, move on to the other side, kind of top two levels, get that done, then move down to the bottom two levels, avoid the fracture for now. Can we move up to the top two on my side? And then again, I'm placing the screws at the last possible time, mostly because of the unstable nature of these fractures. That's just my experience. There are other people who may just place the screw right away, but this is how I do it. Well, thank you, appreciate it. All right. Again, this cadaver is not really much to show here other than sort of on repeat, but just so you guys go through it a few more times, the workflow. And then I didn't mention, but before I even start, I do an accuracy check with the nav. When I first started doing these, I was very, very nervous about the accuracy. And what I would do is, if I was doing a spinous process clamp, I would drill a little hole on either side of the spinous process. So I had a spot to mark what was, a spot that I could see on the O-arm spin to always check again the accuracy. I haven't done that as much in the thoracic lumbar spine anymore. In the cervical spine, I do it for the C7 pedicle screws for navigation, and it's also another internal check for the accuracy. All right, so we've done T10 on both sides. Now we'll just do T11 on both sides. And then we could just, this is sort of a pearls of traumatic fracture stabilization. So the value in doing the screws right now, I probably are not limited, are limited, but we'll place maybe one screw just so you guys could see it, how we do it. We'll finish this side up, so then maybe later.
Donnie, right here at Cedars, you penetrate the cortex? No, that's too deep. Pull it back. So we put it only in enough to get that initial cortical breach go down? No. Right about there. That's as far as we go, or a little bit deeper, but that's it. That's as far as you go in the thoracic spine. You don't want that high-speed drill to be anywhere near the canal. And that's what we learn.
Yeah, well, I think that's really good with the guidelines and what you guys have experienced. In our patient population with, I don't know, we got everything from osteoporosis to meth addicts, so our bone quality is all different.
Yeah, ever more so then. Let me ask you, so let's do disaster scenarios. Leave your tap in there. Let's say you have an inaccuracy now. The screws are not in, the tap's going. Now, how does Daniel Drazen figure out if he needs to respin or not? So can we go back to that navigation screen? Okay, so let's just amplify it a little bit and say that tap is going super medial now, even though on the sagittal it's reading correct. Take me through, and this is a trauma case again, so you're freaking out that even the tap part is inaccurate. What's your algorithm or decision tree on how to get back on accuracy?
Absolutely, it's a great question. So first thing, obviously, I remove it if I'm concerned. I would number one, I'd move the robot out of the way. I would get the starfish, chicken foot, and just check to see where my accuracy is. You move this out of the way, so I could see where that track was.
So you use the reference frame that tracker.
I start with that.
You find that to be the most reliable?
Yep, and then again, I'm using some sort of.
Can you go to the nav screen again, please?
And then I'm usually going to have him save whatever error he found just to see if we could duplicate that. So I'm checking my accuracy on with this. Okay. I'm doing I always use neuromonitoring, so I do a motors. Probably do at least 2 motors to make sure there isn't any neurological change.
Motors, okay.
I am actually a pretty quick person to respin if I find something strange. I will tell you, I have a case where I had a really unstable spine, and I put one side of screws in, put the rod in, and we moved to the other side. It just felt like there was some inaccuracy. And so it is a little bit challenging, because when you have to respin with all that metal in, how are you going to be able to still navigate with the robot? So it did take some quick thinking by our techs to try to figure out a way to angle the basically the navigation so that we could get accuracy. And so the answer is, if you're in doubt, respin.
Okay, so if you leave your instrument just like that, and so you're looking, right, because you're using that as the check, and now you're seeing that you're medialized, you're sagittally inferior. What are you thinking next? What do you do? Do you reference frame all your instruments? Do you put the chicken foot on the black end effector to check the internal nav? What's the next step? So go back to that inaccurate trajectory that remember you were a little bit on the lower side, a little bit medial. Let's say it's looking like that. Okay, so what are you thinking now?
Again, you're starting from the very beginning. You're checking all the nav. You're checking to see where the failure may be, considering respinning, making sure there isn't any neurological change. If all that is fine and you've respun,
Will you cut down on the bony spine? Will you cut down on a spinous process? Will you go that far? Or cut down to your exposure and make it a long Wiltse, or will you just respin?
I'm more likely to respin before I make a larger incision. But if I respin and I'm still not happy, then I'm cutting down and want to see it just so I could see the anatomy for sure. But these are good questions. We could maybe put in one screw just so you guys could see that, and then if there's any other questions.
One thing Corey Walker taught us, and I don't know where he got it from, but in these PERC MIS cases, he'll put an 18-gauge needle and embed it transosseous into the surgical site that you're at, somewhere where the spin finds it, or somewhere where the spin will include it. So you have like an 18-gauge needle sticking out from the middle of your field. And if you have these issues where like it's not quite making sense, he'll put it right over the 18-gauge needle tip as an internal check. And if that's off, and that's the true test that if you're accurate or not, then he'll respin.
Yeah, very, very off. That is a good point. I have used little pedicle markers. Sometimes I use needles. Sometimes I use even Bovie needles. Whatever you could do to put inside that track, just so you could see where that is exactly.
And this kind of situation for cedars, we would put a reference clamp on the thoracic spine. We would not use the robotic reference frame that Donnie is using right now, especially in MIS trauma thoracic. That's like 3 levels of nav is going to be really hard to get to work. So we'll put a clamp, we'll make a separate incision, clamp it somewhere at one of these spinous processes, and use that as the tracker instead of the robot.
Yeah, so that's a good point, and I think sometimes the question becomes if you have to do a laminectomy, where do you put the spinous process clamp? So a lot of times for myself, when I do the spinous process clamp, I put it at the most caudal level, right? So if this is a T10 to L2, I'll put it at L2 pointing downwards, or maybe even L3, and then do it, move upwards. So we're going to put the screw in here at T10 again. Really low speed. It's at 100. Again, this is just how I do it.
What's it normally set at?
What's it normally set at? 250, I think.
250, okay.
Okay. But I don't know if you could hear it. You could just hear how slow this drill is going.
We're not seeing it on the nav screen.
There you go. You could just hear it, how slow it's going, and that's...
So Donnie, I'm seeing it completely off on the sagittal. Is that what's happening there?
I think it was just a shift.
Okay,
Yeah.
okay. Good to know.
There's just a little variance there.
So would you put that screw in if it was that, or would you get a new spin, or what would you do?
I'm always checking a respin after all the screws are in. There's no question. I don't leave the OR until there's a spin.
Gotcha. Good.
Yeah. So as I said before, if this is an osteoporotic case, I'm going to put cement above and below. The tower-based distractors versus the rod-based distractors. These are all the different considerations for these traumatic stabilizations. I think that's about it. And then we talked about if a laminectomy is needed. Are there any other questions?
Kirsten talked about patient positioning for some of those spondy things. Wilson table always, Wilson frame always, Jackson table with a pillow in the chest so that the chest doesn't move, taping down the skin. What are you doing for patient positioning?
Yeah, it's always a Jackson table for me. Definitely a big pillow for the chest. And, I will say that the Pro-Axis table I've really liked. It's sort of a newer table as opposed to sort of the old school Jacksons. So that's been a little bit up another level. I try to avoid Wilsons for these cases, but the Jackson table works out really well for me. The robot attaches easily.
Yeah, I definitely pull that chest bolster down. If it's a mid-thoracic, the chest bolster doesn't have to stay at T2.
Yep.
I'll shift that far down, so at least it provides a little ventral support as you're pushing down on it. I'll tape proximally and distally the body to the table outside of the sterile field,
Yep.
just to kind of stabilize that spine as best as possible. But it's super hairy when it comes to really unstable trauma.
Yeah, yeah.
Okay, we are actually right on schedule. Perfect bioskills. Dr. Drazen. Oh, hey, we have a question from Dr. Ross.
So just going back a little bit to that, how that look shifted a little bit. Sometimes I've come into that's happened to me where one instrument only will be off. And I've had this discussion with Medtronic a lot. And sometimes when you're rewashing those arrays that are attached to the instruments, sometimes there's a little bit, after you use them so much and rewash them so many times, there's a little bit of variance in it. And sometimes only one instrument will look off at a time. So I don't know if you guys have ever had
It's like that one
So it looks
instrument.
like you're not accurate
But the next
anymore,
one
but the
is
next
right
one
on
is
accurate.
correct.
So how
Yeah.
do you work through that, or how do you decide what's accurate or what's not? Or is it a
So-
majority instruments are right and the one is
Yeah.
off, or how?
So how I usually do it is I always do that calibration check where you're checking on the black dot to make sure that that's not off. And if I have to like re-gingerbread man or recalibrate the navigation, because one thing that I kind of changed how I think about robotics was when I realized with the Mazor, like the navigation algorithm is overlaid on the robotics
Yes,
algorithm,
it's
right?
not-
So it is not.
Correct.
So the navigation can look off and the robotic platform can be correct. So when you're recalibrating it with that black dot and re-gingerbread manning it, you're basically just re-overlaying that navigation onto the robotic algorithm. And so that can improve it and make it look a little bit better. But I will actually check with different instruments and like put it down the arm and see and see if like there's only one that's not accurate or if there's more than one. If more than one is not accurate, the thing, it's your accuracy's gone. But if it's only one of the instruments, and I think it goes back to also the tactile feel, right? Like we're really careful to make sure we're still feeling what we're doing as we're doing it. If I still trust it if that only one instrument is off, because I think it's just the array, and our registration actually is still correct. I won't do it if it's really off, but if it's off like a millimeter, I would still do it.
That's a great point. We totally forgot that you can read gingerbread instead of, and especially in her world where it's pediatrics, willy-nilly getting just repeat spins is probably not ideal. So
There's two things
that's a good
that
point.
your question brought up. And then one is the much more common reason for one of the instruments to be off is that one of the balls is wet.
Yeah, sure.
And so the first thing to do is check that. And then once you've
Or
made
flip them out, or just,
Right.
pull them off and ask for another one, put it on.
And once you've made your drill hole, that you're committed. That's the hole. So if you put your drill in the right place and it looks good, and you put your tab in the right place and it looks good, and then you start to put in the screw and it looks a little off,
yeah.
it's going in the hole that you made. And so you know,
Sure
I think,
about that?
well, I mean, if it's grossly off, but I'm saying like the a little bit of variance there. But I would say the first thing, if you have one instrument that looks off, first thing to do is to check the balls. Are they wet? And it's not uncommon. You pass it back and something gets a little bit of schmutz on it. I have seen it where the actual array does get bent or warped at some point during the
Yes.
cycling. These instruments are used,
thousands of
At your
times,
institution,
yeah.
1,000 times,
Oh,
right?
yeah, we have a big problem with our instrument arrays being bent, especially the chicken, the blue chicken foot thing. That top one is bent all the time, or.
Yeah, so it certainly can happen. It's just the balls are probably a once a week or once every other week kind of occurrence. The arrays are probably, that's a lifetime issue for that instrument. That might be a couple times a year, so.
I think there are companies that are working on that part of it too, but these are all great tips and tricks. So, thank you, Donnie, that was really good. Okay, Dr. Shafi, Dr. Kareem Shafi, is he on, or is he, he's,
Why did you laugh when you said my name?
no, you're always present. I remember when we were doing spine fellowship interviews, you were the first one there, like 5 minutes before everyone. And that's the first impression I had of you. And I haven't seen you in person since you've graduated, and it's good to see you, man.
Hey, what's up? How are you?
Dr. Johnson's going to do your introduction.
All right. Hey, everyone. Hey,
Sure
Dr.
that you're there, Kareem,
I'm
virtually.
here.
Not seeing you in person here, really, truly, but it is a distinct honor and privilege to introduce our next speaker, Kareem Shafi, who has recently graduated from our program about 6 months ago. And 3? Okay, well, ago. And, Kareem actually embodies what I envision as a great training program, which I think we have at Cedars, because I've been doing this 23 years, and we've trained about 100 fellows.
Hello?
Kareem, did you lose them?
I'm just going to check in if everyone can hear me, if they could just give me an indication.
Yes.
Okay, great. Thank you.
All right.
Okay, are we ready? Are we back? Kareem, can you hear us?
Yes, I can. Thank you.
All right, we had a power outage here, which I think Terry told you about, and
Yeah.
we don't know if we're on generators or not, but we're back up and powered and ready to start our meeting again. We're not going to start the meeting, we're going to resume the meeting, so. Okay. Well, it is my proud privilege to introduce, I'll start over, Kareem Shafi. Kareem just finished our fellowship. I told him 6 months, but he said, no, it was only 3 months ago. But Kareem comes from a long line of trainees, which we've had at Cedars over the past 23 years. And we've trained almost 100 fellows. And I'm proud to say it's kind of my legacy in many ways is that we've trained about half orthopedic surgeons and half neurosurgeons. Kareem is now attending at Methodist Hospital in Houston, Texas. He trained in orthopedics at the Hospital for Special Surgery. He came to Los Angeles, and it was a privilege to teach Kareem. He's an incredibly talented surgeon. In fact, he's one of those guys that at some point in his training, I had to remind him, I said, Kareem, you came here for me to teach you, not you teach me, but that's okay. That's his confidence, and he's an incredible guy, and we're quite proud of him. He is going to talk to us today about his experience and enabling technologies in surgical training, which, as we know, that never ends, Kareem. I just have to remind you. It's lifelong. So welcome and thank you for participating in our faculty in this great course.
All right, Dr. Johnson, thanks so much for that very kind introduction. Can you guys see my slides?
Yes.
Okay, so I'm going to be taking a little bit of a different stance on enabling technologies, in particular robotics, and looking at the role of enabling technologies in surgical training. I have no financial disclosures, but my only disclosure is I'm really going to try and not stay on my soapbox with this topic for so long. It's something I've really thought about a lot over the course of my training, and I'm not really sure what the answer is, so I'm hoping you guys can give me some insight, but I just want to pose the question. And the target I have today is, both my teachers and mentors who are experienced surgeons, having gone through all the iterations of technology or kind of quote unquote old school techniques. My peers or young surgeons or trainees in the audience, any fellows or soon to be attendings, and then our industry colleagues who kind of play a big role in all of this, kind of guiding us along and being our partners on the side. And just to give a background, like we love technology in spine surgery, and there's just been a total explosion on what we have available to us over the past 20 years in particular. If we think of how far we've come from just simple plain X-ray and then to fluoroscopy, then intraoperative CT, and now surgical navigation and shared control platforms with the robotics, we've come a long way, and I think we're continuing to expand and understand these technologies more. And as Dr. TK likes to say, you wouldn't take a road trip anymore without GPS. And I remember going to new destinations as a teenager using MapQuest, and now we're using GPS and satellites or your iPhone, and it tells you exactly where to go. And that's the same picture we have in our operating rooms now, particularly with minimally invasive techniques. We have all these tools that fit so nicely in the room that we can really do a very smooth and streamlined surgery, and we kind of don't look back. But I want to give you a little bit of a cautionary tale. And so this is a case that came into my partner, his office. It's very similar. I apologize, I don't have the exact issues. But basically, young guy comes in with a MVC. He's got his lumbar flexion distraction injury, plans to take him to the OR. Everyone's not debating the indications or what to do. Surgeon wants to do this with minimally invasive techniques, but it just so happens that his enabling technology is not working, whether it's navigation of the robot. And he says, hey, I can't do this surgery. So he gets transferred to my senior partner who's dual trauma spine trained. And he says, no problem, just short segment fixation using perc fluoro techniques. And when he told me this story, I was like, this is a moment of pause. And this is really what I want to highlight, is that we have all these great tools, but what are we going to talk about when we have problems beyond just the spheres are wet or the tools are bent? What are we going to do when these machines don't work for us at the time that we need them? And so just to go over just pedicle screws, for example, my exposure has been, very varied. So I have these two mentors on the left who really are kind of pioneers in the world of navigation, and they love navigation. They've shown me all the amazing things you can do with these tools. But then I have to think of these two other surgeons that I train with who kind of have a little bit of a different stance, where they are really comfortable with traditional techniques, understanding and being master of the anatomy. And I would challenge that some of them can put in screws as good as any robotic platform. And having these four people and many others on the screen, I have to think of where do I stand and how do I approach my practice and the people that I eventually teach on how they should do these techniques. And so just to kind of say what I like about navigation, and full disclaimer, it's great. And my biggest takeaway is protecting yourself. And that comes in a number of different flavors. So radiation exposure, number one. We've shown time and time again that traditional techniques, fluoroscopy, is tons of radiation, and you can reduce that to both yourself, your operating room staff, and your patient with navigation and enabling technology. So looking at MIS TLIF, this paper looked at proficiency being achieved over 38 cases. But even with that, the mean fluoroscopy time for the first 51 cases is almost 3 minutes, and only drops to about 2 minutes when you get beyond that. So it's still a ton of fluoro. And we know that robotics has shown that you can really reduce that fluoro time compared to navigation even, and also traditional fluoro. We know that you can do better surgery, safer surgery. So this is a paper that looked at robotically placed pedicle screws and minimally invasive TLIF. And I like to highlight this picture on the right. Look at how big those screws are. And that's really going to be hard to do with traditional fluoro. So you can do surgeries kind of better in many ways. It's been shown time and time again that they're more accurate relative to freehand and fluoroscopy. So again, just a table highlighting that. But now I want to get into like my beef with robotics. Like, what is the problem that I have? These are such great tools. Like, why should anyone give any pause? Why should we look back in the past? We should just be full steam ahead with these. And I agree on many fronts, but there's some problems with that. And a lot of my peers kind of maybe don't agree with me. So this is a paper looking at young spine fellows, early attendings, and the impact of technologies in their training and practice. And the overwhelming majority said that they're very confident in their ability to teach with the robot. They love that it allows them to put in bigger screws. They feel safe. Only a few of them said there's like a somewhat negative impact in teaching trainees. So maybe I'm on an island out here and no one agrees with me. But I really do think that we're getting away from our understanding of traditional techniques. And time and time again, both on pediatric rotations where this is really common, but also in adult deformity cases, we have to really master these screws placement, and not just putting it in the bone, but putting it in with the right cascade. The cascade that we talk about being so well achieved with the robot, we still have to have some understanding of that with freehand. And this is a paper that I thought was really interesting, looking at, finally asking this question, like, is this not the best thing for us? Is spinal navigation a double-edged sword? This is published out of India, so I'm not sure how relative it is to all practices, but looked at orthopedic surgery trainees and asked them, like, hey, at the end of your training, how competent are you in applying pedicle screws on your own using a freehand technique on a scale of 1 to 5? And the average respondent was almost a 3, so average. So I'm average at putting in a freehand screw. Basic surgical technique that was done for decades before these enabling technologies came around. They're saying they're average. And then on top of that, if they actually test them, like mark the start entry point for just an L4 pedicle screw, massive screw, shouldn't be a problem. Only 65% of them are getting it right. And to me, as we go out into the world and the community, like beyond just academic centers, whether it includes private practice as well, everyone should be able to do these fundamental techniques beyond their training. And so this to me is like somewhat alarming. And this is another paper looking at how many screws are necessary to be considered an experienced surgeon for freehand technique. This is one surgeon series, but it comes out to competency after 300 screws. So after 300 screws, you're safe. And ask yourself, how many freehand pedicle screws did you put in your training? And myself and probably the members of the audience, probably at that number, 300, definitely more in a lot of cases. But if we move forward with all these enabling technologies as they become more ubiquitous, is that number still going to be reached? And so I really think that implementing robotics and navigation and surgical training comes down to balance. We have to balance these technologies with like kind of the old techniques that we know. And so the way to do that is, I think there's kind of three ways to approach this. The first is really embracing simulation. We were fortunate in residency to have really good access to a lab. I know that in fellowship and now with the fellows that I work with, we have really great resources through our industry partners or our hospital that allow us to use cadavers, use models. Shown here is just a simulation that we do in residency where we practice freehand pedicle screw technique. I've seen a lot of videos over last weekend of surgeons showing off how the medical student can put in a robotic assisted screw no problem. But what about a freehand screw? And can the resident even do that now is the question. So I think that these simulation environments are becoming more and more important. One thing that one of my mentors in fellowship told me was that anytime you're at an industry-sponsored lab, or any lab for that matter, where there's an emphasis on the newest technology, the newest whatever gizmo is that you're putting in, take time, expose the entire spine, and cannulate every single pedicle. And I think mastering the anatomy is something that we really have to become very committed to at this stage as the technology becomes more common. The next is using navigation as a teaching aid. And I think that more and more people are putting in navigated screws as the technology becomes more common. It's almost become a standard of care in many practice environments. And I think that what I call like no-look navigation is a way to do it. So where you as the attending surgeon is watching the screen while the individual putting the screw is not allowed to look at the screen. And so you kind of make them really test the anatomy. And actually, this might even be better way to learn the anatomy compared to regular 2D images that we're kind of used to out of textbooks. You gain a real-time understanding and real-time feedback when you're looking at the screw going in on the screen. And I think that can actually be a very positive side of the navigation aspect here. And then the last is our role as educators, and what I call the term is maximum trainee benefit. Ask yourself, like, in a given case, whether typically outside the realm of minimally invasive techniques, what factors or what parts of this case really require the use of the robotic? And is there some element where you can use some screws or some pedicles as a teaching opportunity with freehand technique? Again, I talked about no-look navigation as a way to coach through and teach the anatomy. And then we just have to ask ourselves, moving forward, like, how do we make sure that the future generation of surgeons is fully prepared for any case that comes their way? Can they use perc fluoro if they can't do navigation? Can they put open freehand screws in still as we start to lean a little bit more and more with enabling technologies? So again, my takeaway is that it's really all about balance. And please don't get me wrong, I love intraoperative navigation. I think it's great. You can really put in great screws. You can build awesome constructs. The robot makes things very streamlined, particularly when you're facile and understand it. But we are kind of in the middle of a revolution in enabled technologies. We're really, really good at them. They're becoming increasingly good, but we're not quite there yet where we can forget everything else. And I think of one of my mentors, a trauma surgeon, who anytime you were struggling with a particular part of the case, you're like, I just can't do this. He would just yell at you and say, hey, be a surgeon, use your skills, use your anatomy, and kind of figure this out. So that's my soapbox. I'll get off for now, and I'll take any questions. Thanks very much.
That's awesome, Kareem. I appreciate your perspective, and so does everybody else in the audience worldwide. So it is. We don't have all the answers. We certainly don't. And in fact, we've been hearing about them all morning. And, we've come so far from doing what we did like 10 years ago. I mean, we were still doing fluoro stuff. And we found that robotics, it's taken a lot of refining from all of the navigation people. I mean, we thought navigation was incredible for a long time, but.
Well, I really enjoyed that talk. I am going to play devil's advocate a little bit, and because I've been on both sides of this argument for countless conferences. And I would say that the most effective argument that they have for, okay, well, you need to be able to do it the old ways is, this disastrous scenario, the robot crashes, power goes out like it just did here a few minutes ago, and you got to finish the case. And so there is a role for practicing in the cadaver lab and on, these pseudo-cadaveric models and such, learning how to cannulate the screws and such. But the analogy I would use is, you're in Houston, you got to get to Miami, you're going to take a plane. Now, if the plane needs to be repaired or whatever, you're not going to hop in a boat and start rowing yourself over there. You're going to wait until the new plane is ready. And as these robots become more and more available, you're going to be in a situation where, yeah, so that robot set's broken. Okay, great, but just wheel the one in from OR2. Let's go do this thing. And so I think that as we move forward, in 2 years, 3 years, where every hospital has multiple robotic platforms, multiple versions of the same robot, that sort of thing, it really, the issue of, oh, well, you need a bailout, you got to be able to to cannulate the screws, is less and less important. Now, I'm an Eagle Scout. I'm a big fan of like knowing how to row the boat, knowing how to sail, knowing how to do those things, riding horseback. But I'll be taking my car home tonight. And if my car breaks down, then I'm going to rent another car, right? And so I think with the robot, this issue of crisis in the middle of the night, we have to do it. I mean, just shy of the post-apocalyptic world, we're probably going to be able to just employ a different, the second robot at the university. And I think that the guys that you're training that are coming up now, they're going to be in a world where this is just so ubiquitous that it's neat to know this stuff from historical purposes, maybe some overseas work, but it's not going to be their day-to-day work like it is. You're just caught in this little spot of time where that matters. So that's, and I've argued both sides of this, so I'm happy to support your argument as well.
Kareem, you have any comments? Because
that's a great point. And I think like when I first thought about it, someone's like, okay, if the robot's not working before the case, are you just going to cancel? And I think in an elective practice, it's not really a big deal. To your point, you could say, okay, I'll take the next plane. I'll use the robot when it's available. We'll move the case till tomorrow. Not a problem. I think that where I have a little bit of question or concern is kind of bringing, becoming just this mindset that the robot's so easy, I should just use the robot. It's so much better, because I just feel that like when I see it used in big open deformities, I have a little bit of pause. I know that there's a lot of people doing it out there who can do it very quickly. They're spending less time with the open case. That does not seem like the best application to me, having seen freehand technique being done in open deformity very, very quickly and very, very safely. So again, I don't have the right answers. This is just my stance. And particularly with the MIS setting, I'm kind of leaning towards robot all the way. It's just so nice, particularly with the preoperative planning. I think that is not to be understated. But yeah, I think maybe this is a temporary problem and will go away, but I'm not so sure.
Can I say something? Can you hear me? Yeah. Hi, Kareem.
Hey, what's up?
You were a first year med student, I think, when I was a fourth year med student. So it was nice to see you again. So no, I would actually like to echo what you said. I think we're, the same generation. And I agree with you. I think actually, so I grew up, did my residency in a place where we didn't have navigation at all. And so I learned how to do everything freehand. And I think I'm probably a better surgeon than some people that didn't have that experience. For example, like when I'm doing my robotic cases, I freehand a lot of levels just to save some times and to save efficiency. And maybe as the platforms improve and it's a little bit easier to do registration for the whole thing instead of getting only a couple levels. But when I'm doing it in, a T2 to L3 and I need to do a couple registrations, much easier for me to freehand, the lumbar screws, and then actually use the robot only for the more difficult pedicles. So I agree with you. I think it is, important to do both, and it is a challenge. And when we talk about these things at PEDS meetings, we're having the same conversations. Like, how do we train people that they can still use this technology, be good at the technology, but still go to, we talk about going to global outreach trips all the time, and like, we're not going to be able to do those trips if no one knows how to freehand. So it's interesting.
You made another good comment there, is learning the technology or understanding the technology. I think a big fallacy of the robot is people becoming, again, letting industry kind of run the show in the OR. And I think if you're going to use the robot, you have to be a master at it. And I think what I saw in the last talk with Dr. TK posing a lot of questions is, what are you going to do when things fail? Forget the rep. Like, no offense to our industry colleagues, but you are in control. Everything is on your shoulders, and you have to know your platform cold, how it works, where it can fail, and how to troubleshoot it. And I think if you're going to go the route of robotics, I think that's the next level of learning and training that we do. Having the med student or resident put in a couple robotic screws and saying they can do robotic surgery is not accurate. So now we have a whole new world of learning to kind of go through when we do that.
All great comments. They're all great comments. And of course, I have to add a couple of my own. When we talk about availability of technology, okay, we are advancing forward rapidly. Okay, we know how the phone has evolved very quickly. Out in the education room is that we have navigation technology from new sources, vendors, and we need to have backup technology. When you talk about the airplane flying, there is backup navigation technology in duplicate and oftentimes in triplicate. Human safety is what it's all about. If you're going to have one, you're probably obligated to have a second or a third. And that was one of our arguments why we had a second CT scan 10 years ago, is that we had one, and I just said, if this thing ever breaks down, I need another one, so buy another one. We justify it. So anyway, I think it's time to move on.
He needs 5 minutes.
He needs 5 minutes. Okay, so we can pontificate even more, but we have a lot of, there are a lot of different levels, okay? And there are different institutions that are capable of supporting, various technologies that do cost a lot of money. And as I've always said, and, Danielle, you've heard me say, it's not just $1 million pointer. It has to do more than that, and we're evolving into that, doing more than that. I mean, that's where we started saying, okay, let's use different instruments. Let's be able to do this. Let's be able to do that. And then the robotics idea was an obvious evolution from that. So, Corey, you've been listening to this, but you're going to be participating in the next lecture. But you have any comments about the current discussion?
Yeah, I love it, and really great to see Cream integrating some of the stuff in his practice. He was a terrific fellow, and one of the things that was really great when he went through is he was always asking questions about how do I integrate this, and how do I think about when to use it, and what's the right time to use it, and when's not the right time. And it made me realize in my own eyes, I didn't know the answers. Like you said, Pat, it's just you don't always have the right answers. Sometimes you might do 2 different things on 2 different days. What I do think is going to be interesting, I just saw a publication of some folks using the robot to do decompressions and facet decortications. And this is only going to become more and more integrated into what we do, more than just putting in screws. And so how, that this is only going to get bigger of an issue as we look forward. What about when our fellows don't know how to do a laminectomy because the robot cuts it? This is going to be that's what I think is going to be really interesting as we look forward over the next couple of decades. But I think a lot of great thoughts. The other thing first of all, thanks for having me here, and you guys have put on an amazing conference. SSF is such a great institution and someone I have so much respect for. One of the things that bothers me is when I hear people say, oh, robotics, all it does is put in screws. And you listen to the talks this morning from these great folks who have put so much effort into mastering the nuances. Think about how many little details, from Dr. Skaggs's talk on the PARS repair to Martin talking about single position surgery. I mean, I think the thing to walk away for the trainees from this is there is so much art into this too. And the really, really good surgeons who've learned how to master and take advantage of this technology have put just as much effort into learning to use the robot as people have into putting in pedicle screws the right way. So I think we need to change the paradigm in how we think about using the robot too, and think about it as an art just as much as putting in screws freehand. So just my 2 cents.
Well, with that being said, now I get to introduce you, Corey. So we're starting our next part of the program, which is going to be a live demo with our colleague Terry Kim doing a prone lateral fusion and a PERC robot assisted fusion. And Corey was unable to make the meeting, but he's actually going to moderate the session. Are we getting pretty close?
No, I think maybe a few minutes, so I think we'll switch to the next virtual.
They're resetting the, okay.
Yeah.
So Corey, if you don't know, we actually had a power outage here, and we had to take an unscheduled break, so it kind of took everything off. So I think we're going to move ahead with Joe. Corey, you okay with that?
No problem.
Are you okay with? us rolling you to the next lecture? How's your schedule here today? I know that,
Yeah, as soon as I can do it is when Joe's done, that's fine, no problem.
okay, all right, well, that's perfect. Then we're gonna move on, and Joe Osorio is gonna give us a talk about incorporating robotics into deformity and spine tumor surgeries, which we're always a pleasure to have you, and look forward to hearing your talks. And Joe, thank you very much.
Wonderful. Thank you for having me. I'm just going to share my slides. It's always an honor and a pleasure to be able to join you all.
We have a little audio issue.
Hold on 1 second, Joe.
Yeah, we have an audio issue.
Just let me know if it's on my end. And do you see my slides by chance?
Okay, when you change slides, you had a massive amount of background noise, so, okay.
Can you see my slides okay there now?
Right, my introduction for Joe Osorio, another star from UC San Diego, is going to talk to us. Joe, thank you very much for being here.
All right, wonderful. Appreciate it, and appreciate the invitation to talk. I do use robotics in my deformity and tumor surgeries. So really my goal today is to give some tips and tricks on how I incorporate robotics and the workflows that I'm using in the operating room. These are my disclosures. So I just want to quickly share my adoption to robotics for complex cases. It did not start with tumor surgery. It did not start with deformity cases. I started with small cases. And you have to remember that as you work in complex cases, even if that's your primary practice, it is helpful to incorporate robotics first within a team environment so that you understand all the pitfalls and everybody understands exactly what they need to be doing so that you can be most efficient in complex cases. All these cases I've used robotics for. The top left panels, you can see this is a patient I had to do a revision on who had a prior Harrington rod. So fusion mass region, that's a helpful place to use robotics. If you're going to use it for scoliotic patients, maybe they have difficult pedicles to cannulate, that's helpful. Distal fixation, multiple points of distal fixation, I'm going to comment on that, and obviously others. So it's a way to improve the pain points that you may have for these more complex cases. This is simply a list of when I think about the advantages of robotics in general, and I know we're hearing about a lot of the different advantages throughout different specialties and applications today. But when I think about deformity and tumor, sometimes I need to really think about the UIV selection and making sure that a patient doesn't have a failure because of their bone quality or prior radiation. And so I want to make sure I spare the facets. I may want to make an incision that's smaller and do a transfascial screw. I could do that with robotics. I can use a larger screw if that's needed because I'm putting a lot of stress in an area if I'm doing an en bloc resection. I'm going to spend some points on pelvic fixation because it's something that's important in deformity, and I'll show you the 4 options that I use. And obviously abnormal anatomy is something that's super useful. So when you look at a case like this is a patient who I offered a T9 to the ilium, and I've highlighted here sort of the region that I would normally expose if I was doing open freehand, which I've done plenty of before I introduced robotics. Now with robotics, that incision and what I actually have to dissect is going to be smaller. And so at the top, in a case like this, and you'll see it in the video, I've spared the proximal tissue, and I'm simply showing the rod so you can see the length of the construct and sort of how it relates to the size of the incision. But if I zoom in closer into the image here, you can see I don't have to dissect that entire region, where in this case I used an S2AI screw. I can spare that distal dissection. That takes time. If you think about time, blood loss, small gains for big cases make a big difference. And you can see on the right side of the image, I've gone transfascial to spare that proximal tissue, which maybe could have an impact on my adjacent segment disease or failure. Also, in the upper instrumented vertebra, for these cases, not only am I sparing tissue, but I'm choosing the optimal screw trajectory. For me, often I may actually point that screw down, and some people feel like that is advantageous to prevent PJK and stress. So when we think about pelvic fixation, I think about it in these sort of 4 options. And so I may just put 2 screws distally. I commonly will place S2AI screws. I know surgeons out there that still use iliac fixation, which is fine, and they don't use it S2AI simply because they find it more cumbersome. That's much less cumbersome with a robot. What if you want to put 4 points of fixation, but you don't want to use maybe 4 rods? You can do that. You can plan to put them in line, and I'll show a case of that. This next case, sometimes I'll actually put 3 points of fixation whenever I'm doing a kickstand screw, or what I'll call hemipelvis distraction, and I'll put those up front. And putting 4 points of fixation actually becomes much simpler, and you can work around the pain points if you're planning it before you place the screws with a robot. So case like this, where you're putting 2 in line, this is what it looks like on the planning software. And you can see that the planning software doesn't have a head on the second S2AI screw, because this is not something that was worked into the software for this particular company, but you can plan it and it works really well. I mentioned the hemipelvis distraction, or the kickstand screw. Oftentimes, when I first started doing hemipelvis distraction, I would wait till the end of the case to understand. We now know what those parameters look like for deformity cases. A case like this, who has maybe a 7 centimeter coronal imbalance, if I lay her supine and it doesn't correct to less than 4 centimeters, it's very likely that with all my techniques, like this case, an ALIF, and maybe even doing a posterior column osteotomy and a bow type C, I'm not going to be able to correct that fractional curve enough to get an optimal correction. And so I need hemipelvis distraction. But let's say that when I put the first 2 rods in a case like this, I actually get the optimal correction. Then I'll simply use that screw and that additional rod as an accessory rod. And so this is a nice way to just right up front plan for that screw, optimize your S2AI trajectory so that you can fit that screw in additionally, and robotic helps with that. Okay, you can see what I'm doing here for these cases. She's coronally off to the left. You can see her spine and that angle to the pelvis, and I'm actually distracting the pelvis through that screw, really taking most of the stress and pushing that ilium down to get the coronal correction that's needed. When we used to freehand 4 screws into the ilium, I would often try to picture and imagine in my mind where those screws need to converge. And then I would often use a ball tip pointer probe and hope that those screws wouldn't collide when I was putting in that second screw, that they wouldn't kiss or touch. But you can see here, I can easily plan for that, and it's not an issue. What about what we're seeing more now these days is that patients, when they come in, they have sometimes SI fusion implants. What do you do about that? Well, once again, if you use robotics, you can easily understand if there is even a corridor at all or not. So I'll use robotics even just to plan and understand. For this case in particular, on one side, I was able to go around the implants. On the other side, there was no corridor. So I actually just drilled out the implant and then put a screw through that space. These cases, when we think about tumor surgery, there are some cases that are very, very challenging, I feel like. In particular, a sacral chordoma. These are cases where if it's a primary sacral chordoma, this 15 centimeters tumor that I encountered, you have to do an en-bloc resection. These are incredibly orchestrated operations with multiple type of specialty surgeons. I need a vascular surgeon. I need a plastic surgeon for a flap reconstruction. We need to do a colorectal surgeon to do a diversion. But when we do these cases, I don't want to worry about the screws. I mean, and on top of that, the reconstruction that you have to do has to be quite significant, because it's going to be, you're disconnecting the axial spine essentially from the legs. And so here's a place where I feel like you really want to be thoughtful and plan out your screws. It's not the crux of the case, but it's a very critical portion of the case. Taking the tumor out in one piece certainly is much more taxing, I would say. So for me, it takes a huge load off my shoulders if I can plan a reconstruction like this and use robotics to navigate around that. What about when you have to do a revision? It's very common that probably for deformity surgeons out there, that more than 50% of their practice is fixing other people's work. So when you're encountering a case like this, you're always going to review the prior work, and you might say, I need to redirect a screw. That often, without navigation or robotics, can be challenging. And so for a case like this that has a screw that's low and medial, you can see the tract here, I'll go ahead and plan around that. And when you have a guided system, with a robot that you can go in and do a tap through that entire corridor, you actually have a high success rate of going around that prior hole. You can see here the post-op films for that, where we've been able to move the screw that was medial and low and then bring it up and actually put it into the appropriate location. Pedicle subtraction osteotomies, it is to some degree a workhorse for your fused spine, especially if you have a fused lower lumbar spine where you're trying to get correction. In this case, I'm trying to get a 15-degree correction through L4. And one of the things that some of us do is if you're working with another surgeon, whether it's an attending, a resident, or a fellow, you often want to be able to be working together. So although they have to remove bone on their respective side, if you have a case where you're moving through and there's a significant amount of blood loss, and you're taking your time per se at the PSO site, it's helpful to be able to suction for the opposite side. And so one of the things that I do is right up front, I'll put my fixation, but at the PSO site, I'll actually use the robotic system to drill and tap screws per se that would essentially meet. I'm not putting in a screw. I'm simply coring out a corridor that will communicate from one side to the next. So you can see here, I've planned screw trajectories, but they're quote unquote colliding. And that's exactly what I want. So I used an 8.5, 60, and 65 tap essentially to go down this corridor. And what you can see here in the video, you can see on the right here, there's that you have L4, you have a block of bone, and you'll see me put in a hemostatic agent that basically communicates with the opposite side. So I'm putting in a hemostatic agent up front. I'm not going to do my PSO right now. At this stage, I simply have tapped the corridor. I'm going to put bone wax. I'm going to leave that hemostatic agent in. And then when I'm working with my co-surgeon, we're operating in at the same exact portion of that L4 level. And then I'm suctioning for him if it's needed, if they're having some issues on the opposite side or vice versa. So it's actually a very helpful, I feel like, tool and technique. And by the time you get to the PSO, because the hemostatic agent has been in there, it actually behaves a lot better from a blood loss perspective. That's the results from this case. Every now and then when you do tumor surgery, you will encounter cases that you might have not done electively. So I have a strict BMI cutoff of 35 for my elective practice, but this is a patient that came in profoundly myelopathic with a meningioma, intradural meningioma. I'll tell you that when you're doing a high BMI case like this, you want to make sure and you localize the level well. Oftentimes for tumor surgery in the past, what I would do is I would have the radiologist place a fiducial screw pre-surgery day so that I can go down and find the fiducial screw if it's in a region where localization may be a challenge. Now that looks different with robotics. So this is a patient, her BMI is greater than 45. I need to localize around the area where that red arrow is. I'm actually going to just use the robotic system to do that. So I plan the screws because for this case, I need to do a pediculectomy to get around the spinal cord. But it's really nice because what ends up happening is I mount the robot on the patient. I've planned my screws before surgery. I do the 2 x-rays for registration, and then I use the robotic system to locate where the screws and basically where the tumor is. I open up the skin, I do transfascial screws, and then I'm simply dissecting down. And now I know exactly where the tumor is, and I've placed a screw in an area where I'm going to do the pediculectomy. So it's already done part of the work for me. So it makes a case like this much more streamlined. So the workflow, as I mentioned, 2 x-rays for registration, transfascial screw placement, and now the screws are my landmark for where the tumor is essentially. And so transfascial, what I'm referring to here, this is where you just make a skin incision, you dissect quickly over the fascia. And this is the perspective from the right side. There's cranials to the right, caudals to the left. And you can see I'm going through incising the fascia, placing my cannula. And through the cannula, I'm going to use the surgical tap. And then through the tap, the system that I end up using is just a modular system where I just put shanks in, and that makes the exposure much easier because I'm not taking x-rays to find out where I am in the spine. I'm simply finding the screws and they're already placed by the time I go to do my surgery. You can see here in particular in my setting, when I'm working with a resident, I find it very valuable for education. Because what I often do is I'll tell the resident, the pedicle is essentially your field goal post. So if I'm going to do an on-block PCO, which is what I often will do for these cases, I'll show them where the pars is, and we'll just drill from side to side with the pars, and then we'll remove that segment of bone. So you can see I'm doing that here. So once again, I'm going to remove that entire section. I'm drilling where that yellow line is. So we're drilling across side by side, 2 drills at the same time, and we know exactly where to go and where we shouldn't go because the pedicles are marking that location. And to me, I wouldn't have done this if it wasn't for robotics. I usually would do this first and then place my screws if I wasn't using a robot. And so here we're just removing that entire block of bone that will be used for bone fusion, and it's particularly helpful to do an en-bloc PCO when you have to work on a degenerative patient and you have to open up the canal for a laminectomy. So once again, robotics being used here for modular applications, using the preoperative CT to place the screws up front. And then you can see these are the 3 different levels we did an en-bloc PCO. And then at the final stages, I simply just place on the heads. So what about when open lag marks are non-existent? I showed the initial set of many cases on one of the first slides where I did that for a Harrington rod. This is an achondroplastic patient. Once again, similar to a tumor surgery that I mentioned earlier, this is going to be a difficult case. If you look at that bottom right-hand corner, this person has had multiple surgeries, non-instrumented in an outside country. And so you can see pedicle fixation may be challenging, but that for this case was not because I used the robot. And so here I'm doing a 3-level vertebrectomy, making sure that because I need optimal screw fixation above and below, and it's going through smaller and more difficult corridors, I have them all planned out and I've been thoughtful before the case. And so you can see here, screw trajectories optimized, very medial, and in a corridor that's very small. So you can see here she's had a good realignment. I'm showing the T4 and L1PA for her 3-level vertebrectomy. As you know, with robotics, your implants are already selected. That's often, this is what my room would look like a few years back. And then now that we use the modular system and we have all the screws labeled out for these cases before in the heads, everything sits on a tray. And so it ends up being much more seamless for the scrub tech. And they really like doing that system in that way. So I'll just end there. In conclusion, I would say that the robot has certainly helped me tremendously, in particular on the ends of the construct. That's why I spent some time on the pelvic fixation. I use that basically for every deformity case. I think about the applications when it comes to tumor and deformity as what are the pain points? What are the workflow areas where the robot can help me? And you can see how I've sort of thought outside of the box when we've talked about the PSO and even localization. And then you can really focus for these cases on the part that is more the crux of the case, which may be the correction, the osteotomy, or the tumor removal. Thank you.
Joe, that's a great talk with incredible pearls, especially about the proximal and distal ends, that's oftentimes your challenge. I mean, being able to make this work and make it work better and elevating it is really what I think you pointed out here. You're doing great work, that's certainly for sure. Danielle, we ready to go in our? Okay.
Thank you.
Joe, thank you very much, and we'll have you back for certain. So we're keeping our program moving on. Thank you much.
Appreciate it.
We're going to move on with Dr. Terry Kim and Corey Walker. I didn't get to introduce Corey. No? No what? What's up, Ben? Oh. What do you say?
They said they're all ready. Maybe you could do that song and dance.
Ken Metcalf, I can always count on you. That's for certain. I could tell a couple jokes, but no, we're not quite ready yet. What's up, Ben? Okay. If they're not ready, we're going to move on to Dr. Ross. Kirsten, you ready to? Okay, we're pleased and honored to have Dr. Kirsten Ross, who you've heard her commentary a few times, and she's also been partially introduced, but she's a young and up-and-coming star from the University of Texas in Austin, and she's going to talk to us about her contributions, that's for certain, and where and how we're going to use it in pediatrics and her perspective. Thank you very much, Kirsten, and welcome.
Thank you for that nice introduction. Thank you to SSF for having me, for Dr. Kim for inviting me. Let me see if I can pull this up here. Can you show me how to share this? Also, it is a little bit staticky still. Do we know why that's happening? Okay. Did it stop? Is it working? Kind of. It is a little staticky. It seems like it has something to do with, oh, wait. Microphone's off. Is that better? It is better. It was because that microphone was there. It stopped, right? Yeah, okay.
I think we're off now.
Okay, cool. Again, thank you guys for having me. I am a pediatric orthopedic surgeon. I did not do an adult spine fellowship. I did a ped spine fellowship or a pediatric ortho fellowship and did a lot of spine. So my practice is a little bit unique. Since I am a pediatric orthopedist, I still, take call and fix fractures, but my elective practice is all spine. So that's why I was invited today. I started a robotics program at Dell Children's, which is our children's hospital in Austin, when I came out of fellowship. And it really was because I had just some really great training and fellowship that I was able to do that. So these are my disclosures. Objectives for today. We'll talk a little bit about what I think the indications are for pediatric surgery, and we'll talk a little bit about what other people think they are. And we'll just go through my OR workflow because it is a little bit different because the anatomy is a little different. Some pearls and pitfalls, and then just a really quick case at the end. So in the peds ortho world, at least, there is a really big hesitation to adopt robotics. Pretty much everybody is very skeptical. There are a few of us that have really adopted it and, gave it a big hug and love to use it. But there's a lot of people that were having trouble convincing of the benefits of it. Their complaints are that it's inefficient, that it is a big capital purchase for your hospital. The radiation exposure is a huge concern. Also, as we heard from Kareem, a lot of people just don't think they need it. They've put in a ton of pedicle screws in their lifetime, and they don't think that it's worth it. And then probably the biggest one is, the safety and accuracy concerns that you've heard about throughout this entire morning. And especially when we're doing this in kids, most of our scoliosis cases we have a pretty dysplastic pedicles, and there's really little room for error when we're placing these pedicle screws. There's a lot of safety data in the adult world, but in the peds world, our safety data has only started to come out over the past couple years. So we have, a couple high volume centers, not very many, but a few that have put out their safety data. And this one is the most recent. They retrospectively looked at, over about 5,000 screws placed in 334 consecutive patients at 2 high volume centers. So their complications, they did have 1 durotomy. They had 6 monitoring alerts, which were not associated with putting in the screws, and they were associated with correction. And then 62 breaches, which is only about 1.2%. And that actually, when you think about your freehand breaches and your rate of that, that's smaller than freehand. So they concluded that's an acceptable safety profile to use in the pediatric population. Same thing here. This was from my mentor, Boston Children's, Dan Hedequist. He looked at his experience over 3 years, 2019 to 2021. They had 1,467 screws attempted. They were able to successfully execute or successfully put this screw in the right position in 1,461. of those screws. So that's 99.6% success rate. And you guys that have done robotics starting in 2019 or before know that with the Mazor at that time, you didn't have the high-speed drill. So actually, all the failures of the screw placed were in type D pedicles placed lateral before they had the high-speed drill. So there actually was zero misplaced screws after the initiation of that high-speed drill. So what makes pediatric surgery different than what you all do? Kids are not just little adults. They do have, we're working with a lot of smaller anatomy. You know, a lot of the cases I do are on teenagers, but sometimes I'm doing cases on 3 and 4-year-olds for congenital cases, and that's very, very, very small anatomy. Most of my cases have pretty dysplastic pedicles. This is an example from one of my mentor's cases, but you know, especially on neurofibromatosis patients, there's no pedicles. And if we're going to try to get screws in, it's really difficult to do that freehand or even navigated. So, you know, to place those extrapedicular screws, it's robotics is really helpful. And then we're also dealing with rotational deformities. So most of our cases are scoliosis cases. Some of them are pretty significantly have a big axial deformity. And that sometimes can be challenging. For the robot, and there are some nuances with that, and you definitely, there's a big learning curve with that. So indications for use in ped spine, for me, if they need surgery, I can use a robot for it. So I really like, I love it for my AIS cases. For neuromuscular, it's also awesome. We run into if you're doing a T2 to pelvis, it can add a little bit of time, but that's where, as we talked a little bit before, you know, you can robot the parts that you want to robot and then freehand a lot of it to save you some time. Syndromic cases can be very helpful on, like I said, for like the neurofibromatosis cases, congenital cases. It's awesome for, especially if you have a platform that can easily go between robotics and navigation, because you can place your screws robotically and then navigate your like hemi resection, and that is really, it's a very powerful tool for that. Also, probably one of the biggest, when people have adopted this early, it's really high-grade spondy was like honestly the ideal case for this, because as you guys have said before, you know, it's really hard to get those freehand screws in for L5 and L4 when you have such a high-grade slip. And, you know, it turns a really hard case into a really easy case. And so in the peds world, people are starting to recognize that. And then as we heard from Dr. Skaggs, PARS repair is now kind of the newer thing that we're talking about, and some of us are trying. So my workflow, I do use the Mazor X with Stealth. I will say the workflow in peds, as with adult, is really variable. So if you ask me how I do my surgeries, it is different than Mark Erickson in Colorado, Dan Hedequist in Boston. And we all have kind of created our own little workflow and how we like to do it. The way I like to do it is I do my exposure. It does tend to be a little bit wider than a normal exposure if I'm just freehanding using nav. This is a point of contention when you do your facetectomies, because you know these spines are pretty mobile. When you guys are doing you know, adult deformity cases, that spine's a little bit stiffer than ours, and so when you're using robotics, you're a little bit worried that any kind of little pressure there that you put on it, if you destabilize the spine at all, it causes you to have more loss of accuracy. I've found that I can safely do facetectomies before. That's how I was trained, but some people will argue that you should do your facetectomies after. I then mount the robot to the patient. As we've talked about before, there's a couple options. For the thoracic and upper lumbar, I do the spinous process clamp. I do use a PSIS pin for the lumbosacral spine. That's just a video that's, one of the things that you need to make sure when you use the PSIS pin is that you keep it out of the way of your S2 AI screws. And then you attach your navigation array. So we've already kind of talked about this a lot today, but the way that I was trained originally to use the robot was we actually put the robot mounted array, and that's how I learned how to use it. After talking with other ped surgeons that have done this, Mark Erickson kind of showed me that when you put the array on the patient, it does add another accuracy check and definitely makes it safer. So I've started to do that. So when you're doing your registration with the Mazor, you have two options. You can do your intra-op 3D imaging with scan and plan with your O-arm or your 3D C-arm. It is easier, right? You just bring in the O-arm, you get your scan, and you have your images. However, then you have to plan your screws intra-op. So, when you're doing if I get a whole, one registration of the O-arm on a smaller kid, I can get, sometimes 8 or 9 levels. And that is a lot of screws to plan intra-op. And if you don't have a rep that is really facile at planning your screws, it can add 20, 30 minutes sometimes. So I really, I try actually to not do this protocol if I can get away with it. We do use a low-dose radiation protocol when we do the PEDS cases. Our other option is the pre-op CT to fluoro workflow, which I actually, there's not a lot of PEDS people doing this workflow because it is more challenging. So when you're doing it with a big curve, it's really hard to get the right shots. And there's a big learning curve of, the AP is really easy, but that oblique shot to make sure that you get the end plates on FOSS, it is really, really, really challenging when you have a big scoliosis curve. So I tend to use currently the CT to fluoro workflow for curves that are about 60, 65 degrees and under. If it's anything over 65 degrees, it gets to be a little bit more challenging. And then I'll just do the O-arm workflow from the beginning. There has been a couple times, maybe 2 times, that I've tried to do the CT to fluoro workflow, and I tried to push it, and I just couldn't get it to register. We took a couple different C-arm shots, and I just could not get it. So then we had to bail and do the O-arm spin, which in PEDS, I hate doing it because then I've rated them twice because I've already got a pre-op CT and then we're doing another O-arm spin. So I try not to do that. So I try to be really judicious and think about which workflow I want to use. The benefit of that, again, screws are pre-planned. So now we're ready to robot. This has been said time and time again, but I don't think we can say it enough. The accuracy safety check is really, really, really important when we're instrumenting a thoracic pedicle that is very small. So our safety check is using the chicken foot, just putting it on the spinous process since we're doing all this open at this point. Then I use the high-speed Midas. And this is also where we vary in the PEDS world of what we do. High-speed Midas, me and Dr. Hedequist do tap, and then we don't place the screw through the robot. So the thought process behind that is when you are drilling, drill tap, and then if you're still putting your screw in, we're getting such good bites on these screws that it torques that vertebral body and then rotates it, and then we're afraid that we're going to lose our registration. So the current way that we do it is we drill, tap, move on to the next level, and then put our screws in freehand after I do my osteotomies. I can't always get my level safely, and I know we talked about this a little bit earlier. Sometimes I feel like I maybe push it a little too far, and especially at the top levels, it's not exactly accurate. So this is where it is important I think it's important to, still have your freehand and your nav screws, that you can get screws at those levels if you still want to without doing another registration, because that does add time to your case. And sometimes then I'll just also use hooks at the top if I want to. So we've done the robot. I actually move it out of the way at this point. I take it off the bed. Then we do our posterior column osteotomies in the levels we want to, without the screws in the way. And then we put our screws in freehand. For my deformity corrections, I use all uni screws if possible, sometimes polys at the top. Okay, so now going through, some pitfalls and pearls that we have come up with run into along the way. So this is one of the things that we maybe touched on a little bit today, but I don't think we've really driven it home yet. Skiving of the drill in PEDS, and I think it just with this specific anatomy and the rotation of the spine, we run into this a lot actually. And so before the high-speed drill was introduced, it was before I learned robotics, but from my mentor. He was not a nav guy. He went from freehand to robotics, and he actually hated the robot in the beginning because he was running into so many issues with skiving of that slower drill. And kind of it changed the game for him when he was able to use that high speed drill. So what I mean by skive is, so when you put that sleeve down, especially I think in the adult world, it doesn't really hit the TP in the same way that it hits in the peds population, especially when it's rotated and you get like some deformity of that transverse process because of the rib. And so it's really easy sometimes when you put that down, it really does come into contact with it almost parallel, and it will change your trajectory if you put that sleeve down to like put too much force on that sleeve. So either one, you have to really prep your bone in that area first. Remember, we're doing this all open still. So you can just prep your bone and make it a flatter surface, or just pull your cannula back and then make sure that you are not having it interfere with any of the bone before you start to drill. He actually wrote about this because it was such a big thing and game changing for him when that high speed drill came out. I don't know if this is going to play. Let's see. This kind of shows a good example. So you can see like if you push that cannula down further, and I think this is where some people actually get into trouble sometimes with MIS if they don't know what they're doing. They run into some other bony prominence that they're not really expecting and push that cannula down. And it will change your trajectory. So what you have to do, again, if I make this play, you have to pull your cannula back up a little bit and make sure, we talked a little bit about this earlier, but we still have our haptics when we're doing robotics. People talk about not having haptics anymore, but we have, once you get used to this feel, it's just a different feel. So you have to really lightly tap that high-speed drill until you get your start point. I actually, because a lot of times we're going down these like really thin pedicles, I drill all the way down the pedicle, but I'm looking at the navigation screen and I'm making sure that I'm still feeling with my drill what I'm seeing on the screen so that I am comfortable with knowing that I'm not breaching. And again, one of the always things that we're worried about is our loss of accuracy, especially because of these dysplastic pedicles. The platform is not going to know if you moved, and you really, you must do your accuracy check before each screw when you're cannulating these like tiny little thoracic pedicles. So we just do that with a chicken foot. We place it on the spinous process. It takes an extra 2 seconds to do that in between each screw, and it's really helpful. This is an example of actually trying to figure out if you're actually off or if you just need to re-register your navigation. So this happened to me where the navigation actually was just off. I re-gingerbread man this instance, and it actually was more accurate. So once you feel like you're off, you again still have to go through those steps to check where exactly you're off, and if it's really is truly the navigation, truly the robotic robot that's off, or if it's just the navigation. One of the other things that we run into in peds a lot is the soft tissue impingement on the sleeve. When you're doing this MIS, we talked about you get that really big skin dissection, but then you're still going through the muscle. We still are doing it open. Maybe in the future, as we get better with our techniques, maybe we also will start to do a little bit of that. But right now, we're still dissecting the muscle away. And at the top, especially the top and the bottom, you really can get a pretty bad soft tissue impingement if you didn't do a good dissection carefully and have your retractors appropriately placed. So you can see here, example, that soft tissue obviously is going to change the trajectory of that cannula. So you need to make sure you're doing your dissection wide enough. If you're running into situations like this, we also will just do it transmuscular. I'll just put that muscle back where it was supposed to be and just do it, just through the fascia, or even percutaneous, like here when we do high-grade spondies is an example of that. We just do an entirely different incision actually and perk those screws. This also has been said already today, but you really must pick easy ones for your first cases, especially with bigger curves. That's just kind of a recipe for disaster to try those curves as your first cases. You must master the easy before you do the hard. This was my first case, super easy case, right? I don't need to do a robot for this case. But it just goes to show, like, these are the ones you have to do over and over and over to get really good at the robot before you can do the hard cases. One of the things that I think is different in peds is we do use a lot of uni screws. And so when you're doing this freehand or navigated, it's a little bit easier just to like have them line up because you're doing one sequentially after the other. When you are planning a robot plan, it's harder to see that. So how I do it right now, I will plan the screws and then I'll actually go back through each level and make sure it's not more than 1 or 2 degrees off from the AP plane from each other, because then it just becomes too challenging to get your rod reduced. So that's one of the things. The Mazor software, I know we already saw this video earlier today, but the new software will make it a little bit easier to tell when you drop your rod which screws aren't going to be lined up enough. So that I think is going to make it a little bit easier to make sure our screws are lined up okay for these bigger constructs. And that just goes to show, as these platforms get better, it's going to be easier for us to do these bigger surgeries and more facile at it and just more efficient. So really quickly, this was a case that I did that I think highlights how these screws can be so much better than just freehand or navigated screws. This is a 12-year-old girl. She was never braced. She came to me like this. She had 51-degree right thoracic, 56-degree left lumbar curve. I was able to do a CT to fluoro on her, which helped our efficiency. So these are her bending x-rays, our supine x-rays, structural curve. So my plan is to do T3 to L3 with some thoracic posterior column osteotomies. Like I said, I did it to CT to fluoro workflow. I did it with 2 registrations, actually. I did every single screw robotically in this case. I do use patient-specific rods on all of my AIS cases, and actually at this point, most of my neuromuscular cases. And it's really nice for those cases as well. I use 6.0 cobalt chrome, and I get them differentially contoured. So on my convex side, I do -5 degrees of kyphosis, and my concave side, +10. And so my left rod in this situation was 40 degrees, and my right rod was 25 degrees of kyphosis built into that. So actually, when I placed my screws and dropped my rods, I dropped both rods at the same time, and then I used my reducers to pull the spine to the rods. And basically, with my differential contouring, it just derotates thoracic for you, which is really nice. I segmentally derotated the lumbar levels only, and I did a little bit of distraction at L3 just to get the L3 level. So basically, I did really minimal work after my screws were placed for this. I really didn't fidget with it that much, and this is what I got. And so I think this case, I really do believe that the robotic screws that we're putting in are just they're the optimal screws. And this is all very anecdotal. I don't have any evidence and data to support this yet, but I think these screws for pediatric deformity are so much more powerful, and we're going to be able to get so much better correction with them, especially when we're utilizing it with patient-specific rods. It basically makes our workflow optimized, and it makes everything more reproducible. I think peds deformity still is a little bit of more of an art and not so standardized as maybe adult deformity is. And this is moving towards standardizing it all. So future aspirations for me. Now we're talking about doing radiation-free robotic spine surgery with synthetic CTs that are now commercially available recently. I think this is really what's going to move the needle in pediatric spine for robotics. Once we can actually do these surgeries with very little radiation, basically only 2 C-arm shots, if I could do an entire construct with 2 C-arm shots, that's pretty incredible. And I think that's what's really going to get the pediatric surgeons to adopt this a little faster. So in summary, robotic-assisted spine surgery certainly does have a role in pediatrics. I think as these platforms evolve and we have more pediatric input into how the platforms evolve, it's going to become even more adopted. There is a little bit of a high learning curve because of the special nuances with the peds anatomy. So you really want to make sure you're thinking about those pitfalls that we went over. It is, at this point, we have proved it's safe and accurate. And so some of the peds deformity surgeons just kind of need to get over that aspect and saying it's not, because it is. And, radiation-free scoliosis surgery is probably here sooner rather than later, and I'm really excited about that. So thanks to Dr. Dan Hedequist, he gave me a lot of the pictures and videos for this talk. Here's my contact.
Real quickly, Kirsten, how are you managing blood loss for these patients?
Yeah, great question. So I use Aquamanus, and so when I trained with Dr. Hedequist, he is like a stickler about like if there's a cell of blood, you better be Aquamanusing that. So I use Aquamanus like very religiously, and I mean we still, kids bounce back a lot easier than adults. And so blood loss, like you have to be cognizant of it, and especially on the little kids, but it's not as big of a deal for their recovery. We also use Cell Saver in every case, and we're always giving them Cell Saver back. So I very rarely have to transfuse anybody. But Aquamanus, I think, is the key to that. Yeah.
Kirsten, I just want to say how impressed I am at how you have adopted all the new technologies. I know a lot of pediatric folks, Dave Skaggs included, and you are so farther ahead in all these enabling technologies than they are, and it's kind of crazy, interesting, exciting. I have kids, so to know that, this is slowly being embraced by the younger generation, I think this is really like take it and run with it, because you're going to be one of the few, I think, in the country that really master this and can speak to a different level. That's kind of the way Pat was when he did when he was using nav and stuff like that. So just keep going.
Thank you.
My biggest question to you is, you harp on accuracy, so important, accuracy. But the last part where you want it to be accurate, you're putting it in freehand. Like, explain that
Put the screws in free-
dichotomy. With freehand. Like,
Yeah,
I
no, it's a
understand the
great-
issue because
Like
it's
one up the
hard.
line.
You're torquing the spine. You
Yeah.
don't know. But like, to
think-
me, I feel like that's missing the point.
Yeah, no, that's a good point. And so I think I said this earlier, I did not use any technology when I learned how to put pedicle screws in. So like, for me, like the tactile feel of putting in a screw, once you have your hole, like that makes more sense to me of actually knowing where I'm putting that screw. So when the way I do it, when you drill and tap, I do pretty much tap to the end of that. And one thing I actually didn't mention is I use the ball tip probe, and I feel like every step of the way to make sure that I don't have a medial breach. If I do feel like I have a medial breach after I've drilled or after I've tapped, I either will redirect it, or sometimes I will just skip that screw because we don't always need a 2.0 density construct, or I'll use hooks. If it's at the top, I'll use hooks. But I am feeling with the ball tip every step of the way to make sure that I'm not medial. And then to put the screws in, yes, we can put it in through the robot. I actually feel like, especially with those in screws, I think with the robot, it would be easier to skive lateral, actually, and misplace that screw rather than me putting it in freehand and having that tactile feedback of like, I know this is going in the right spot. I mean, that's also just in my hands, because that's how I'm used to putting in difficult screws is with like, I don't use power. I've never really used power, and I feel like I lose the haptics of it when I'm using power. And so for those in screws, when you're, it's really easy if you don't get it in that exact spot, that screw will hit the body and then just skive lateral. And so I find it easier to actually put it in freehand when I know my trajectory with my ball tip probe. I can see that. I'll pull it out and just stick the screw in. Also, over a guide wire is not a terrible idea too. We will do that sometimes.
Yeah. I've lived this adventure before, and one of the mistakes that I learned the hard way was with the sharp tip screws.
Yeah.
So using a blunted tip screw, if you're already tapping, you already drilled the hole.
Yeah.
Your screw's going to go where your hole is, where
Yeah.
you tapped it.
Yeah.
Unless it's sharp and it's going to cut through where you did. So when I'm doing the kind of thing you're doing. The other thing I really liked, and I think it's an important point, to drive home for the other attendees, is when you're planning out your screws in this pre-planned manner, you're measuring the angles. If you put your screws at both levels at the same similar type angles, you said 2 to 3 degrees apart from itself, when you lay down your rod, once you've done your fascectomies, the bones will come to the center, right? It does it on its own. So you don't need a pre-contoured rod unless you want to use that for your own ease or convenience. Like, literally, it will do it. It will come there. And so I think that's a really critical point, and I'm glad that you made it and just wanted to reemphasize it for the attendees.
Thank you.
Kirsten, thank you very much.
Thank you.
Excellent talk.
How do we get out of this?
We're going to keep moving, but I'm going to make one comment.
Yes.
Someday somebody's going to give a lecture about costotransverse screws and if, when, and how robotics is appropriate there. Because I put them in a lot of people, and in fact, I just had a patient the other day that had a fracture in the thoracic spine, and I put in those kind of screws, and I couldn't do it with the robot, even with all of our caveats that we have learned here this morning about precision and to do it to perfection. Costotransverse screws, which some people, that's all you can put into them. That's it. And pediatrics is a place where that happens. So anyway, I'm going to listen to myself and shut up and move on. We're going to get back to our demo with Terry Kim and Corey Walker is going to moderate for a while, and then we're going to keep going. So Corey is a recent addition to the Cedars faculty a few years ago. Did his training at Barrow Neurologic Institute in both neurosurgery and spine fellowship. And Corey's a great addition to our program. Terry, take it away.
Can you guys turn up the volume for Corey? Can you turn that volume up a little higher for Johnson and Corey? Corey,
I can hear you great. Yeah. And thank you so much. I have a hard stop at 11:30, so I'm going to try and get through the first bit, and then we'll I'll jump out and let you take it from there.
Sure.
We'll take over for you.
Corey, just want, while we have you then, prone lateral, tell me about your experience and why you adopted it and why it's so great compared to single position lateral fusion or staging them, flipping them. What's your kind of general consensus viewpoint right now?
Well, this is something that I really adopted after graduating. And we're still in its infancy in terms of people thinking about doing it when I was finishing training. And it really came with, and Alpha Tech is our supporter, so we thank them for coming that. But I think it really has grown with the company adoption of building up a technique that allows you to have the versatility of being prone. So you can do all the things that we do naturally with all of the other spine surgeries we do prone. So doing decompressions, fascectomies, placing screws, every other part of the procedure is done prone. And so being able to do that and also being able to, at the same time, without changing positions, get a great interbody fusion. And, I've always been, taught by, Juan Uribe, who I trained with, and the guys in San Diego, Bobby Slack and Greg Mundis, like the values of lateral. And so being able to do that and having the flexibility of working back and forth while being prone was something that I saw really to be super valuable early in my practice. And so I thought that it would be worth taking on the learning curve of learning how to do surgeries prone. And simultaneously, the companies were building and developing the technique better. And so what you'll see today is Dr. Kim performing a lateral interbody fusion in the prone position. And, I think that's, where I saw the value early on was the versatility. And, there's a lot of stuff talking about the added lordosis and some of these other things. But for me, it was being able to work back and forth. So, when I typically do these procedures, I like to, for typical degenerative cases, place the screws first using navigation. This is a robotics lab, so often I'll do this with robotics. I love to do them percutaneously, which often goes hand in hand with what we're doing. And then using that navigation after the screws are in to plan my incisions on the side. And so that has been a change in my workflow from how I trained. If you go to put the inner bodies in after and use the navigation first, you're going to change your anatomy. And so you're going to be inaccurate when you go to place those screws. And even if the few millimeters of height restoration from an inner body can change your accuracy enough in placing the screws that you could have a bad screw. So I like to place the screws first and then do the prone lateral, and then come back and do any other sort of work I need to do, facetectomies or decompression rodding after the laterals are done.
Can you raise his volume up?
That's as much as we can get out there.
Okay. So Corey, did you talk about the lordosis too on prone positioning and trying to achieve maximal sagittal alignment?
Yeah, I think it's our paper showed that, and when I was early on in the experience, and several other groups have validated this. I mean, there's no better positioning to get lordosis than with the patient on a Jackson frame with their stomach sagging, and we're always trying to achieve the maximal lordosis. And I found that doing these positions prone, it's almost it's changed how I choose my inner body. Almost always at 4-5, patients are getting 15-degree implants, which really caters to kind of our goals of trying to get enough lordosis at the bottom of the spine. And I think that definitely there's a benefit there.
Sorry, Craig, I think you cut out there. So anyway, let's kind of go through a little bit of the prone lateral setup, just as Corey was saying. When you're doing this kind of setup, it's pretty straightforward. If you can see from the top, this patient is in the prone position. We have these bolsters that typically angulate the spine out laterally, or angulate the spine, just like if you were going to jackknife them on a lateral approach. But the actual bolsters of the AlphaTech system allow the spine to open up for your entry point, so it pulls the ribs and the pelvis out of the way. In this case, we're doing L3-4, so we don't have to kind of open it up too much, but it gives that nice access. On the other side of this is a bolster on the contralateral side. So as we're potentially introducing instruments, we're doing disc prep, we're pounding in the implants and whatnot, there's a nice backstop on the other side that prevents it. So you could do a prone lateral on a regular Jackson table, jerry-rigged with tape and everything like that, but this table itself really secures the chest, the pelvis, angulates the pelvis, chest out of the way so that you get a good access point and a nice backstop to get it done. So prone position, pretty straightforward. And again, all these AlphaTech retractor pads and everything fit on a traditional Jackson table. So you're not buying a brand new Jackson table. They're just a little additional equipment that you add on. So I'm going to have Cameron take us through some of the screws that are just the standard screws. So screws go in first, because as we all know, once you start changing the orientation of the spine, you're going to change navigation. So Cameron, if you want to come in here and start it off. So let's bring the camera. We've already done trajectories. Is there a camera that can see the navigation screen? Good. Let's get to the plan.
Yeah, I want to go to left L3 trajectory.
Yeah, show them the plan. So this is our plan, and we did something interesting. Cameron was kind of pointing out that you could potentially try to minimize your screw trajectories by having the tulips kind of come out at the skin level at the same time. So this is not ideally my trajectories, but in order to kind of get really small incisions right at the skin level, the software allows you to calculate that, and what you see are those yellow and blue circles on either side. Those are the skin level trajectories of where the screws go. So if you line those up pretty good, you can imagine that you just make a little stab incision in order to access both. And then on the screen to the right, or at least on my right, as we're scrolling through. This is the part where the robotic reps are great at getting the initial trajectories all laid out for you. But then you tweak it, you understand it. On that axial cut, you see that we're trying to be as far lateral away from the facet joints. I actually, in my practice, I go even farther lateral because that soft tissue envelope does go over the facet joint. Yeah, exactly. And I toe it in even harder, especially at the proximal segment. Another trick that you do with this is on the sagittal or on the lateral, you start low and you kind of angle up north a little bit. And that again pulls you out of the facet joint. And this was taught to me, I think, from Dave Polly, originally from the nav stuff. Not super superiorly the up trajectory, but you, in order to really get out of that facet joint as much as possible, you're angling north, you're medialized, and you really get out of the way of the facet joint, the soft tissue envelope. And the screws look a little wonky on the x-ray, but this is why you're doing it. And this is, we're so used to the old MIS ways where it's like, you know, pretty straight in, abutting the facet, but on bone CT scans, the screw doesn't get in the way, but the facet shifts. It goes superior caudal cephalad, it goes medial lateral, it moves. And I imagine if you're too close to those facet joints, you're gonna have a problem. So this is where robotics is really making that difference. Now on that yellow screw, you can also see, sorry, if you go back on that yellow screen, you can see that you're kind of close to the medial trajectory or the medial breach. So you want to toe that a little bit lateral. Yeah, see that? You want to kind of bring that screw tip away from that lateral recess. And if you have to just slightly lateral breach, I'll take a lateral breach over a medial breach any day. So again,
Harry, I would add, you know, remember that these robots were tested to be within a millimeter of accuracy, right? So if your screw is a millimeter away from the canal, you better move it 1 millimeter away, right? Always think about your safety factor of what all these are. They're not perfect, so I think that's a really good point. Always just give yourself a little freedom. Err towards the side that's safer. That's a really good point.
And the blue screw also, you want to just toe it out laterally a little bit more. Just make little micro movements to get it out of the way in that way. So then we're just going to put one screw in and then go to the lateral. Cameron, go ahead. So yeah, once we figure out the plan, you send it over. This is something, Donnie already did this, so it's kind of a reiteration, but we just wanted to show you in practice. You bring the rod to the actual pedicle screw level of L3. You make the stab incision, which has already been made from previous exposures.
Is the knife back?
This then, Cameron, if you want to look this way so you can get all the glory and all the glitz. Okay, so Cameron has the balls pointing towards the camera, and we see that the alignment or the trajectory alignments are all very good. This surprisingly is the same cadaver we used on the last case of Dr. Drazen's, and what you realized, this is the drill going in, but what you realize is at the end, Dr. Drazen lost his accuracy. All we had to do on this same cadaver, because it's a preoperative CT scan, all we had to do is get 2 fluoro shots, AP oblique, and then we reset it right back to the ideal or perfect trajectory. So not hard if you lose registration, to Dr. Drazen's point. If you know, a low threshold, especially when you're CT fluoro matching, if you're feeling like the accuracy isn't quite making sense, to just have X-ray come in. The other part of workflow disruptions we learned with navigation is the other people around the room, the X-ray tech, the anesthesiologist. In these kinds of cases, the X-ray techs, in my opinion, in a very respectful way, have some form of ADHD, and they cannot stay in the room for more than like 3 minutes or 3 seconds. And after they get their X-rays, boom, they're gone. And you're like, so I intentionally tell them, I say, stay in the room, don't leave. You're an integral part of this process in case we do lose accuracy, and they still leave, but at least I tell them not to. So in a couple seconds, Cameron got the first screw in. Our average screw time is, 30 seconds or whatnot per screw. And it's everything with the Mazor X Stealth Station, as many users have used, and why it's so popular is everything is quick, very easy. It's very software plus. Those guidelines that we talked about, the 10 millimeter depth stops, Medtronic has actually made custom or drill bits now that are go only 10 millimeters, so you don't have to plunge it like Dr. Drazen did 40 millimeters into the vertebral body. It will actually physically, there's a little build-in where it stops at 10 millimeters, and I think that's going to be the future. So in the interest of time, we're going to skip these screws and go to the prone lateral. Can we get the cameras rearranged so that we're looking down the chute? I think it was a movement of this one.
Because it's such a small area and it's going to be easy.
Yeah, here he comes. We'll just keep shifting in and out maybe and see if we can make it work. It may or may not work. So, thank you. We're going to try to give you a bird's eye view over the shoulder of the surgeon going in. It may or may not work, and if it doesn't, that's great. There are technologies such as the Vision camera that feed into the actual retractors. We tried to get that for today to really wow Dr. Drazen and Dr. Johnson, but we were unable to get it, so sorry, guys. Okay, Cameron, have a seat. So this is Cameron's second time doing a prone lateral, and that's enough to get him ready for next week when he and Dr. Escuian do their prone lateral. I would say that when you're being taught, listen to the manufactured recommendations. They tell you very specific things about where to make the skin marks, where to make your skin incisions. Typically, Corey, go ahead and keep going with it if you can, if you're still here. He may not be here.
I'm here. So yeah, I like to, I think there was some early discussions about, whether to plan your incision more posteriorly to allow for gravity drifting forward. And so, I think that the key is I still use the perfect midline entry point, and I try to plan it right in the center of the disc. So I make a single dot either with my navigation or lateral fluoro to make that entry point.
Right. Our fluoro machine is kind of wonky right now, but the same thing, you just make a lateral incision over the center point. You go in, you show the camera. If you can zoom out on the camera looking at the procedure, maybe make a 2 window. Can you split screen that by any chance? Hold on one second. Yeah, so you can show that camera, the instrument that you're using, Cameron. So this is the initial dilator that goes in. It's got a guide wire attached to it. So it eventually, the guide wire comes out. This is what you stick into the disc space. But this is the initial cannula that you're introducing in. It's so, I don't know if, right there, yep. So you can kind of adjust the depth of that guide wire. Initially, you want to insert it. What you're seeing, that little white dot, is the neuromonitoring. Corey, do you use a lot of the neuromonitoring for AlphaTech instead of the house neuromonitoring?
Yes, I do. I think that, there's 2 components that are super important. You need your triggered EMG to make sure that the plexus is behind you. That's the part that goes through your dilators and allows you to basically localize that the plexus is stimulating at a lower threshold behind your dilator so that you know that the plexus is always posterior. The other part of that is AlphaTech has some proprietary saphenous neuromonitoring, which allows them to do saphenous SSEPs during the case. And that gives them basically a sense of the live ongoing health of the nerve, which is, so important, especially if you're doing 4-5. I've had several cases where we're at about 10 minutes and you start to see a drop of signals, and it indicates, hey, you're a little too much stretch on the nerve for a little too long. close down your retractors, give the nerve some breathing room, let it get some blood flow, and then finish it up and continue. So it's been a huge add in terms of me feeling comfortable at the safety, especially at L4-5.
And Corey, respectful of your time, it is 11:30. Any last things on prone lateral before, or anything that you wanted to highlight before you head out?
Well, I just think that, it's going to take a little time to learn this procedure. You always have to remember when you're dilating and going through the psoas, and you got to remember all the same core tenets of doing any lateral surgery. I like to make sure you're always protecting your dilators and keeping sure that you don't have any sort of visceral injuries during the approach. And once you're down, it's the same procedure. So, the key is take the effort to learn it. It'll be worth it in your practice to have that versatility. And I think it'll make you a better surgeon.
So can we get a view of the fluoro machine with one of the cameras? It was the same camera that was looking at the nav computer. Or right. Okay, great. So there's our pedicle screw in there. And then obviously this is the dilator, and we're going at the L3-4 level. That's the AP, and then we show a lateral. So do we have the, give that to him right here. And then if we can split screen that lateral, that X-ray, and then the procedure that we're doing. So that camera that's looking at the actual incision. I feel like I'm a Hollywood producer. Yeah. I was watching The Fall Guy on my flight in. It's a great show. So great movie. So we're the dilator is in. We're trying to another X-ray right there, saying that we're pretty close to the center mark originally, and that's where then we'll deploy the guide wire. So, and just kind of, Cameron, rotate your body so the camera can see possibly. Probably not.
Can I tap that?
And then we just tap the guide wire straight through the dilator in. Okay, take this off. Try to keep the guide wire in place, good. And then we have, show the camera. Show, here, take it. We have serial dilators that are working on just in the standard lateral axis way, so throw that dilator on.
Terry, last comment before I jump off. One of the really nice things is this is probably more anterior than I would normally dock, and in a traditional kind of way when I was using a 3-blade retractor, but with the 2-blade retractors that they have, what's really nice is you can kind of enter a little bit more anterior in the psoas and then titrate with the 2 blades how far anterior posterior you want to be. So if you enter a little bit more anterior than the exact 50-yard line, that's okay. You just open a little bit less anteriorly and a little bit more posteriorly. And likewise, if you enter, all the way back and you're still anterior to the nerve and you need to make all of your opening with the retractors anteriorly, that works too. So I think having that 2-blade retractor is really nice because you can kind of titrate where you are in the psoas and make sure you're exactly where you want to be.
Marcus, you need to move so they can see things first. We're not ready for that yet. You're 3 steps ahead. So, sorry, the audio is doing that wonky thing again after. Must be all the rain and the electronics. After the dilators are in, we put the actual retractor.
Let's get do you have the handle for the retractor?
The bare handle?
No, we have the handle first. Yeah. And you want to kind of make sure that we're in the right position now. Okay, so go ahead and attach it. So now we're going to get the actual final retractor over all those dilators. It's going to secure in place. But in order to do it, we want to make sure it's orthogonal, so don't tighten it yet. Let him be able to adjust things. Okay? Okay, so just light adjustments. Go ahead and get an X-ray there. Okay, so we got to get, Marcus, you put this on too early, man. Take this off. No. Okay. Technical difficulty. Okay, let him get the actual, remember the triangular shot. X-ray there. Okay, and then you want to lift it up a little bit.
X-ray there.
Try to find that perfect view that we had before. When we talk about the fiddle factor, this is a little bit of that fiddle factor where that's a pretty good shot, right, guys? Yep. Logan?
That's even better. You can see the cutouts on the sides.
Yeah, the cut. So there's two parts. There's triangles, which are right there. And then the cutouts, which are here and here. So Logan, can you help him adjust it a little bit more? That'll tell you that you're on FOSS with the actual X-ray.
Put your hand up the floor a little bit.
Just a little bit. Too much movement. And these triangles should all, and the notches should all be clean and open. So you lost, hold on, you lost, no. You don't move, you're 0-0. He moves, not you, yep. Good, it's better. And then we make a little adjustments towards the posterior. Okay, X-ray there, little micro, okay, so that's about as close as we're gonna get right now. Okay, Marcus, now go ahead and attach it on. Okay. Danielle, our producer, is telling me 5 minutes, so we're almost there, Donnie, I promise you. We're coming in. Burning plane, landing.
Easy. Okay, that's probably good.
Okay, that's good. You get an X-ray there. Nope, that moved, so don't try to tighten it too hard as he's getting you to the right position. Get an X-ray there. A little bit towards the posterior, so lift your hand up as you're doing it, towards the head or ceiling.
Yep, X-ray there.
Towards the ceiling. Yep, like that. Good. Lock it in, Marcus. Good. X-ray there. Excellent. We'll take that for now. It's not ideal, but you come to an AP.
Yep.
I think from a standpoint of prone positioning, I think that's the hardest part, is getting that retractor in its right orthogonal trajectory. And we can see that there's still a little movement that needs to be done towards the feet, just a little bit, like that. X-ray there. Okay, good. And we'll take that for now. So then we take off all the retractors. No? Yeah?
Yep.
Yep.
Do that, and then before you put it in and
Right. Do you want to click it up open too?
Yep.
There's, like all the other retractor systems, the Alphatec recommends 6 clicks, 3 on one side, 3 on the other, for a total of an 18 millimeter window. What's nice about the Alphatec retractor as well is we call it a crab walk, or walking the retractor. So let's say, to Dr. Walker's point, we're too anterior. If we look on the actual if you look on the actual retractor, move that out of the way for a second, there's an A and a P on the retractor system. So if you wanted to go more posterior, you would click that posterior 3 clicks, and it would just walk up the spine. It would open up your retractor direction in a directional way. And that's very useful depending on where you want to be so on and so forth. So we've done 6 clicks to open it up. We like our position. Then we secure the actual retractors with disc shims. These are, you show the camera the shim right here. And those are sharp ridge. They embed into the actual disc space itself. So we'll go ahead and place that. It's based inside the retractor. There's a little mallet. This is what secures the, get an X-ray there. Oh, we have to be a little bit south. Okay, we have to be a little bit south. Yep. X-ray there. That's a little bit too noted. Yep. It's a big osteophyte right in there. Yep. X-ray there. Good. Keep malleting it in. Excellent. And you take that one out with the gold button. And then get the second shim. Yep. Mallet. Put that in. Mallet. And again, as we're seeing it, this is all done from a prone position. There you go. Good, take that out. And what the 2 shims do is we call them like end zones or goal posts. The top shim in the posterior, the lower shim in the anterior sets your 18 millimeter disc prep space. The psoas has all been removed. We put the lights in, and I don't know if the camera can see down the tube, but it gives you this wide working space that's very rigid and stable, and you work within the goalposts. So then from this goalpost position, you give him the knife to make the annulotomy. And I think from an ergonomic standpoint, Cameron is sitting, which is nice. There are opportunities actually that AlphaTech train you where you turn the whole patient 30, 40 degrees or 45 degrees or tilt. So that you're a little bit more standing if you're not a sitting kind of surgeon. But, now 15, 16 years into my career, any opportunity to sit is probably a good thing. So then we make the annulotomy. We use the cob to go across first to release and then this becomes the lateral disc prep, which everyone knows. It's very straightforward. There's nothing new about this process. Can we show him the x-rays, show a view of the x-rays, or is that not possible to do both? X-ray? Oh, the x-ray camera. So the floor shots would show the cob slowly marching across the disc space, releasing the annulus on the other side. Huh? Okay. I think we're trying to get that view down the shaft. It won't go down any further? Okay.
Can we raise the table? Oh, I guess.
No, the table doesn't go up. Oh, it's like we're 3 inches away. We could probably rotate the table. Can we rotate the table with the robot? Either way, okay. That's fine. That's fine. If you can just show the x-ray screen. So we're almost done here. Then once the cob goes in, you take the cob out. We put the box cutter in. X-ray? Is that the box cutter? Yeah. Okay, great. This box cutter is great. It basically removes about 50% of the disc. It's a cutting edge. The flute, the insertion point of it is sharp, so it kind of cuts the entire disc between the goalposts, and we go all the way through, and then you remove it. And usually there's a lot of disc material, show them the disc material. There's a lot of disc material that comes out. We already did a little bit of discectomy before, but that we pull that out. There's different, AlphaTech provides all these different instruments, including rasps, rakes, curettes, and we go in and go ahead and finish the final disc prep before the graft insertion. Do you have the trial space, the trialer? Okay, Good, we have that. That fluoro shot is the box cutter that's going through. And then we put in the trialer. Yep. Go right in, give him a mallet. Yeah, go ahead and mallet it in. Okay, get an X-ray there. Keep going all the way through. You see the spine deflecting or moving, and that's why we do this second. And yep, the hole is measuring the distal hole to the proximal 3 holes. That's 40, 50, and 60, and so you can go ahead and pull that out. You can measure it, and you can say within the trial itself, so to my eyes, that would be about a 40 millimeter graft would be ideal. It's the second dot. You pull that out, and then we put in the final trial. Okay, that comes out. And then the trial is a standard. AlphaTech offers PEEK, titanium, expandable titanium cage options, and we insert that in. Go ahead. Yep, beautiful. And then all of differing lordosis, and their implants are more lordotic because it's the prone position, which again is ideal because you can never get enough lordosis. And so now the actual cage is going in. Yep, keep going. You see the radiographic marker on the other side, all the way in. And I always go a little bit past midline when we're done and keep going. Okay, so that's the prone lateral. I think, when Martin Pham was talking about a 2-hour endeavor, this is how it gets done. I think in many ways the prone lateral is superior than the single position from a lordosis standpoint, from a screws being towed out. Remember, Dr. Pham was talking about not being able to tow out those low screws because of fear of hitting the bed or being unsterile. You have a completely natural, ergonomically natural view of doing everything.
Lateral real quick?
Oh, yeah, and then come to a lateral, obviously.
Oh, sorry.
Cameron wanted to make sure everyone saw the lateral. Make sure, can we take this off? How do we take this off?
Got it.
And we'll see if we can get a nice lateral before we finish it. And booyah, that's beautiful. Nice job, Cameron.
Cool.
You're ready to do them next week. Take Dr. Escuian,
right?
Take Dr. Escuian through it. Okay, guys, thank you very much. Yeah, nice job.
Once you get it, it's 3 months, right? Because needless to say, those are gonna coincide. These wings, you're gonna twist it all the way until you get to that point, to lock.
Gotcha.
That's what's gonna lock it in.
Okay. Cool.
Yep.
All right, you're good to go.
All right, thanks, Dr. Kim and Cameron, appreciate it. We're going to move on. Our schedule's a little bit twisted a bit.
How we doing, Ben? Another electronic issue.
This is the tech conference.
Right. It's been fun for me. For sure, of course. It's like what to do when the robot doesn't work, right? What to do when our AV stuff doesn't work.
Yeah, so we're gonna just have a slight change in schedule. We'll start off with Dr. Galizzi, and then we'll go with Dr. Gold, and then we'll try to finish up with Dr. Manista's live demonstration, then have lunch, but see how Ben feels if we need to push off and have lunch and then go back to the demo, whatever will work best for our workflow. But I'd like to introduce Dr. Galizzi. He's in Vail, and he's an awesome leader in robotic and endoscopic spine surgery. He was here last year and was able to give us pretty much a first ever percutaneous robotic assisted posterior cervical fusion. And he's been doing them now for a little bit. And so this is an honor to have an update all the way from Vail. Thanks, Mike.
Yeah, thank you so much. And, really, you guys can all hear me?
Yep.
Perfect. Thank you guys so much for inviting me back. And, just want to say thank you again to the Seattle Science Foundation, Dr. Drazen, Kim, and Johnson, just for allowing me to kind of give you our experience here on doing posterior cervical instrumentation with the robot. It's been a very good adventure in expanding the indications. And I just kind of wanted to share my PowerPoint and sort of go from there, and we can kind of talk through some of the evidence and stuff on what we have and some cases that I've been doing. So let me go here and start the PowerPoint. All right, y'all can see all that?
Yeah, that looks great.
All right, excellent. So again, just wanted to talk to you about the percutaneous posterior cervical screws and instrumentation here from the Stedman Clinic in Vail, Colorado. These are my disclosures. So again, this is obviously a tech forward conference, and so we would maybe have widespread enthusiasm for this. But on the posterior cervical instrumentation, I think we're sort of in the encouraging reports and right before everyone says, wow, this is a great idea, we should just jump in and do it. And one of the benefits of the robotic system I use is we can really move it anywhere in the room to get ideal trajectories, especially with the cervical spine. Obviously, it's a little more flexible. I would make it more akin towards a pediatric situation as opposed to a adult degen in the lumbar spine, but just being mindful of the flexibility of the cervical spine itself. So this isn't really a new concept. Definitely in the last 3 to 4 years, we started doing more and more. This is some cervical spine navigation with robotics that we're kind of moving towards. And, a lot of stuff I do is endoscopic as well as robotic. And I think when we move towards percutaneous robotic posterior cervical instrumentation, that really starts opening up that endoscopic posterior cervical foraminotomy in conjunction. So then we're really doing the decompression, we're doing the instrumentation, and we're also doing the fusion part truly as minimally invasive as we can.
I'm a tapper.
And so my indications typically are greater than 4 levels, ACDFs that cross a cervical thoracic junction, and obviously non-unions. And I think, there's been a lot more literature that's being put forward about even 3-level ACDFs recently by Dr. Nunley pushing kind of the Providence surgical instrumentation to back some of that stuff up. So we're not as good as we think we are at 3 or level 4 ACDFs, making sure they heal. And here, revision rates as high as 35%. So is there something we can do at a single setting to prevent that higher revision rate? And so this was a recent paper that I'm sure has been promoted and come out. I don't use the Providence devices, but the point of this paper was, hey, if we do a circumferential fusion on a 3-level ACDF, we're going to have a significantly improved fusion rate and a decrease in that revision rate. And as this is robotics, and I love the whole concept of robotics, being able to percutaneously back up patients in a minimally invasive way to decrease their non-union rate, to me is very advantageous. So some of the advantages of the percutaneous approach, obviously, we're trying to spare as much muscle as we can. We're trying to reduce blood loss. We're trying to shorten length of stay, and we're trying to increase the union rate. And in my experience, and I'd love comments from everybody, when you're doing, a multi-level construct and you really start to cross that cervical thoracic junction, I just feel when you're going from a more mobile portion of the spine to a more rigid portion, just like in the lumbar going from L5 to S1 to the pelvis, do we need a little bit more robust fixation to ensure that we really get good healing across the cervical thoracic junction?
Just feel the pedicle down.
So really, patient positioning is going to be key. I use a Mayfield head holder. The system that is about to come out for percutaneous posterior cervical robotic instrumentation should have a DRB that's actually in the Mayfield head holder, which allows you to not have to make that incision in the upper thoracic spine to place your DRB. Really getting good camera positions. I generally put it at the foot of the bed. And you can see here, the robotic arm comes in from the side. And typically I want all the instruments kind of pointing at kind of a 20 to 30 degree towards the ceiling. Again, you can watch the video I did last year. Really, it's a finesse technique. And just like we heard in the pediatric space, especially at the upper thoracic levels, you have to really worry about those sort of steep angles as the ribs start to instrument or get close to and articulate with the transverse processes. So skiving is always a risk here. A lot of times I have a preoperative CT on these patients because a significant number of the cases that I do for this are non-union. And so I can sort of pre-plan and know what type of screws I can get. And the reason why I called this talk posterior cervical instrumentation is because one of the beauties of the robot is you can do pedicle screws if the anatomy allows you, but you can also do lateral mass, spinal laminar. Really, if you can put a screw in safely into the bone with the depth and diameter you need, you can place it. And the advantage of this is you no longer have to make sure you're doing the traditional up and out technique for putting in lateral mass. You can do a more straight technique, especially to line them up if you're doing sort of multiple levels posteriorly. So just like last year, I typically bring the robot in and I draw little circles where I'm going to plan my technique. When I was doing most of these cases, because we didn't have the instrumentation, I would do essentially modified Wiltses. You do have to be cognizant of the trapezius muscle coming through here. In the upper thoracic area, you have to worry about the rhomboids. So it's actually very interesting to see, because we're typically not far lateral. When we're doing that midline dissection, we're typically peeling the muscle off and kind of pulling it apart. But in the percutaneous situation, we're actually dividing some of the trap, and we just have to be cognizant of those muscles so we're not actually transecting part of the trapezius. Again, I drill, I tap, I put in the screw. I do put these in on hand. I don't put cervical screws in on power just because I do like that tactile feedback, and I don't want the weight of the drill to start pushing the spine. I want to be able to actually put as little downforce as possible and almost let the screw pull itself into the channels that we have cut. Again, I don't necessarily do immediate post-op spins. I think that can be a good idea if you have any question, but I'm at almost 400 robotic cases at this point, and the way we sort of have it, we have a pretty good trust in the posterior cervical space. We're in double digits on that as well. So this is just that 3D model crossing the cervical thoracic junction, just perking that at 7 and 1. So these are the tools I use. This is sort of a bottom to top view. You do have a pretty steep angle. What's nice about the way we have that set up is really if the angle of the screw changes to a point where your robotic arm doesn't necessarily get there, you can always unlock the robot, relock it in a better position. A lot of times the robot's almost too close, and you actually need it to move away to get certain trajectories. Obviously, you have to be mindful of the elbow hitting the head and causing any sort of deflection there. But in general, that post in the upper thoracic spine really helps.
Bring it down.
So nice.
So these are just more articles. It seems to be a growing trend that people are looking at this. So it's very appropriate for being right on the sort of front edge of this. These papers, if you look, are basically 2022s, some 21s, some 23s and 24s. And so really this is an emerging technique in utilizing robotics to now basically navigate the entire spine, not just the thoracolumbar space, but also in the cervical spine as well. This was last year at this very conference when I demonstrated it. That's a QR code that actually links out to that talk. If you'd like to watch some more live how to do it, I go through placing multiple screws percutaneously, and that was here at this very conference. So I just kind of wanted to go through some of the cases that I'm using this for and sort of the how and why. This patient, pseudoarthrosis, adjacent segment breakdown. And so again, I've had some questions, why didn't you instrument it all the way up? And one of the reasons why is I really wanted to do an ACDF, basically a 2-level ACDF, and fix the non-union, but I also wanted to spare as much posterior soft tissue as possible, as like this patient right now had a bad pseudo, already had a previous multi-level fusion, and now we're extending it. And I just didn't want to continue that instrumentation further up and let it heal. This patient's over a year out now, and everything healed. There were no issues with that 2-level ACDF above that construct, and the pseudoarthrosis also healed as well. These were all pedicle screws that were placed, and you can see that by the trajectory of the screw. But again, this patient over a year out, happy as a clam, had a shirt on in clinic that said, "Make my neck great again." So that was a little comical. So again, crossing the junction, I find that this is a very excellent technique to really, especially in some of these athletes that were football players, they have really, really thick necks. They're going to put a lot of torque on these inner bodies. And I want to back up that cervical thoracic junction in a minimally invasive way. Another pseudoarthrosis. And you can see here, these were done more in sort of a straight in or lateral mass technique. That was the bone that was available. This person had a little bit less real estate to put in true pedicle screws. So again, posterior cervical instrumentation got that non-union to heal without any issues. 4-level ACDF crossing the junction. Again, tried to convert this 4-level ACDF to essentially a 2-level ACDF based on putting in the posterior screws in the back. Again, this patient healed, no issues, and basically you're converting the non-union rate from a 4-level ACDF essentially to a 2, which is in the 90%. So we're really increasing the probability that these patients with multi-level anterior surgery have good solid fusion the first time. So this one, multi-level pseudoarthrosis, you can see on the left, you can basically see air in almost every single level. Again, I used a kind of more straight in technique to place those screws percutaneously. And that really allowed good instrumentation, solid fusion, no complications here. Again, another pseudoarthrosis. You can see, unfortunately, I get a lot of pseudo sent my way. Again, perc techniques. This was sort of a modified pedicle screw. I didn't have enough room. Her vertebral artery was right next to the channel for the pedicle, so I didn't have enough room. But I was still able to get, 14 millimeter screws in a pedicle trajectory in. Again, healed great. Another pseudoarthrosis. This was the first time I've ever seen a plate broken in multiple locations with screws broken. Again, did a modified pedicle perc here. And again, full fusion, no issues. And another one crossing the junction. And that's what we got. So really, this is a great technique, backing up pseudos, fixing those larger multi-level constructs. If you want to ever see stuff that I'm doing, you can follow me on Instagram, and that's my QR code. And that is about it. Thank you very much for allowing me to talk.
Thanks, Mike. Great update. So how many cases have you done now using the robot for the posterior cervical, would you say?
Yeah, we're at about 12. I have another one this coming week, so that'll make it lucky number 13. Yeah, we're getting there, slowly but surely.
Dr. Galisi, hi, it's Terrence Kim.
Hey.
Yeah, fantastic talk. You're really on the frontier with this. Pat and I, when we were venturing into navigation with cervical, we ran into a lot of problems with the cervical spine flexing in the same way that Dr. Ross with her AIS patients, a lot of flexibility. And are you getting none of those problems because the spines are all rigid arthritic? Are you positioning patients in a very specific way so that their neck doesn't shift or move? And how do you position the head? Do you use Gardner-Wells tongs or Mayfield frame? Like, how are you getting through all that dynamic motion?
Yeah, I think that's a great point. And I use a Mayfield head holder, so a rigid head holder every time. The other thing is kind of when you're putting that chest pad on, when you feel that angle of Louis, sternal notch right here, I'll cheat it just a little bit up, obviously not to impede or do anything to the airway, but just try and cheat that up a little higher. I do sort of papoose and burrito people, and I really, really use tape. I know people hate tape on the beds, but I use a ton of tape to really make sure that's rigid. The other thing that's nice about the Excelsius robotic system is really that deflection, and it's really, really holding and letting the drill do the work. So as you kind of touch the spine, we have that high-speed burr that's a cylinder, or I'm sorry, a sphere, and that sort of makes a divot, and then really being patient. It's the best advice I can give is as you're advancing that drill, it's the patience. You really, really have to let that drill do the work. And what's going to be nice is the new set that comes out, you're going to be able to set on the end effector how deep you want that drill to go. So it'll have a stop of the depth on it, so you'll never plunge the drill. And so then you don't even have to worry about that part. But really, it's holding that trajectory. And, out of all the screws I'm putting in, this is the, feel the burning in your belly, sort of like holding it like the whole time, watching it. And, I generally jam a lot of EDM in my ORs. That's probably the only time I turn the music down a little bit. And so, it's really like all hands on deck. I typically allow, a little chatter, but that's the only time that it's really like, okay, we need to really, everyone needs to be on point. And to your point with the X-ray techs, they're not allowed to leave that room at that point. So really being able to do it, and it's a finesse thing. It's really feel. And then again, I don't power any of these screws in. I put these all in by hand because I just want to feel the bite throughout the instrumentation. Yeah.
All right, thanks, Mike. Appreciate it.
Yeah, absolutely. My pleasure, guys. Wish I could be there.
All right, well, we'll have the fellow come and give a talk. Colin Gold, there he is. Okay, this is expanded applications for robotic surgery, and then we'll move on to Dr. Manista's demonstration. Colin.
Thanks for the introduction. So this is probably a good talk to follow that. The talk is titled, But What Else Does It Do? Expanded Applications for Robotic Spine Surgery. And my name is Colin Gold. I'm a spine fellow here at Swedish. So Dr. Askewian asked me to give this talk this week, actually, when we did a bunch of robotic surgeries together. But yeah, just following that talk, that makes my palms sweat, having done a good amount of freehand and nav cervical pedicle screws. That's like really some faith in the system. So I have no disclosures. One disclosure, I guess, is that I have a healthy skepticism of technology due to my training, which we'll talk about. So I did neurosurgery residency at the University of Iowa from 2017 to 2024, and then now spine fellowship here. I had a lot of kind of more elderly attendings in spine at Iowa that didn't use any technology, so we learned everything with fluoro and freehand. And then here we have the proprietary robot that we call the J-bot or the Yenza-bot. So we have a mix here of technology users and non-technology users. I kind of approach each one of these new technologies with kind of a prove to me that it works type of attitude. So my first robotics case was in 2020. It was L3 to L5 open TLIF, and then we kind of gradually pushed it in terms of mini open, where we'd do transfascial perc screws, and then a unilateral dissection for the interbody cage. And then as well during residency, we did some open T10 to pelvis with S2AI screws and pre-contoured rods. As I mentioned, fellowship here now, and then I'll talk about the cases we've done here recently. And in the future, I'd like to combine kind of a tubular MIS technique with the robotic surgery, which I know is being done some places, but I haven't personally done yet. So evolution of the robot that I've seen, back in, I think it was early 2020, the robot that we had at Iowa, there was no high-speed drill yet to make the first starting hole. It was kind of this telescoping awl with the outer cannula had sharp teeth, and there was a pinpoint awl that threaded through it. And we had a good number of skiving issues. Kind of had to pick the entry point really carefully with this because it would slip really easily. And we also noticed that each screw was becoming more inaccurate because just hammering this thing in moved the spine. So then this particular robotic system came out with this high-speed thin drill, which really, in my experience, more than anything else, changed the game in terms of accuracy. Other issues that we kind of ran into were, again, screws becoming more inaccurate, maybe because the frame was placed too far away, so we adopted this, we called it a drilling run. So we just used this high-speed drill and move the arm quickly from one spot to another, drill all the pilot holes so they're really accurate, and then go on to the more kind of torque-heavy steps like the tap or putting the screw in. And then other things that kind of we ran into were the pre-op CT wasn't including a wide enough field. So we had one case where the iliac crest wasn't included in the actual model. So we realized intraoperatively that the robotic arm was bumping into the iliac crest and made the L5 screw inaccurate. So then we kind of fixed that by expanding the field. And I know we were talking earlier about how to get around these problems that will come up. And at least for us, the answer was to often abandon ship and use AP fluoro and old school kind of jamsheedy needles and K-wires, because fluoro is always what it tells you. So after all these kind of workarounds, we didn't really have any further problems with screw accuracy. But the next question that came up in my mind was, what else can I do with this? Since we already had methods for putting in screws accurately, whether with classic navigation or fluoro or freehand. This is a case that we did here. This is a robotic MIS approach for a buck screw for a pars fracture, a 19-year-old baseball player with 1 year of left-sided low back pain, no dynamic instability, and just a left unilateral L4 pars fracture. So we did a robotic MIS approach for this. So I think ultimately we ended up with 3 skin incisions, one incision for the PSIS Chance pin, another for the screw itself, and then another for the decortication track. The 2 bigger of the incisions were about 1 inch, big enough for a 10 blade to fit in the screw and the drill bit. And then here's our final x-rays, and then an x-ray with the decortication drill in there at the same time as the screw. Some things that we learned, because this was the first time we'd done this, was you kind of had to compromise a little bit on the screw trajectory based on the spinous process. Luckily, this patient was really thin, so we could feel the spinous process on the skin, send the arm to the planned trajectory and feel that it would run into the spinous process with the kind of initial dilator probe. And then we just kind of moved the trajectory starting point a little more lateral, and just kind of kept playing with that until the screw fit well. The other problem, which actually luckily Dr. Skaggs had some insight with this, is we used just a standard Jackson table with the hip pads, and the angle was really difficult. Like, we were overcoming all these robotic warnings that the skin incision was too low, but the Wilson frame seems to be a nice workaround for that, because that was another thing. We had to keep adjusting the tract to not have the skin incision out of the frame. Here is a robotic mini open TLIF that we did also recently. This is a woman in her 60s. She had low back pain, left lower extremity pain, and left EHL weakness, and a prior L5S1 laminectomy. You can see this grade 1 spondy and a calcified synovial cyst on the left side. So this was our planning phase. So on the 2 planning screens, you can see both the screws, and we were kind of first time playing with this decortication burr as a laminectomy tool. So these green tracks are the tracks for the drill bit. And this is the drill bit itself. It's a cutting burr that's 7.5 millimeters. We found it to be pretty highly accurate. Here we planned it with a good margin of safety to leave some cortical bone deeper, because this was the first time we had tried this and didn't want to test live how accurate it was going to be, but it turned out it was highly accurate. So we used modular screws. We placed the screws transfascial perc, and then did midline opening for wide midline sparing bilateral laminectomy and cage placement, kind of dissected, pulled the muscle over the screw heads, and then put the screw heads on and the rods at the end. So on the left, here's an x-ray of almost final, kind of just had to put on the screw heads on the left side and put the last rod in. And then we got a post-op CT just to kind of check on how accurate these screws were. And the pedicles were not big, but we found that the accuracy was very good. This is an open robotic deformity surgery that we also did recently. This is a patient with untreated AIS. Cobb angle was 56 degrees. So we did a similar technique where we opened and dissected the midline. We had 2 different registration frames, so one as a Chance pin, and then we also did an L1 spinous process clamp to keep the upper thoracic screws accurate. We ended up doing T8 to pelvis. So the use in the robot in this scenario was we were able to kind of minimize the soft tissue dissection. So for the steeper angle of the S1 pedicle screws, L5 pedicle screws, we were able to put them in not quite transfascial, but kind of transmusculature, and then kind of pull the muscle over the top of those screws to later put the rods in. But it made it much easier to get a good angle at those pedicles without really cranking the muscle open. And then same thing at the top. We didn't really have to dissect much around those T8 screws. Here's a video of osculating.
See, there's no room for shift here. You do that.
And that was just the workflow of drilling with that initial sharp bit. And then here's the post-op CT. This lady had a significant amount of axial rotation. So we just wanted to check that all these screws were accurate because we were putting them in at really funky angles, and they all look perfect on the post-op CT. So this is something that I actually got to test out yesterday. They were doing a demo with a sawbone cadaver, and this is where my interest really lies with this. So it was cool to get to play with this. So I'd like to do MIS, unilateral approach for bilateral decompression with like a T-lift, for example. So one part of the planning software that I thought was really interesting is the skin modeling. So on this picture on the right side, this is the skin level view. So each one of these little circles represents the entry point for one of your planned trajectories. So on the right side, these are just 2 screws, and on the left side, there's 2 screws, and then all these different decortication, or in this case, laminectomy tracks. So I wanted to see how easy it would be to plan all of them, starting from a single point, but then being able to do a bilateral laminectomy, unilateral facetectomy, and basically just take that out and drop a tube and see what's left and just remove it with a kerosene or a diamond bit or something a little more precise for the final touches. And then on this left side picture, these are the decortication tracks that are planned. So this is 5. I think we ended up doing 2 more in the final demo. So here's a video of what it looked like, actually putting that 7mm drill bit down. And this is the first contralateral trajectory that we did. So you can see there's a depth stop with this. So you can just kind of bird beak the drill bit down, just kind of slowly have some tactile feedback, and it's easy to cross the midline with this. And then this is a video of what it looked like after we did 7 drilling trajectories. You're kind of left with this buckshot-like look. So at least in my mind, it'd be nice to try this and then drop a tube down through this same trajectory used for both the screws and these initial decompression steps, and just kind of remove this extra bone, pull out this inferior facet. Ultimately, as I said, 7 trajectories. This took 20 seconds per trajectory. And you can set the drill depth to desired safety margin. Here, I left no safety margin. As you can see, it just went right through. And I just wanted to test how accurate it was going to be. So my hope is that this will make a unilateral approach for contralateral decompression much easier in high BMI patients. I learned this tubular technique in Vail, where the BMI is quite low, and it was easy to operate through a small, short tube. And then I kind of practiced it in Iowa, where the BMI was quite a bit higher. So it was not uncommon to be operating through an 18mm diameter and 9cm length tube, which the farther you're out from the bone on the skin, it just would be a really crazy reach sometimes to try to get across and be airplaning the bed extremely, just not pleasant to do and kind of difficult. So this, I think, would be a nice way to get around that and not have to be in a poor ergonomic position for as long during these surgeries. So what's next? I don't know if this is possible. Maybe it is, but we've had a lot of courses here that talk about endoscopic spine surgery. So I kind of wonder, why not combine this with robotics? I'm sure there's a bunch of logistics that come into this with companies and adaptability and whatnot, but a lot of times with these transforaminal endoscopic techniques, everyone talks about the learning curve. And Dr. Chapman always says learning curve is just another word for complications. The hard part in these courses with doing this uniportal endoscopic technique is the navigation and the docking is really difficult with fluoro. There's a steep learning curve. And I found when you're holding this scope in this awkward position for a long time, your wrist really starts to hurt. So my thought is, why not put it down through a navigated tube, and then when you want to take your hands off, the robot just holds the scope for you. Yeah, I think that'd be a really unique use to these new technologies. So yeah, thank you for allowing me to talk. I appreciate the course chairs and Dr. Askewian and Dr. Chapman and Dr. Abdul-Jabbar for training me. Any questions?
You know, from that last slide with the endoscopic stuff, is anybody doing it?
Yeah, there's a few people.
Not that I know
Some
of.
people navigating things, or I'm not sure where the robotic thing comes in, but
Yeah, Saqib
Yeah.
Hassan gave a talk here 2 years ago using the robot and endoscope.
and he was combining it then. I think I must have missed that lecture. Yeah, that makes incredible sense. It really does, so.
There's actually going to be a,
Somebody we need to invite for one of our upcoming programs. It really is, because I think that's a big hurdle that just
Needs to go away, so you don't have learning curve. Okay,
there's actually going to be a percutaneous kit.
What's our plan?
We're gonna try to finish up with Andrew's demo. Is that okay, Ben? All right. Thanks, Colin. Was that the direct northwest face of Half Dome, or?
Yeah.
Looks like it.
How long did that take? 36 hours. What took 36 hours?
Direct northwest face of Half Dome.
Where's Half Dome?
Yeah.
Yosemite.
Yeah. It's a walk up the south side, isn't it?
Is that you sleeping on the mountain? I was gonna say, in November, I touched the rock. Who do you like?
2 friends, one from Colorado.
Is that the biggest one you've ever done, or is that?
No, I didn't.
It's beautiful.
Okay, we need to keep going.
No problem. You want us to continue, or you want us to break for lunch? No problem. You're doing great, Ben. Really appreciate you. Sorry about the accent you had. You may need to see a spine surgeon.
I'll let you know if we find a good one.
Terry, did you have a question for Colin? No. Okay, I was just going to pass around the microphone because, you know, everybody out there in online land would like to hear.
Call if online, if anyone's got anything to say.
I didn't see any questions.
Okay. Well, they like to hear the discussion too, even if they don't have any questions, so.
So we'll finish up with this live demo, and then we'll break and have lunch, and then we'll move on to sort of the non-CME section where we have a bunch of companies presenting new technologies. Not sure. Okay, here we go.
All right.
Andrew, take it away.
Well, thank you so much. I am very grateful to be allowed to be here today, and thank you to our chairs for including me. I'm just flabbergasted I could be included with such greats as the likes that have gone before. So thank you very much. Dr. Minasali and I are going to take you through thoracic pedicle screw placement with this particular robot. And one of the things I wanted to start off with is the planning, because I think planning is how we get success. I'm a huge proponent of planning with the preoperative CT scan for several reasons, not the least of which is that I think it gives you an opportunity to take the stressful parts of that process and take them away out of the operating room so that you can do that thought, you can make your tweaks and changes. And I agreed with the speaker that said earlier, it's good to have a night to sleep on it, and then make any changes you want to make the next morning and really have that plan be where you want it to be. One of the things that's nice about preoperative planning is you can plan the screws that you need to use, that you want. You want to maximize that minimal pedicle, engage that cortical bone, get the right length. And one of the things that I have found in my experience doing robotic surgery is that I'm using larger screws, and I'm also placing them in trajectories that I wouldn't have done on an open. I would have looked at that exterior anatomy and thought, oh, it's going that way. But when you have that CT scan, you can see it is a little bit different. And I've been very, very pleased with this process. So on the screen, you can look at an X, Y, Z axis, and you can actually march down the pedicle and see where that is going and make sure that you're engaging in that actual bone. You're then going to go on to do the registration. I have a little bit of glare on the screen there for me, but I think I hit the right button. When we register, the different platforms are going to have a slightly different protocol, but you're basically linking what that preoperative CT scan is to where the patient is in the world. And so you're going to have a reference frame, you're going to have an auxiliary ball. I'm blanking on the name for that right now, but that one tells you whether it's been moved or not. You're going to have the end effector here, and these all have to be in line of sight of the camera. And if they're not, then you're going to get an error message on the robot machine itself. So Dr. Mendesali and I, we're going to take you through some of these pedicle screws. So why don't we start off, we'll say T5. So I'll go ahead and send the robot to that location. And then I guess we should have pointed out that we already did our anatomy check with our chicken foot, but we can show that for you as well, just to confirm that we are where we think we are. We will start off with the burr, and this is just a light dusting to get that opening for the router bit to go down. And so this is going to be in line. We can see on the screen that we're heading in the right trajectory. Can you see the screen? Is it too much? Thanks. Okay. And so you're just going to lightly touch and let that, you can go spin on this one and just let it open up that little bit of the cortex there, so you have a nice spot to place your drill. All right, that looks good. Come on out. Now, if you have two instruments in the camera field, the computer can get confused. So your techs are going to basically place them down. Now, we want to keep the balls dry so that they don't get, we don't suffer any changes there. Now, if for some reason, let's just say somebody carelessly, the attending carelessly comes in here and pushes the robot away, we can always remove the instrument out of there, cover up the balls, and then press on the foot pedal and redirect the machine and get back to that perfect trajectory again. And so now we're just going to lightly touch. We're in the divot that the burr made, and we're just going to lightly touch, go full speed, and let the power take us down the pedicle. Really don't want to be shoving. Just let the weight of the instrument go down. The gentleman that taught me how this technique was named Guillot, Dr. Guillot. So we always call it Guillot hands. You want nice Guillot hands on that. And once you get down, it'll show you where you are on the screen there. Go ahead and come on out. I'm mentioning this because this is my preferred technique, is to tap the screw whole. But however, we're using very narrow screws here. So when I get to the 4.5s and the 5.5s, I generally don't tap. But when I'm at 6.5, 7.5, 8.5, 9.5, 10.5, I am going to tap. So this is how we would do it. But we're just going to make a little bit here for the demonstration. And then you can go ahead and take that one out. Now, what's nice about this particular screen is that the technician can see what screw you're going to use, and so they can preload it for you and have it ready to hand you. And then as you move to the next trajectory, they can get ready with the next screw. I do prefer to use a headless screw system. That way they're kind of out of my way when I'm doing my bony work, whether it be a laminectomy, an osteotomy, or the like. And did you get your check mark? Are you down? Yep. Yeah, good job. All right. Now, I did talk a little bit in one of the comments about the serpentine pattern where we weave ourselves back and forth, starting from the top more towards our array. And the reason for that is that you can pull the body from side to side doing that. This will help compensate for that. There are, of course, instances where for technical reasons, you might need to do a couple in a row on one side. That's fine. Just be aware that that's a possibility that the body's getting pulled towards you. All right. Wow, it's actually easier for me to look at that one. So here we are, just making a little tiny divot for me to put my drill in. There we go. And I'm going to take my drill and I'm just going to make sure that I'm in line, that I'm getting my proper trajectory there. It looks like doing pretty well. I'm going to go full speed. All right. Normally I would tap on with the larger screws. Again, we're using smaller screws here, so really not necessary. The drill is the correct size. And there we go. We're getting our screw back. So we can see coming down and we're following the plan that we had. Now, when we say serpentine, the next one I would do, and this is maybe just a matter of efficiency, but I'm actually going to go to the next one down on my side, and then I'll hand it back to Dr. Minisali. There we go. There are times where the patient will be moved enough that you'll need to re-register. And it's important to be able to recognize that. Having the array in line with the camera the whole time, you're going to be able to figure that out. There are warning signals that will come up if the anatomy is grossly off. However, you're going to want to use some common sense there as well. So you want the people around you to be very gentle. Thank you. And there we go. You'll notice, I don't know if you can see for the overhead camera, but the spine is moving here as we're inserting this screw. And some of that force is being pulled up in this trajectory here. All right. Back up, Dr. Nick.
Thank you.
There are times when the arm will not be able to reach the trajectory that you want without impinging on the body, particularly in high lumbar lordosis, where we have our cervical thoracic junction as well. And in those cases, you may need to invert the arm. And that's fairly easy to do. Here, let's see if we can, I think there's some tissue on that. There we go. It's fairly easy to do. You just unclick the screw, grab the collar, and the arm can be inverted, which will allow you to get those trajectories. Again, that's usually a problem down here at L5, S1 on those high angles. You can feel it, right? So we talked about the haptic feedback. You can actually feel when you're in. All right. These are the blunt tip screws. Where he made the hole is where the screw is going to go. And then with redirections, if you have a revision case and that sort of thing, I agreed with the speaker that mentioned earlier about tapping. So you start off with the small taps and work yourself up. And that way you have given the screw the best chance of going down the hole that you wanted it to go down. Checking with the ball tip feeler is a great way to confirm that. And you might have to get a ball tip feeler that's a little bit longer in order to get it past the sleeve here, or you can enter in from the side. Sometimes this happens and you can just back it up a little bit and then take it out. All right, let's go. Why don't you hit T7 on your side? You got it? Excellent. Now, some mention about using the robot as a teaching tool, and we certainly do at our place and enjoy it a great deal in that regard, because you have the ability to see the anatomy, particularly if you're doing a near percutaneous situation. Most of the screws that I'm going to end up placing are going to be transfascial. And so being able to see the anatomy on the screen underneath the muscle layer that we're looking at, I think is helpful for the people on the other side of the table. Now, it's been a while since I've been a fellow, and maybe they'll tell you something different in private, but I think it's helpful. There you go. Excellent. Once this screw is placed, I'm going to give you a little, show you how we invert the arm on those cases that we need to. And when we invert the arm, the position of the end effector is going to be different. And so the camera will frequently need to be moved to a different trajectory in order to see that. So we may need to move the camera over to the other side of the. All right, so before we move the camera, I'm going to go to this one here, and we're just going to, there we go.
So let's say for whatever reason, I can't reach this trajectory because I'm going to impinge on some structure that can't be compromised. And
you can assume if you were down here or up here, maybe it's the head. All right, so here we are. What are we going to do? Well, we can unclick the screw. We can grab the collar and push it, and then move the end effector into this position. So now we've inverted the arm. We re-click the screw and send it. And as long as the camera can see the end effector, we'll be okay. We might need to move that camera slightly to the side. Yeah, go that direction. But this is a good workaround for those people that, when you're dealing with those high grades. So a little less convenient when you have the arm in your chest, but it is a way to get those screws that you can't otherwise get, which has been a challenge for me, because I do like to keep people in the Jackson table as much as possible so that we're fusing them in an anatomic position. Our previous speaker had mentioned what his dream combination would be of endoscopy and robotics. And I will say that my dream combination is going to be the overlay of my reality and the reality of the patient, so that I'm no longer looking at the screen, but I'm actually looking at the patient and seeing this stuff. So that's my wish list there for the companies. So please get working on it. That's really basically how I do it. Again, I think the key fundamentals here are to make sure that you have your reference array in a way that it can be seen the whole time, that you do your anatomy check, that you're very gentle, that you use soft hands. This high-speed burr is a very helpful tool to make that initial divot so that you can avoid the skive. Having a flat tip router type bit is very helpful as well, because it makes it difficult to push it into the wrong direction. Just let this gently go down through that area. I'm a big fan of tapping, particularly as you get to the larger diameter screws. At any point, if you feel like you need to check a fluoro image or use your ball tip probe, by all means do so. I think that it's helpful to build that confidence in the robotic platform there. And then it's imperative that you be cognizant of the fact that as you're doing these maneuvers, you're going to be manipulating the spine underneath you. That effect will be exaggerated the more cephalad you are away from your array. And so it's nice to start at the top, work yourself down in a weaving pattern so that you can compensate for that. So I imagine everybody's hungry. I will take questions during lunch if that's okay with the team.
Sounds great. Thanks, Andrew. Appreciate it. All right, lunch break.
So we're breaking for lunch. Awesome. Thanks, everybody.
Thank you.
But you're in control, you're the one who's running the mat view, it's your cases, you just, and if he wants to add one or two, it's great, but you're kind of in charge. Because that's what some of the tumor people were like, well, I'm gonna go to that tumor conference too. They were given the last 5 minutes.
is where it will be.
Okay, Ben, are we ready to roll? All right, thanks, everybody. I hope you enjoyed your lunch. We're sort of on cruise control now for the final section of this robotics course. This is our opportunity to have companies in a non-CME format be able to present new technology that is usually not really allowed in normal CME courses because of the rules of CME. So this is sort of our opportunity to get smaller companies, companies with new technology that's not really even FDA approved yet, to allow them to have an early demonstration to our virtual viewers as well as our in-person. So the first technology we're going to have is VUS, which is a 3D guidance without any navigational hardware. They're out of Israel. And I believe we have a video that we're going to play, and then we'll follow that with a demonstration by Aesculap, and then Stryker, Brainlab, and then finally with J&J MedTech Velis's new spine robot. So we'll start with VUS. Thank you.
This is
CEO of VUS Medical, and today we shall be demonstrating our software-based guidance and verification, currently FDA cleared for spine surgery. The technology is applicable to any skeletal portion. And as you will see throughout the demonstration, we're doing that without any navigational hardware. All we need in the OR is a 2D C-arm and an off-the-shelf PC running the VUS software. With me are three surgeons, Dr. Paul Sloser, Dr. Baron Schiffer, and Dr. Shai Menachem. Dr. Sloser?
Thank you, David. So for those of you who don't know me, my name is Paul Slozar. I was the Chief Medical Officer for Titan Spine. But more importantly, I've been a practicing spine surgeon for 28 years. Had a pretty traditional degenerative spine practice like many of you. T10 of the pelvis, some complex deformity, but a lot of standard L4 to the sacrum and some ASC work. I'm here because I met David a couple of years ago, and we reconnected about 6 months ago as the VUS technology platform matured. And I watched Dr. Baron Schiffer, who's one of the surgeons here, on Orthopedics This Week masterclass, and I was blown away. I actually couldn't believe what they are doing with just a C-arm. So I actually flew to Cologne, Germany, spent 7 hours in their cadaver lab, did 14 surgical levels. I tried every trick I knew to break it, to mess it up, to mix it up, and the technology was bulletproof. I think this is an extraordinarily simple, yet really accurate complement to the existing navigation platforms. So for those of you looking for assurance to take C-arm technology and image navigation, or if you will, image guidance down the pedicle, I'll give you a little clue. Once you start seeing the axial view, it's generated by the C-arm superimposed on a CT scan, you'll become addicted to it as a surgeon. It's an amazing transformation to take this, and I see a great opportunity for this for ASC surgeries and other markets where bigger equipment, more complex navigation platforms, maybe not necessary.
Thank you, Dr. Sloser. What VUS does is we start by summarizing it so that it'll be better understood once we see the demonstration. Whenever a new X-ray is acquired, VUS, by means of image processing only, detects the surgical tools in the X-rays, and the dotted yellow lines you see there are detection. What it does next is that it registers that 2D X-ray with a prior 3D scan of the same vertebra. And that 3D scan can be any standard pre-op CT, we don't mind the prone supine issue, or a 3D scan in the OR, be it with an OC3D or a Siemens SAR spin or a Medtronic O-arm or a Zeem RFD 3D, any of those we're compatible with. Once it does those two things, it takes the surgical tools from the X-rays that it has detected in the X-rays, and places them virtually within the 3D data of the same vertebra or vertebrae from that prior scan that I mentioned, and shows the cross-sectional views, the traditional navigation views that today require a lot of hardware in order to generate, shows those axial, sagittal, along the longitudinal axis of the tools. And as you will see throughout demonstration, this whole process takes about 2.5 seconds. Views requires only AP X-rays because one of the early requests from surgeons was to avoid laterals, and even those APs do not need to be Ferguson views, parallel end plates, etc. Just any generally AP would do. So while doing that, views, unlike traditional hardware-based navigation, affects no cumbersome preparation. The only preparation is connecting the video cable to the C-arm. No workflow disruptions, no cameras, no markers, no references, no tool add-ons, only a 2D C-arm and a PC. We start by very simple planning, can be performed on a laptop or on the Views PC in the OR, and then we start the procedure. We start the procedure by making an incision that is as small as possible. For that, we need one X-ray image, typically acquired at 0,0, and we see the scalpel relative to the planned incision site. That's the dotted cyan circle, so that the scalpel can be positioned such that the incision is very, very small, which is, of course, desirable for many reasons. Once the incision has been made, a Jamshidi is inserted and we require a first X-ray from a generally AP view. And what you see here is the prior planning from the current angles of the C-arm projected on the 2D X-ray so that you can see how your tool is relative to the planned insertion trajectory and to the planned vertebral entry point. If that looks reasonably close to planning, a second X-ray is acquired, and we only need that X-ray to be at least 10 degrees apart, still generally AP. And once we have those two X-rays, we instantly generate the cross-sectional views that all surgeons desire, the axial and sagittal cross-sections. In those cross-sections, you see the tool. The tool is a solid yellow line, and the cyan notches are how far you still have to go. Each notch is 5 millimeters. If you're happy with the trajectory, you insert the tool further, tool exchange, etc., and then only one X-ray is required to ascertain the depth. In essence, is the surgical workflow, and now I shall hand it over to Dr. Schiffer and Dr. Menachem.
So now we will do the tandem mode on L5. Maybe most of you would agree that it is not so an easy level because you have quite to come far from the lateral. Sometimes it's not so easy to find the correct entrance point. At this, we would just place both our scalpels, as this is a tool which allows us to work with two surgeons on the same vertebra. And again, as you've seen before, we first start with the incision site. So we acquire an X-ray, AP 00. And you now see that mine on the right side, I have to go far from lateral and proximal. I move my scalpel. Shay also does that. Okay, new X-ray. Okay, so you're happy?
Okay. Yeah, I'm happy with my position.
Okay, so I do it a little bit more lateral and proximate. Of course, this procedure affords a little bit of communication between the surgeons. So you're happy? Okay, so please X-ray. Okay, so now I'm quite happy with my position. Jay, probably you want to correct it a little bit?
Yeah, I'll change my position a bit. Okay.
Okay. So we are both near the magenta spot. So we will acquire a second IMRI. We will accept that. And LAO2 cranial 25. That's right. So again, we have these two images and can calculate the cross sections. So now we have the visualization of the cross sections for both surgeons. So on the right side, that are mine visualizations, and on the left side are Shay's. I think we can both be happy with that, okay?
Yeah, pretty good.
Okay, so we advance the needle. Okay, once again, so the image can be acquired in this position. Please X-ray. And then we move to another position. In fact, the system calculates the optimal angles so that both incision needles can be seen by the system well. But of course, you see that we need only half of the radiation compared to the single site technique. Okay, so we exchange to K-wires. Okay, so again, X-ray please. And the second image. So that's the final position of K-wires. I think you got an impression how fast and with how less radiation it is possible to place 2 K-wires. Okay, we do a spin. I think you would agree that we have a perfect match between the visualization and the reality reflected by the C-arm spin.
Okay. Is Dr. Slosar on?
I'm here. Can you hear me okay, Danielle?
Yes, we can hear you.
Can you hear me as well?
Yes, we can hear you.
Excellent.
Great.
So can we provide a few additional details?
Yes, you can.
Okay, just to clarify, Views is FDA cleared. To date, we had 59 clinical cases, all in Israel at a large 1,100 bed medical center. 8 surgeons have used the system clinically. Another 30 have used it in cadaveric surgery, where we also did SI fusion, S2AI fusion, single position lateral lumbar interbody fusion, all of those. And we are now looking for 1 or 2 pre-commercial US sites to further expand our clinical data. And I will enable Dr. Slosar to provide any additional information and answer questions.
Great. Thank you. And it's nice to see a few familiar faces there. Hello to everybody whose paths we've crossed. I wanted to just comment on a couple of things that built on the NAS surgical stadium that I co-hosted with David, just from the surgeon's perspective in the audience. You know, first there's a continuum of spine surgery demands, and one continuum is just the site of service, everything from inpatient to outpatient ASC. The second is the continuum of case complexity. Again, everything from the highly complex scoliosis cases, deformity cases that have been shown, to the simple, 1 and 2 level, interbodies with percutaneous screws. And then finally, I believe there's just this enabling technology continuum. And what I mean by that is, freehand still uses, quote, enabling technology. It uses C-arm. You've got navigation and guidance technology, kind of traditional stealth, which is still pretty complicated. It brings in a lot of technology external to the patient, but maybe just not as complex as a robotically driven, which would represent kind of the kind of penultimate, synthesis of all of these continuums. The Views platform, in my humble opinion, sits perfectly in that middle tier of the continuum. It's a complement to existing enabling technology platforms for cases for surgeons who wish to use a C-arm driven instrument guidance. The next thing I wanted to just touch about, I've been on the whole conference, it's been amazing, and compliments to all of the faculty. I've learned a lot, a ton, quite sincerely. But the issue of all of these papers citing, frame shift errors and what that drives, and in terms of just stopping your workflow cold to the worst case scenario of causing a complication, this is non-existent as it pertains to the Views platform. You could see there's no there's nothing in the way. There's no reference frame with which you have to rely upon. And then lastly, the other part of this conference that's been extraordinary has been the focus on minimally invasive, coupling robotics, coupling deformity surgery with MIS technology. And as it pertains to the Views system, as it sits, as I said, I think it complements an enabling technology platform in a way that it's the workflow. There's no reference frame to mount, specifically or separately to the spine or the iliac crest or to a spinous process. Number two, there's no landmark registration that you have to go through. You don't have to find a part of the spine to open, if you will, and land a spine anatomy check. And then lastly, the learning curve, 2 cases probably. It took me probably 45 minutes when I was in Cologne, Germany, to get the workflow down and then just kind of integrate it in as obviously all of us are very familiar with C-arm-based workflow. So we appreciate the opportunity. I'm enamored with the technology. I just find it elegant in its simplicity, and hopefully we can answer some questions from the audience.
Hello, Paul Slosar. How are you? Welcome, and thank you for your time here today, you and David. I'm kind of blown away by all this. I'm looking at it and I'm trying to understand. There must be some complicated mathematics that I'm just not
There's none.
that level or something.
It's just a C-arm and a PC with software. That's all.
And I just want to know more about it. That's the whole thing. You just be a little bit to where it's like, okay, how and where am I going to use this for each of the procedures that I'm thinking of, all the things that we do as spine surgeons? I can imagine all kinds of things. And I've been saying we need localization and navigation technology that does the same thing, that we can go do a laminectomy, a microdiscectomy, a fusion. I don't know if it applies to the front of the spine or not, but I do a lot of artificial discs, and I'm just thinking, I don't think I'm understanding exactly how all this could be applied.
I'll jump in, Pat. Yeah, I didn't mean to interrupt you. Yeah, 100%. I was going to say anything that's transpedicular, or anything with bone anatomy, SI joint, the relieving procedure, the pain procedures, placement. We actually were talking with some of the guys at NAS who wanted to get better sense of where their artificial disc is placed, medial, lateral, from a centralization perspective, especially in an anterior lumbar where it's hard to get, straight up centralized. But the thing that's hard to put into that presentation is this is basically a C-arm overlay. And the key thing here that is very differentiating, it's C-arm overlay onto a CT scan. So you can get a CT pre-op, you can get a CT intra-op if you have an O-arm, or you can get a CT intra-op with a 3D C-arm scanner that are coming out now. These are becoming much more prevalent. So you just spin with your C-arm. You don't need an O-arm to do a localized spin. But the thing I wanted to point out is the Views navigates off the tip of the instrument. It's really where the tip is. Everything else, navigates or references from the handle, because that's all it sees is what's external. So the fact that you know where the tip of the instrument is on real-time overlay, I think just adds another layer of elegance to it.
So you need both K wires put in to be able to get 3-dimensionality. Is that correct or not? I'm head shake no. I'm just trying
No,
to...
our current FDA clearance is for single tool, minimally invasive thoracolumbar fixation coupled with fusion, kyphoplasty, vertebroplasty. All of that is single tool. What you saw in the video is an extension, how we can guide 2 tools concurrently, which as far as we are aware, and I've been in navigation for 30 years, and no other navigation technology can achieve.
Wow.
So Dr. Slosar and Mr. David, thank you so much. It's Terrence Kim. I'm sitting here with a couple spine surgeons. Our heads are scratching, but I'm trying to understand this better. No navigation camera, no navigation instrument, throw away all that junk.
Wonderful.
No reference, no calibrations.
I put a scalpel right down to where I want it, and then it will give me a 3D onlay of what it is with an AP and a 10-degree off. Is that what you're telling me?
That is correct. Basically, on the 3D scan, we just plan the insertion trajectories and get the dimensions for whatever we want to insert automatically. And then when you shoot a first X-ray, you get the planned incision site projected from the current viewing angle of the C-arm. You make your incision as small as possible, insert a Jamshidi, take a second X-ray at least 10 degrees apart, and then you get the axial and sagittal cross-sections. And that process that I described takes 2.5 seconds. And as I said, there are no cameras, markers, references, calibrations, etc.
That initial trajectory, the first 00 X-ray, that trajectory that the software figures out, is that based off of your ideal trajectory that you preset on the CT scan?
We always show you where the tool is relative to your planning from the current viewing angle of the C-arm.
Okay.
And
The
the pre-op
planning is
planning,
always projected on the current X-ray.
yeah, and Terrence, the pre-op planning basically once you have your CT, be it from loaded already or you spin and it's integrated, you basically get a picture like we're traditional any navigation where you say I want my screw to go here, I want this screw to go here. Once you do, if it's 4, 6, 8 screws, you label them, and then the funny thing is, since it's a CT, you're just doing the pedicle. You're saying, I'd like it to go, down the pedicle this direction. The views will then extend you to your skin, and it'll tell you that little circle at the beginning is where the incision starts, which many of us who've done this or taught a lot of fellows, we always start too medially, typically with our incision. So it brings you from a skin incision all the way down to where the tip would end in the vertebral body.
And because we focus on a targeted vertebrae, we don't mind the prone supine issue of pre-op CT versus intra-op X-rays. That does not affect our accuracy. We just focus on the targeted vertebra. We don't mind tools bending because we track the distal tip, and we don't mind reference shift because we don't have a reference.
So this is, as I'm trying to understand this is kind of dynamic navigation. In other words, with the current systems we have with navigations, it's static, and that's what causes you to put an instrument straight into the canal because you're following a false path.
Yes.
What you're doing is, this is almost like 7D with light projections. You're using X-ray. So every advancement of the instrument, you get a shot, it'll show you where you are in the CAT scan. You're like, whoa, I'm too medial, adjust, get a shot, and then go in a better place. Like, it's that kind of dynamic registration, right?
That's true. And what got us started, our team has previously developed 2 standards of care in guided bronchoscopy and guided coronary catheterizations. What got us started here is that we stumbled upon spine surgery, and we asked ourselves, how come almost 30 years after optical navigation has been FDA cleared, only less than 20% of the most complex inpatient surgeries are navigated? How come MIS is only 20%? How come only 200 ASCs do spine, et cetera, et cetera? So I went out and talked to surgeons. That was 7 years ago. And surgeons said, look, most of our cases are 1, 2 levels. We like X-ray because of its simplicity, affordability, tool neutrality, small footprint, et cetera, Just give us the cross-sections, the axial and sagittal views. And if you can do it without lateral X-rays, only with APs, that's even better because nobody likes laterals. So those were the guidelines, and that was the road we marched along.
Any C-arm machine, or it has to be the C-arm that your company has?
No. Our FDA clearance is for C-arms currently from GE, Siemens, Philips, and Zeem. The only limitation currently is that we focus on flat panel C-arms. We haven't yet dealt with the image distortions of the old image intensifiers that are gradually fading out.
Flat panels. I see. And then, so I see this as a problem with us in arthroplasty all the time, not knowing if our implant is exactly where we want it. Sometimes you get a fluoro to confirm where your implant is on the AP. You get a CT scan down the road, and it's way off to the side and rotated. And you're like, well, the fluoro looked like it was dead on. So I see this as an extremely compelling thing for arthroplasty placement.
Dr. Schlosser, did you want to add anything?
Yeah, no, we had a couple of people come up to us after that surgical stadium, Terry, and say the same damn thing. Yeah. So, I mean, and these guys, they just need an outline of the instrument, right? If you're going to use whatever the dimension of the AP, side to side dimension depth of the instrument, that's what you guide to, right? And you can recreate that pretty easily.
Okay, what are the prospects for developing beyond axial imaging?
Okay, can you clarify the question, please? We mean beyond axial imaging. Do you mean beyond the current type of procedures, or
orthogonal planes, coronal and sagittal?
Oh, we currently provide axial and sagittal, but our software can do any plane that you want to do. Also, the technology is not limited to spine. Our software knows nothing about vertebrae. The technology, as long as there are patents, is applicable to any skeletal portion.
Okay, it's all pre-planned. What's trackable? Is there something live that's trackable?
No, every time you acquire an X-ray, the software automatically detects the distal tip of the tool. We take a few millimeters backwards in order to show you the real trajectory, not the one you extrapolate from the proximal side, and show you the cross sections. Currently, we show axial and sagittal, but we can show you anything you want.
Disposable. Disposable.
Yeah, okay. I want to learn more. I'm fascinated. Totally fascinated.
Yeah. So that's why I got on a plane and flew out, because I couldn't believe it either. So I tried everything I could, but it was pretty simple. Yeah, it was wonderful.
No, I've done that. Whenever I see something I like, I go see.
Okay, may I just mention again that we're looking for 1 or 2 initial pre-commercial US sites. I'm David T. at viewsmedical.com, and if you go to our website, the info at viewsmedical.com gets to me. So you're welcome to write to me.
So this is also a question, just as we try to put everything together. This is software.
Mhm.
And clearly not holding, huh? Where is that screen? Oh, that viewer that's behind you on your right shoulder, on your virtual background, is that the unit that needs to be purchased?
Yeah. All you see is a PC in a nice casing. It's an off-the-shelf PC with a strong NVIDIA graphic processor and a large touchscreen and an isolation transformer. It's all off-the-shelf hardware. It's basically a PC on wheels and a touchscreen.
And then just from and not holding either of you to it, but like from a cost standpoint, what's the US equivalent ballpark of some thing like this?
Pricing has not been established yet. Basically, any imaginable pricing scheme may be applied here because the hardware is just a PC and a monitor. But currently, we're still in a pre-commercial phase, and that's our current focus.
Can so you're saying a gaming laptop can run this, or it has to be?
Well, basically, it's an NVIDIA GPU graphical processing unit whose main use today is gaming and cyber, I guess, and we're the beneficiaries of that. The act of acquiring an X-ray and immediately generating the axial and sagittal cross sections 7 years ago when we started took an hour. Today takes 2.5 seconds, and that's not only thanks to our progress in developing our software, but also thanks to NVIDIA.
Okay. Thank you very much.
Awesome, Paul.
Good to see y'all. Thank you. Great course, you guys. Appreciate it. Thank you.
Thank you very much.
Thank you for this intriguing concept. Thank you. All right.
Asculap.
We're moving on to Esculap and the robotic exoscope. Ryan?
I think he's in the lab.
Is he in the lab?
There he
Okay,
is.
perfect. Ryan, take it away.
Oh.
Can't hear you.
1 second.
Someone on this production set is getting.
There goes Ben.
Bring the audio guys up here.
Hang on, somebody's gonna give him the hook.
Okay.
Yeah.
Okay.
This is good.
Yeah.
Was
All right, let's try that again. So again, I'm Ryan Mancini. I'm the Group Product Director for Robotics here at Esculap. I'm joined by Stephen Hagan, who's our Seattle area neurospecialist. And so today, going to introduce all of you to our EOS robotic exoscope. So for those of you in the audience who may not have had the opportunity to use an exoscope firsthand just yet, so a quick orientation here, right? So no oculars at all, 100% digital visualization system married to our robotic arm. We have multiple monitors. We have an integrated 26-inch monitor, and then both here today, we have our 55-inch monitor as well as available a 31-inch monitor on roll stands. And so what that means, able to configure multiple monitors in the OR, depending on both the physician and procedure needs. And so Stephen's going to kind of walk us through some of these controls here. Obviously, we're here to talk about robotics, and we're going to give you, let's start with the robotic features of EOS. So in order for us to make some repositions, Stephen can go ahead and grab one of our unlock buttons here. We can make large gross readjustments with just the press of a button. The robot does the work for us. And the idea is you don't have to hit a bullseye as far as what you're trying to visualize here, because where the robot really starts to stand out is some of these finer micro movements where essentially we can move in the X, Y, and Z planes and really get a precise precision as far as exactly what you're trying to visualize. And then from there, we're able to do some semi-automated robotic repositioning. So with the press of a button, we can, instead of going from X, Y, and Z, we can now pivot around a fixed area of interest. So we can rock side to side, front to back, and really start to put the scope in some aggressive angles. And now, since we've decoupled from the oculars, now you're able to really take a vantage point that would be challenging, if not impossible, with a traditional optical-based microscope. And so what we've seen from our surgeons who have adopted this technology is that ergonomics may not have been the primary motivator for moving to an exoscope, but one of our surgeons likes to joke that now, after performing an ACDF, he no longer feels like he himself needs an ACDF, right? Because of being able to have that direct line of sight to the monitor and no longer be affixed to the microscope, and therefore the device is no longer dictating the ergonomics to you. Another area of robotics that we can lean into here is what we call setting a waypoint. So it's like dropping a pin on your GPS. So Stephen's going to set a waypoint there. If we move the scope into a different position, and then with the press of a button, we can recall that waypoint, and the scope will move exactly to where it was before. It saves its zoom, it saves its focus level, it saves its positioning. So it really is like hopping in your DeLorean and going back in time back to where you were previously. You can set an infinite number of waypoints over the course of the procedure. So for example, we have some of our users who they'll set a waypoint in between levels. They can pull the scope out of the way, press a button, and then the scope returns exactly back to where it was before. Muscle memory probably could have got you very close. But again, the robotics, that's what gives us the precision. Outside of spinal surgery, for cranial surgery, we have some of our users, for example, in an aneurysm, in a complex case, they may set a waypoint at the front of the aneurysm. They want to take a look at it from the rear, press a button, they can then quickly return back to where they were looking at previously. So these are just some of the examples that if this were, say, a non-robotically based exoscope, you'd be relying on the human brain and the human hand to make those same movements. Again, robotics gives us that precision, it gives us that reproducibility. One of the other interesting things here, since this is also a fully digital platform, so the visualization is digital, it's a software-based device, is the hand grips that you see there with the different controls that Stephen was just interacting with. We can save the configuration individual to each user. So for example, if a given surgeon had commands that they prefer for one procedure over another, we can set an infinite number of surgeon profiles to either make the controls as complex or as simplified as the individual user prefers. And again, this is just I think, it's a little bit of a tired analogy, but if we kind of look at our cell phones, right, we kind of have come to expect that the user experience will continue to evolve with the technology that we use, and that's very much the case here, where we're constantly rolling out software updates that are both improving the interface, improving workflows. So very much the expectation is the device that you have today will not be the same in some shape or form a year from now as far as its functions, its capabilities, and how we interact with the technology. Speaking of the digital visualization piece, a couple other examples we can show you here. AOs can essentially act as a digital receiver. So for example, we can do a picture-in-picture to pull up, for example, while we don't have another navigation source right now, as you can see, we have a split screen on our control monitor and on the big monitors as well. And just with the press of a button, we can pull it up. And the press of a button, we can pull it off screen. So the idea is pull up supplementary information when you need it, and then pull it off monitor when you don't. Similarly, for example, if we had a neuroendoscope, we could also pull in that same digital feed as well. Another example of this is we can add a digital aperture on screen. So if we're in a MIS procedure, right, and we want to black out the information that we don't need, while it's not changing the actual image itself, right, we don't see there's not a black circle on our anatomy, but on screen we can digitally augment what that looks like. And again, this is just sort of scratching the surface as what we can do with a digital image as opposed to with an optical image. Lastly here, and while our model here won't quite do it justice, we have multiple imaging modes, so we can also essentially tweak the color set that you see on screen based upon the preferences of the surgeon, as well as the anatomy on hand, and again, being able to augment what we see on screen versus what the naked eye could see with an optically based image. Another piece, well, I do want to highlight, while it falls a little bit out of the scope, no pun intended, of our topic here in the cranial neurosurgery space, we do have both blue light and ICG fluorescence. And so while those themselves aren't novel technologies, being able to have them in full 3D, and also we're able to throw additional white light on those images, it allows us to spend a little more time in those fluorescence modes than you would typically, right? Obviously, it's a little bit brighter in the room that we have here, almost sort of looking a little like sodium fluorescein, but the idea is by being able to throw more white, we can work in these modes a little bit longer. So again, kind of reinforcing the benefits of this a digital image as opposed to an optically based image. All right, so I think a couple other pieces just kind of tie this all together, right? So I'd say that our viewpoint is that exoscopes, both the current generation and their successors, this is very much the direction that surgical visualization in the neurosurgical space is headed. So we're deeply invested in both the current generation as well as subsequent generation technologies, because we feel that the benefits that robotics provides, again, bringing us back to the reason why we're all here today, as far as both automated and semi-automated movements, the precision that provides, and then as well as really the untapped potential on that digital visualization piece, as far as being able to improve the user experience and workflows, but also be able to provide additional insights to the surgeon on screen that traditional, more analog-based technologies really essentially have hit their ceiling on. This is where we see things are going to continue to expand, especially right with AI, with machine vision, with augmented reality, as more and more of these technologies are converging with one another and more finding ways into additional devices. This is very much where we see this both platform and, as I mentioned, subsequent platforms expanding as we go forward here. I think a little bit ahead of my finish time here, so I guess moving to the questions.
That's cool stuff. I have to ask the question about a lot of exoscope stuff, is that there's work in the 3D world. Where is that? Are there thoughts of that in the Escalop world?
I'm sorry, could you ask that one more time, please?
Are there interest in 3D?
Oh, yes, I'm sorry, thank you very much. So yes, so this is a 3D platform. We just, for the purposes of this presentation today, we have this set to a 2D image, but yes, the idea is all of our monitors are 3D when we're actually using this in surgery.
Okay. That would interest me. That interests me a lot. So any other comments from audience?
And I'll clarify that slightly too. It's full-time 3D, so I know there's been some other technologies that have had limitations as far as 3D at one, it'd be at a certain magnification level for 2D, a different magnification level for 3D. This is 3D regardless of your mag.
Dr. Kim.
Yeah, no, my biggest problem are sometimes those MIST lifts under the microscope. That tends to be a little problematic when you're trying to put in the interbody cage. The microscope is pulled way out laterally. You're almost putting them in with your hands fully extended to try to get that. So the scope blocks you. So I find a lot of value in this. Tell me, price-wise, how does this compare to a microscope? Because I imagine this is kind of a substitute for the microscope, correct?
Absolutely, yes. A substitute for a microscope. So I'd say what you're looking at here, the fully loaded package, the big monitor, the fluorescence modules for cranioneurosurgery, that whole package for under $500,000, which is going to be a substantial savings compared to fully loaded platforms for some of the other products on the market.
Awesome stuff.
And I'll say too, from a lateral positioning perspective, essentially what we can do is we also, since of decoupling from the arm and the robotic capabilities, we can invert the arm. So essentially, as you see the elbow up here, the elbow can revert down, and essentially the camera can sit at that more of a chest level. I was actually just in an X-lift the other day, and the surgeon couldn't believe how well he could position himself, or he no longer felt like he was having to reach so far around from his microscope. So from a lateral perspective, there's definitely some great advantages with the Exoscope.
All right, great stuff, great stuff. Appreciate you guys coming. It's
thank you.
Exciting to see the advances. Okay, moving ahead with Stryker and the Mako Spine and Copilot Robotics. Where's Sean? Sean on?
Green, can you hear me?
Yes, we can.
Perfect. Thank you very much. I appreciate the opportunity to attend the meeting, and I appreciate the opportunity to showcase some of the technologies that are recently coming to market. I'm going to share my screen here. Hopefully everybody can see my screen.
Yep.
I wanted to speak today about the Q Guidance system with our most recent spine guidance software launch, Spine Guidance 5.0, and I'm going to be speaking about our Copilot platform as well. And these technologies, if you haven't seen them already, are available to be evaluated in the evaluation area that you have set up. So our Q Guidance system, this is our 4th generation platform, and we were very purposeful in calling it a guidance system as opposed to Nav4. And the reason for that is this is really the computational center of the ecosystem that we're developing to support not only technologies like Copilot, more traditional navigation steps, but also robotic arm technologies as well. It has 2 PCs. One is dedicated to the software application. One is a real-time PC delivered with the intention to reduce latency. For the software as well, we also have 2 touchscreen monitors, one for an operator and one for the surgeon in the field. Our camera, which I'll talk about more in a moment, is also a 4th generation camera, our FP8000 camera. And this is something that we do a little different than what's on the market today. We don't use an off-the-shelf camera. We actually design and manufacture the FP8000 ourselves. And the reason for that is because of the intention of our roadmap and the capabilities that we want to enable surgeons to perform, but we also want to leverage active and passive tracking capabilities. We know that those that have used navigation systems have experienced frustration with maybe blood or other fluids getting on passive trackers. Our active tracking technology, in addition to being very active and very precise and accurate, it's also less susceptible to interference due to fluids. It also allows for two-way communication between the sterile field and the system with smart pointers and other smart instrumentation as well. And then with our cranial guidance platform, we also enable a third mode of tracking with EM tracking as well. So a few things I want to highlight here. The first one being that this is actually the Spine Guidance 5 software is our 3rd clearance. So our clearance on the platform, the Q Guidance platform, was first received in June 2022, and our first application was Spine Guidance 4. We followed that up in February in 2023 with Cranial Guidance for Q applications. And then most recently, in July of this year, we launched Spine Guidance 5.1, which is featuring the Copilot software. And then our most recent clearance is Spine Guidance 5.2, which supports Mako Spine. So now what you have is a Spine Guidance 5 software that'll support smart powered instruments as well as smart robotics technologies. And with our Spine Guidance 5 software, really our intention is to deliver the benefits of imaging the patient in the operative position and intraoperatively, but reduce the time from image acquisition to plan execution. And there's a number of ways that we do that. We have smart segmentation capabilities. And really what the state of the art is today is to put a bounding box around each of the vertebral bodies and identify to the user that there's a vertebral body within that box. What we're actually doing is we're identifying the bony surface of each vertebral body. It's looking at things like the pedicle, the isthmus of the pedicle, and based on the screw family that you pick, it's provisionally selecting and placing a screw within the area of interest, within the vertebral bodies of the surgical area. What it's also doing is it's creating no-fly zones, and I'll demonstrate that in a moment. So it's putting a boundary around places that you don't want powered instruments to go, like the spinal canal, the anterior wall of the vertebral body, the exiting foramen, and the superior and inferior end plates. And all that is done automatically. Now, certainly the surgeon needs to go through, review, and approve it. But again, the intention here is to minimize the time from image acquisition to the time that you have a completed plan and ultimately execute that plan. So within the Spine Guidance 5 ecosystem, one of the product families is called Copilot. And what I'm going to show you here are two of instruments. These are two of the first, but I'd really like you to think about this extending to become a family of instruments utilizing different technologies. Now, one of the demonstrations earlier, it was mentioned that really the preference isn't to have to stare at a screen while you're operating on a patient. And one of the ways to address that is through advancements in instrument tracking. So what you see on the screen here are two things. One, you see our Signature 2 high-speed burr with a 360-degree tracker. And really the intention there is to eliminate line of sight concerns, to maximize the visibility of this instrument and allow the surgeons to focus on the patient, not on the screen. And then the other instrument on the right-hand side is our ES6 driver. Here it's being shown with a screw attached. And what this enables is a smart stop or an automatic stop when the implant reaches the planned depth. So I'll show you an example of this on the video, which I'm going to play now. On the left, you can see that instrument goes into the zone. You have a stop zone located around the spinal canal. And one of the reasons for the speed of our camera, which is critically important, and this camera is up to 15 times faster than the off-the-shelf cameras used by market-leading systems. And you can program it to do a couple of two things. You can have it automatically stop. You can have it vibrate the foot pedal. You can step down the speed of the instrument, which is more of an audible cue, or you can have the system tone or have a visual signal that you've reached that boundary. With respect to pedicle cannulation, tapping, and screw delivery, similarly leveraging that plan, you have an auto stop. So when the screw is inserted and it reaches the planned depth, the insertion instrument will automatically stop as well. And as I mentioned, this is enabled through active tracking technology. This is an example of that 360 tracker. So you have 360 degrees of visualization with active LEDs. And when I say active versus passive, what I'm speaking about is those trackers have LEDs on them. They emit infrared light to the camera, as opposed to the camera emitting infrared light and having it reflect off a reflective fiducial. So as I mentioned, really, this is an attachment in a software addition to what is a market-leading powered instrument platform. So our Signature 2 high-speed drill, you have the 360 tracker. It utilizes, there's 10 different Elite Q attachment options, ranging in different lengths based on what procedure you're doing, which step you're performing, or surgeon preference and patient size. And then the other thing that we spent careful attention on is the instrumentation. When you have tracked instruments, sometimes those instruments can become heavy. they can become too long. And certainly in a spine procedure, we're cognizant of the fact that that can place undue strain on surgeons as they're doing these repeated steps day after day. So we spend a lot of time trying to reduce the length of the components that are used, reduce the size of the tracker, and ultimately make these instruments more ergonomically friendly. So with that, I'd be happy to answer any questions you have. As I mentioned, this is part of an expanding ecosystem. Spine Guidance 5 with Copilot, as mentioned, launched earlier this year. We are now also in a limited market release for Mako Spine. We've done our first cases with Mako Spine with good success. We'll continue to roll that in a limited market fashion for the next 2 quarters until full market release. So right now, for the first time, we're adding spine procedures for the Mako, and Mako to date has performed over 1.5 million joint replacement procedures. So we're excited to add this capability to that platform. I'd be happy to answer any questions that the audience might have.
Great. Sean, thank you very much. That's some exciting advances in some of these things, which I think have been needed a long time. And I have kind of a personal one I suggest to you and anybody else who wants to follow. It seems that a lot of our tools that we use are very long, and they're made for one part of the body. Okay, and the cervical spine and thoracic spine are much shallower wounds. And so I think a lot of those things that you have this whole platform of your implants and all of your navigation things, it's just that they seem to fit the ergonomics in the operating room, and I'm not sure why nobody's ever done that out in the world there yet.
I agree with you, and I'll say we were certainly guilty of that with prior generations of our own platform. So, that, as I mentioned, there was a concerted focus on that to make them light, more suitable to the procedure being done. I'll also say that platforms like Copilot, while our first application is in spine, we're looking to extend that across other powered instrumentation that we offer within the Stryker enterprise, not only for spine procedures, but for other neuro and cranial procedures as well.
Dr. Kim.
Yes, so I was with Dr. Ross. We were looking at your Copilot and your Stryker system in the demo area. I was shocked by how the instrument could still be read even though it was completely blocked from the camera. I mean, that was insane, right? Like, we had the instrument and then I put my hand in front of it and it was still tracking. Like, how is that possible? What is it doing?
That's one of the benefits of, and one of the reasons that we designed our own camera. And I think the other thing too is that tracker that you're seeing on that instrument, that 360-degree tracker, is bespoke as well. It was purpose built for that. It's one of the benefits for being able to develop that organically and within the business. So it's something that we have expertise doing. It's something that we look forward to applying, but that's exactly it. Ultimately, one of the benefits of Copilot is that as you start to introduce these advanced guidance capabilities, we want you to be able to retain that tactile feel and that awareness and what you're used to feeling in instrumentation that you use today. So I think that's one of the beauties of Copilot, is giving you an instrument that you're probably used to holding, used to feeling, knowing what type of tissue that you're in, but providing that added layer of safety. And what we find also with respect to the warning zones is that sometimes if there's younger surgeons or fellows, it may be desired to have the instrument stop. That may be how surgeons start to use it initially, but very quickly they migrate either to the step down speed or vibration of the foot pedal. So it allows you, particularly if you're doing a laminectomy, for example, to go through, have awareness that you're getting close to having a frangible element when you get close to that breaking point, giving you a warning and allow you to proceed until you break through that element. You can break that fragment off. And then also, as we look at across the portfolio as well, these are obviously mechanical high-speed cutting instruments, but as we look at other potential for energy devices and things like that, these are capabilities that could be applied to those instruments as well.
I think that's what's the most exciting part of your technology, is that about 5 or 7 years ago, just the stay and hold screw was the only thing a robot could do. And to try to understand if there was ever going to be some kind of forefront of someone looking at no-fly zones in respect to decompression, in respect to autonomous robots that can protect themselves. So I think these are creative and extremely appealing solutions to creating that next level of robotic technology, or what you would call robotic 2.0 or 3.0 in the future. And I'm really excited about your company.
Perfect. I'm very happy to hear that. You know, as the way that we look at it, we look at this as being an ecosystem in the truest sense. And that means that we don't want to take a single tool and make it do all the steps. We really want to align the right tool to task. And in some cases, that means a manual navigated instrument. In some cases, that means a smart powered instrument. In some cases, that means a robotic arm technology. And we also understand that that's going to change over time, right? With respect to surgeons' level of comfort. We've also spent some time today talking about the ASC, and we understand that there's different considerations in the ASC as well. If a surgeon's operating in an ASC and a hospital, we don't want their workflows to change substantially, right? They can pick the tools that are available to them in the ASC. They can pick the tools that are available to them in the hospital, but the software workflow is relatively the same. It just adjusts based on whether or not they're using a robotic arm technology or not.
That's why they call it everything that's cool in spine surgery. That's this session. Sean, that's great stuff. I love the no-fly zone concept, and there's just some great innovations that you guys are doing. So thank you very much for being here, and
thank you very much.
Please come back. We'll invite you again in the future. We're going to move on to Brain Lab. Krish Vigneswaran's going to talk to us about where they are with their Brain Lab robotic suite and loop imaging technology, and I've seen some of their stuff.
We have a circ in the back there.
And, yeah, thanks, Danielle. There is a circ system in the back. I urge everybody to go put the helmet on or put the glasses on and see this stuff. You've all seen augmented reality, but I think it's kind of taking it to a new level. So here we go.
All right. Yes, hi. Thanks for having me today. I'm happy to be here and present some of the great innovations that I've been able to do with Brain Lab. Let me get my slides to show up here in 1 second and share that. All right, hopefully we're all able to see that okay. Yep.
Yeah.
And everyone can hear me okay? All right, thank you. So I'm joining you guys today from Houston, practice here in the greater Houston area with the Mission Neuroscience Associates and at Memorial Hermann Southwest Hospital. As part of our disclosures, I'm one of the consultants for Brain Lab, and kind of the story that we're telling here is a little bit how we developed a true, what we call a robotic suite. So the hospital back in 2020 didn't have any navigation, was deciding. Yes.
We're looking at the presenter view. Could you swap your screens? The top left-hand corner, yep, or in the middle one, display screens, hit the caret on the right. There you go. Perfect.
Yeah, sorry about that. Thank you.
That's okay. Thanks.
Yeah, so in 2020, the decision was made to go forward with, first getting a navigation system. But at that time, there was an idea of what if, robotics started to become a word that was thrown around a lot, in the concept of developing a robotic suite. There was some potential there in terms of ROI, in terms of marketing. The main thing was trying to figure out if we were going to go mainstream with things that are already established or try to something new, something that could be multi-purpose, multidisciplined, and allow us to innovate as well. The key things that we wanted to be agnostic to instrumentation, so we could use any type of implant as far as hardware, and also agnostic to the type of tools we're using, meaning we could use a Midas Rex drill or a Stryker drill or anything, any microscope, a Lycoscope, a Zyscope, and we wanted to just be able to navigate and kind of innovate with any device that was already in our accoutrement. And we also needed to be mobile, able to go into multiple rooms and to be able to be used with multiple beds. So at that time in development was the kind of the suite of things you see presented here, the Loop X, the Circ, and the software that accompanies it with the Curve navigation system. Now the Curve system is used for cranial applications for our standard stereotactic guided resections of tumors or lit and such. But in building a hybrid robotic suite, we were kind of following the precedent of what's been done with our open endovascular suites, with our IMRI suites. We wanted a spinal robotic suite that would be very efficient,
that the staff could become very familiar with, be reproducible, and be mobile into different settings, different rooms. So software, I won't belabor the point. Lots of groups today have presented software, and it's always getting better. I think the pre-planning ability of the software is key. In clinic, we have our screens up. We show patients exactly what their hardware is going to look like on their preoperative images and CTs, and then the ability to auto register once you do the intraoperative scan allows us to merge the preoperative plan scan with the intraoperative scan and look for subtle changes, which is especially important in our prone lateral and lateral cases. I think having the ability to plan everything ahead of time rather than having to plan in the OR allows you to kind of account for some changes and also to think about things like where the array can go, where collisions can happen, and be proactive about anticipating things so things go smoothly in the OR. Again, the software is getting smarter by the year and by the iterations with auto segmentation, auto labeling, auto measurements, but those all come with nuances. And as surgeons, we are responsible for detecting the variances and adjusting and accommodating for those things, especially in the spine oncology world when performing separation surgeries. It's very useful to be able to merge the MRIs and the CTs, create models, and develop that. The navigation platform itself, the curve, again, we use for both cranial and spinal navigation, so it can be used across disciplines. I'm sure everyone's very familiar with it, so I won't belabor the point on the curve. Microscope integration has been around for a while, but again, it's continuing to improve. The thing we're really here today to talk about is robotics, and I would say the LoopX is actually a robotic imaging system. It has the ability with its large gantry to come into the room on its own. There's not a tech pushing this thing around. It will drive into the room with the panel. It can allow us to do some off-center imaging. It can memorize positions, different views that we need, and store those positions, recall those positions, along with recalling bed heights. And it's not fully autonomous at this point, but I think that's the direction it's going. The newest iteration of the Loop actually has its own camera on it to help it become more autonomous, more like a Tesla, if you will. And so that it helps just seamlessly in the room. When you have sometimes turnover in X-ray technicians that are using these devices, these actually start to kind of know more and are more helpful, and the surgeon can actually integrate easier with the machine itself to help with optimizing and streamlining the imaging process. The CIRC, which is the true robotic arm, is I think a really efficient tool. It's steady, which is, the key thing is that's moving us into robotics is with percutaneous placement or open placement of screws, is we need something that will be very steady once we've identified our landmark of where the screw is going to go. So steady, in fact, that we've used it to do C2 pars pedicle screws, DEN screws, and it's very accurate in its placement of S2II screws. It's small, it's ergonomic, so we're able to get in weird angles to place those sacral screws, and it's implant naive. So we can use whatever instrumentation we need based on what the surgeon needs and what the case calls for. And interestingly, it allows us to improvise. It allows us to do things in semi-open manners where we keep some portion of the back closed, the fascia intact, some part of the fascia open, and so we can put screws in percutaneously and open. In prone lateral cases now, we are actually trying to get our lateral dilators in using the CIRC to help with alignment and to get us directly into the disc space and playing around with that as well. So I'll show you some real world things here in just a second, but ultimately the robotic suite is the combination of the CIRC, the LoopX, and the navigation system. So in 2022, we had the first robotic suite in the US, and we're able to deploy all three of these tools in an OR setting to allow us to push the boundaries on that. So here's kind of our real world now. How we set it up with 3 HD monitors in the room so that everyone's looking at what's going on both on the operative field and from the navigation standpoint. We have the LoopX, the CIRC, our diving board table with radiolucent head frame, and the curve system set up with the camera. So the way the room flows is that we have the patient here, heads towards the door, feet towards anesthesia, the diving board setup, navigated scope, the loop that can drive into the room, do your imaging, and then leave or park itself by the wall once the scan's required. It's then auto-registered and merged into the preoperatively planned scans, and so we have all the different devices ready to go. So again, the types of cases that we're doing, spine and cranial, but from a robotic standpoint, what we're able to do is, and I'll give you some examples of some standard cases, a standard TLIF or degen case. The preoperative planned screws are then loaded into the system intraoperatively. We merge those with our new spin and new scans, and we're able to then move forward in a timely fashion. I know that y'all have been here for a long time, so I want to get to some of the real world examples. So here's a pathological fracture from a multiple myeloma patient that we were addressing. And so when the planning portion of the case starts, let me see if this video will play here 1 second. All right. Right. Like I was saying, the 3D planning portion of the case is done preoperatively. It's a good tool that we use when working with our residents, and also when educating patients about what we're planning to do in terms of giving them some insight into what the actual process of the surgery is going to be like. The software does predict, as you can see, what the screws may look like and where they may go, but the final touches are done by us. So once we've planned these screws out and decided on it, then we move into the OR and we're actually doing the surgery. The scan that's acquired is then merged. But this part of the software allows us to really think about in bigger constructs where heads will align, where we could run into problems with the orientation when we're looking at angles and balance and all the other things that come along with doing larger constructs. For other pictures. Again, the loop here coming in to proceed with acquiring the image, then us being able to use incision planning, which is a tool that aligns a laser directly on the patient's skin so that we can minimize taking extra shots to kind of mark out our incision and our plan of where things are going to go. Sorry. System's lagging just a second. So the picture that was there before was our use of staples for fiducial mapping and things of that nature. But again, not clicking, but okay. Again, here, more of some kind of ideas of the workflow of when we get to, so we've marked out the incision, we go ahead and drape, we then come in with our navigation system, acquire our intraoperative scan. You can see there the circ that's laid off to the side. That is then going to be integrated later into the screw portion of the case. But so workflow and design of the room and are all key things in this process. And so being able to optimize that is really where reproducibility comes into play, because there's so many different people that are involved in the whole process of these cases, and those people turn over and change. So everything that we can control and standardize helps make sure that the surgeon's day goes smoothly. So here's one of our residents just kind of ensuring accuracy with the pre-planned screws, and then we proceed from that point with the cases as standard. Forward here, and here he's using the circ for placement of those pedicle screws, and it's a very good tool for them to use to first in their mind's eye and using navigation, understand where it's going to go, but then in real time also have the nav there to help them as well. All right. So the one benefit of this system we found is that it's agnostic to tools. So we're navigating a lot of different instruments now, navigating cobs, dilators for retractors, various drills, drivers, taps. So this allows us to kind of innovate. So here I'm using in the prone lateral case as a cob instrument. And so you can see here how we're able to navigate a dilator to the area of interest on the bottom left corner, pass that K-wire into the area of interest, verify with an X-ray that it is where it needs to be, or navigate a Cobb instrument across the disc space and performing this thoracic corpectomy. What we're working on now is that bottom left panel where I'm using my hand to get the dilator there is to get the circ to do that move. And that's going to be robotically assisted lateral placement of dilators in those cases. But the navigated tools in these prone lateral cases are awesome. It really gives us a lot of confidence in proceeding forward with these corpectomies. We're always using X-ray to confirm. I think that's never going to go away. But I do think a lot less shots are taken in placement of the dilator. A lot less shots are taken when passing instruments across the disc base and performing these procedures. We're able to move forward with that. So this is not a talk about prone lateral cases, but navigation does allow us as two surgeons to work simultaneously, one person working on the corpectomy side, one person putting in the screws, all navigated. These low profile systems that are mobile allow you to do that efficiently. So two people can be working with various navigated instruments with less retractor time placement and be more confident with the resection. And so some of our films from that example case. So again, with placement of difficult screws and weird angles, S2AI screws and such, the robotic system is very helpful in making sure that it docks appropriately in the right place, that it holds firm in the right place, and allows for accurate placement with these very large screws that can sometimes skive or jump off the joint. So that's very helpful in those types of constructs and big cases. So kind of a variety of different cases that we've all done using the robotic system, the robotic suite now. I think it's a very effective tool for these larger cases and even for smaller things too. For posterior cervical foraminotomies even, we've used the robot to help us dock in the correct position and then just put the tubular retractor down and perform a small case like that, but it's still technically robotic guided or robotic assisted. I'll leave, and it has cranial application as well. So in our retro SIGs or in places where you have a hard time doing registration, this will allow you to acquire your images with the CT scan, merge with your preoperative scan automatically, and then you don't have to worry about crawling under the bed with a pointer and doing registration in that manner. So auto registration feature is very helpful in cases where the positioning would make standard registration difficult and where accuracy is very important. So it's kind of examples of how we're, the cranial application of this software is still, for most of us, a good at least 30 to 40% of what we do as well, in addition to spine. So thank you guys. As they said, in the lab, the Brain Lab team, I believe, has their planning software, their navigation software, their mixed reality, the circ, all in the lab to check out and test out today.
Krish, thank you very much. Can you hear me? That's a great.
I got you.
And then Brain Lab's always pushing envelopes, and I love some of these things. So you have any questions? If not, we're going to keep moving ahead. Anybody out there? Okay. Thanks again, Krish. Terry Kim is going to team up with Ken Metcalf and talk about the VELOS spine robot. Thanks. Thanks, TK.
All right, last talk, guys, right? Last talk, Daniel?
Last talk.
Can everyone see my screen? So today I'll be talking about our next generation robotics. We've been kind of building up to this. There's a lot of cool technology that's coming through, but this is something that's currently happening now. The next generation robots are here, and Johnson & Johnson is certainly leading that charge with their VELOS robot. These are my disclosures. Going through always the history of it, this talk about next generation robotics is not a contradistinction or diss on the robots that are currently here. They all have done extremely well. They've paved the way for the additional next generational stuff that we want to do as spine surgeons, but just as an homage to guys like Pat Johnson, who were around in 2004 with the Spine Assist, all the way to the Renaissance, the Mazor X with the Stealth Edition, Globus Excelsis and Celsius, and the Circ, which we just heard about. So at Cedars, we definitely have had a robust experience in using the robot, and whether it's MIS, deformity, or degenerative, it's definitely not going away. All places of the spine, you've seen it, the robot being used today, trauma, tumor, single positions. The one thing I haven't heard today is where to use robots for arthroplasty. But
Actually, your buddy, Dr. Perry.
Sure. But ultimately, the reason being there's copious amounts of data to support its use, which I'm not going to belabor. But the question is, what is next? What are we looking for that's reasonable, not robots that can watch your kids or do vacuuming. You're looking for, first of all, a robot that, again, is approachable. We all live in our ivory towers at our academic centers, but you want robots where the novice to the expert surgeon can come in and immediately utilize. You want faster robots. If you've seen today, these robots that are coming in, it's a very slow, kind of deliberate movement, very not easy to move out of the way if you want it to be in a different place. They're very static, so they kind of hold one position. You're certainly always looking for better accuracy and anything on the margins that might help the surgeon to stay accurate. And now what I'm talking about is, and what I've been harping about all day, is dynamic tracking. Any robot that can assist the surgeon in doing what they want to do instead of the surgeon trying to compete against the robot to get the proper job done. And so essentially what's called an intelligent arm. You're looking for easier user interfaces, quicker workflows, and these are just some of the attainable wish lists that I've been looking for the next generation. And so J&J came out with their new VELYS robot, which is commercially available. It's FDA approved. It was FDA approved in June of 2024, launched several months later, and Dr. Ross tells me that they are one of the first centers to purchase and use, so we'll be looking forward to her experience next year. It's the first active assist robotic platform. So in other words, it is not static, and it constantly moves and works with the surgeon to get the job done. This robotic arm is 7 joints. It's made in Germany by a company named KUKA, designed in France, finished and completed in the United States. It's the same company that makes those Tesla robotic arms. So a lot of those early robotic presentations that showed the Tesla robot working on the Tesla cars coming through. And when you realize that the first generation robots weren't really like that, it's the same company that makes those arms. The current VELYS robot is their first medical grade LBR KUKA robotic arm. So a lot of technology from other industries built into this robot. So this is a true kind of commercial robotic arm that we're pulling into the OR through J&J. And ultimately, the idea is that it's an active assist robot. It's the future. I think all the next generation robots will follow in this step. And what active robotic technology really means is 4 main pillars. Manual manipulation, so the robot has to be smooth, fast, get out of the surgeon's way. It has to be able to help the surgeon with trajectory assistance. It has to have adaptive tracking, meaning that it can move around the patient and sense changes without the surgeon having to press a pedal. And the screw release mode, which we'll get into in detail. But a lot of these highlights, I think, separate the VELYS robot from all the current ones. Because all the current arms are static or set trajectories. So you decide where the robot goes and it just stays there. And that's not what what we want to see. We want to see robotic arms that can adapt. So in this kind of video, and by the way, we'll virtual feed to Raynham, Massachusetts to actually show you the robot arm after my talk. So I won't speak too much longer, but the VELYS arm, when you move, let's say the robotic arm goes into the surgical field. You don't like it, the elbow's in the way, that's not exactly where you want it positioned. The surgeon can actually move it out of the way, and instead of old robots that kind of find the same trajectory back to its obstructed position, it will literally calculate a new way, a new algorithm, or through its algorithm, a new pathway, and say, okay, you didn't want my elbow in this way. We're going to try to get the trajectory from a different perspective. And that subtle kind of change in the way the arm moves and thinks helps to find ideal positions and to, again, assist the surgeon. From an adaptive tracking standpoint, this is, you'll see this better in the virtual, or in the model, or in the Raynham lab today. If the patient moves, the robot moves. So any kind of, with the reference frame attached to the patient, as you can see, if the anesthesiologist accidentally adjusts the patient, accidentally pushes the buttons, or the patient actually moves, the robotic arm tracks that sense. So if the patient moves, the VELYS arm adjusts to a new position. It actively tracks the patient reference frame in all planes real time. So you're not, again, the Globus robot also kind of does this, but you have to push the button. If you don't notice that there's a shift in the patient, the robotic arm does not necessarily, you have to push the pedal in order to recognize that. But if the patient moves, in the words of Ludacris, the robot arm will move as well. From a trajectory, now this is a big one. From a trajectory assistance, the VELYS arm actively holds trajectory. It is the answer for skive, for patient soft tissue pressure, and instrument weights. If you've ever used any of the robotic implants, sometimes you lean a lot because the instruments are wired or the battery is heavy, and that leads to a lot of inaccurate trajectories. What this video doesn't show well, but what's going on when you actually use it is it's holding your position. And if you lean hard on the lateral side, the robot is actively giving a medial trajectory or a medial pull to keep you in line. And so that idea that there's a skive or there's a lot of soft tissue for those open procedures, the high thoracic screws with the soft tissues in the way, the robotic arm, hopefully, on cue, there's the audio. The robotic arm will counterbalance or counteract that. And the common metaphor is the Tesla lane assist, in that when you're on an automatic trajectory with your Tesla, if you're starting to veer out of plane or you're starting to get into the outsides of the margin, the car will gently give you a nudge back into the center. And that's what the robotic arm does, is it keeps you accurate. And this is a pretty big game changer in terms of active movement. This screw release mode, if you do a lot of robotic trajectories or robotic screws, what you notice is that as the screw goes deeper and deeper, sometimes it catches in the bone, but the robot is static. And so it will actually tweak the spine as you're inserting the screw and will create some kind of problem. Or the screw will get lodged into the human with the robotic arm holding it in place, and it's hard to pull everything out. There was one episode where I yanked it so hard that the robotic arm disengaged and we had to respin. So what is interesting about the VELYS robot, and this is something that they've thought about a lot, is as the screw is going down about 80% of the way, It relaxes and it gives the surgeon that tactile feel that Kirsten wants and Pat Johnson wants, that tactile feel that the screw is going down the way you want it. And so that's kind of new because it allows the surgeon to avoid being in the wrong trajectory, being pulled or pushed in the wrong way. And I think that's kind of very intuitive and nice. From a UI standpoint, Naveed and Michael and Raynham will go over this, but their UI, their user interface, is extremely friendly. It's very graphically oriented, and one thing about the UI is that from any point on one screen, you can go back to the initial registration to the final screw delivery. It's all on one screen. A lot of the systems require numerous amount of clicks. The robotic tech is feverishly using the mouse to get through the process. This is a very intuitive, the screen is nice, and everything lines up exactly that you want. And again, something that's approachable from both novice and advanced. Click efficiency, go to any step from one page, a fast, responsive touchscreen. The other problem we've seen with our robotic instruments is they tend to bend. All the frames over time, as they're being used over and over again, they wear. And by wearing, they lose their accuracy. And there are certain instruments, in particular the chicken foot, that tends to potentially be a problem. And so what J&J has come to market with are these disposable reference frames that are lightweight. They're extremely precise, and they're disposable. So they're one use. They really are cost effective when you talk about how they leverage the J&J company with plastics and molding. They're able to get accuracy through reference arrays that are readily used. And at the end of the day, in addition to these four things, the idea is that VELYS Spine is here. You'll be seeing it more and more. Hopefully next year, we'll have this in demo. The arm, I've been there to Raynham. We at Cedars do not have the robot, so I don't really have a conflict of interest in terms of that. But they really have created the next generation robot. So here we go, sending it to across the country to Raynham at the lab at J&J MedTech. Who is that? Mike?
Mike, hey, can you hear me?
Mike, can you hear me? Yes.
I can. Can you hear me?
If you can just speak up so we can all hear you well.
Can you hear me? Am I on?
Yes, we can hear you.
They can hear me. Okay. Hey, it's good to see you. You look good on camera.
So do you, Mike.
I appreciate it. Well, thanks, Dr. Kim. Yeah, great introduction. I mean, you really stole a lot of the thunder we were going to go through here, but we are going to spend a little bit of time talking about the hardware. We could keep it super high level, just give a bit of a live demonstration about how all this works. One of the things that I thought was really cool throughout the day is all the advancement in robotics. It's awesome to see Medtronic and Globus and now Stryker with all their robots, such fantastic companies, such fantastic opportunity to innovate and really see what everybody else is doing. One of the things I think is a little bit different about us is, at J&J, we have to be everything to everyone all the time, right? And so a lot of the cool advancements we're seeing are really for those early innovators, those early adopter types, the bone cutting, the osteotomies, the AR, VR. But as Dr. Kim had mentioned, we have to kind of focus on bringing technology to that fatter part of the bell curve, to the everyday surgeon. So how do we create technology, robotics in this instance, that could be used in New York City, shipped to Uganda, and then used the next day as well, right? And so our whole thesis around designing the VELYS Spine platform was to make it easy, adaptable, and shouldn't really have to choose between robotics and navigation when executing on a surgical plan, okay? So a lot of what's been built into the hardware is to make robotics, again, a little bit more forgiving, a little bit more in line with how navigation works, and again, an easy procedure for the everyday surgeon to adopt, and really not as focused on those cutting-edge surgeons, but again, the everyday surgeon that just wants to do a couple cases and get out to their kid's soccer practice, right? So we've already done our surgical plan. Again, not going to spend too much time on the planning. It's very basic. We focus on screws, rods, skin incisions, okay? And again, that's already been done here, right? But when we move forward into the surgical plan or the surgical execution component, right? I have a foot pedal. I'm going to send our robot to the first trajectory, right? Now, again, I think at first glance, you're going to notice a couple different things. First off, the robot, well, it looks like a robot, so that's a good start for us. I think secondarily, though, one thing for me, it takes a little bit of time to get to that first location, okay? Now, one of the things we hear from surgeons all the time is this idea that they feel a little bit constrained around robotics as they exist today. If you'll notice in this particular position, I don't ergonomically have great access, right? I have to work around the technology. It's not super forgiving in terms of my ability to operate and have great access in this particular setting, okay? But what makes an active robot very different, as Dr. Kim had mentioned, is this idea of manual manipulation, right? So what I can also do is I can completely adjust the ergonomics of this robot, right? I can get the elbow completely out of my way, okay? And now I have full access. I can recenter that initial trajectory, right? And now I don't run into any problems, okay? So now for a lumbar procedure, that's probably not going to change your life too much. But when you think about the lateral applications, the upper cervical, the pediatric applications, right? Those angles and the ability for this arm to really move in any which position is fairly favorable and allows a lot of great opportunity to apply these types of technologies to those new procedures that really aren't seen in robotics today, okay? Now, one thing that we also want to talk about that's fairly important is this idea of a problem of stereotaxy with patient movement, okay? As my robot gets into position here, right, one of the things that we notice today with robotics is although they're all fantastic, okay, we are still in the stage of just static, rigid drill guides, right? So when I have a static arm and I want to retract a little bit, right, or the patient moves or something changes, right, or I'm in a flexible spine, that robot is going to stay in a static state, okay? With an active arm or active robotics, again, we have a bit of a different flavor, okay? So as I do a retraction, right, you'll notice the arm's going to move right along with the patient, right? If the patient's breathing, you're going to notice the arm move right along with the spine. Now, I don't have to go in and change my trajectory, read register. I really have a good opportunity, and you can see on camera here, that robot arm moving right along as everything is adjusting, okay? So this is all happening in real time. Now, this is important because if I'm doing a traditional navigated case, I have an opportunity to really dock my tool down. I can probably retract or make those adjustments in real time. A robot, I don't get that flexibility. But the forgiveness of this active technology, again, I can dock my tools, I can retract. This is going to be able to move right along with me, right, in real time. So again, from a cognitive load perspective, I don't have to constantly be checking, have things changed, have things moved. It's just that little advancement that really makes this advantageous, particularly for those tougher procedures, right? One of the other things that we had talked about, this is the idea of trajectory assistance. Again, a little bit tougher to do if you're not going in traditional bone, but as I place my instrument, right, and again, I'm starting to make these fine adjustments and push on the spine, the robot's not going to allow me to come off track, okay? So again, if I'm really putting a lot of force on the spine or having major issues, the technology isn't going to allow me to come off my planned Z-plane, and I'm able to really execute without any issue. And then finally, right, I'm going to take a screw off and do a little bit of a phantom demo here. You want to focus on the main screen. We talked about that idea of trajectory or screw release mode, okay? So, you know, there's a phenomena that robots have really introduced where when you start to place that final screw and that final tightening, the anatomy is going to shift just a little bit probably towards you, okay? And it's just because of the torque that's being applied to the bone. What that does is it creates a force between the screw head and the driver, which then creates a force multiplier up into the robot, which creates a bit of a cold welding. So if you've used a robot and you've had to kind of add that into your workflow, if I got to take the end effector off and work around it, you're not the only one. We learned this in our verification validation labs that this is a problem, and it was actually something we were able to solve through an algorithm. So our software, and you'll see, when a screw gets about 80% of the way down the pedicle, the arm's smart enough to sort of let out a sigh of relief. It'll actually adjust, and it'll no longer be fighting me or auto-correcting me, and it's going to allow an easy transition to release the screw. So just a quick little demonstration here of how that works, right? And you'll see it come on screen. Screw release mode kicks in. You notice the arm will sort of move a little bit and release itself, right? I'm able to easily release my screw. So some of the basics of active robotics. Really, really excited about this technology, excited about our early partners. We'd hope that every robot in the future categorically is an active robot. We really think that this makes this type of procedure easier for the masses to adopt because of its forgiveness. That being said, that's the end of our quick little demonstration here. Dr. Kim, appreciate you participating with us here, and we'll open it up to any questions.
Ken Metcalf, you're here as well. Did you have anything you wanted to say, or?
You stole my thunder. I'm good. Mike, great job. And I also wanted to echo what Mike said earlier. It's been fascinating sitting here and listening to all the other companies and the technologies out there. What an exciting time to be in spine. So thanks to everybody.
Yep, can't wait to, as I said, can't wait to see this deployed more and more. I think you guys have the right stuff. You're thinking about the right things, which is surgeon-directed problems instead of engineer-contrived issues that they hypothetically come up with. And if any of the participants virtually or in present are interested, please reach out to Ken so that you can see it. And J&J, come back next year and showcase your robot to us.
We'd absolutely love to. I appreciate you guys inviting us.
Thank you. Danielle?
That's it.
Where are we now? We're going to close it?
That's it. We're going to close it up. Well, it's 5 to 3. We've kept everyone here long enough. Just want to appreciate everyone who showed up, all the companies, all the faculty, Dr. Johnson, Dr. Kim, Dr. Ross. Safe travels, everybody. And
Mexico City physician.
A Mexico City physician, yes. And this was the 9th annual, so just appreciate you taking your Saturday to learn some new technology with us.
Okay, and Dr. Kim, come on over here so everybody around the world can recognize us, but stay tuned for next year. Okay, this is 9 years running, and I think we're going to have a 10th anniversary that we're going to try and top all the previous 9. So
all right,
it's going to be exciting.
Thanks, everybody.
Thank you, everybody.